Ma'am, we are live now.
Good morning, all of you delegates and speakers and friends out there in the audience and also in this faculty lounge. We've had an outstanding day yesterday with the best of speakers speaking on unraveling the Pandora's box. And we know that the Pandora's box have all the differences that in the pathophysiology presentation and also in the management of type 2 diabetes in women. And we are doing just that even today. And let me tell you that we have another marvelous speaker, marvelous, outstanding faculty today as well. And I know that these deliberations will go well. All of you are in time and just hopefully the day will be good. So let us begin the day, and to start the session, I invite Dr. Ami to start the first session.
Thank you, ma'am. A very good morning to everyone present today. After a studied and a day of learning and academics yesterday, we are back today with an equally interesting day full of science at its best, with a galaxy of stars, as learning is an ever-evolving process. So to begin with the day for the first session on first strike, I invite my co-chairs, Dr. Alpana Sovani and Dr. Alka Gandhi, both consultant diabetologists from Mumbai, to start with the first session. I request Dr. Alpana to kindly introduce the first speaker of the day, Dr. Shaila Sheikh.
Thank you, Ami. A very warm welcome to all of us here. And it's my pleasure to introduce Dr. Shaila Sheikh. She's a consultant endocrinologist at Prince Ali Khan Hospital, Saifi Hospital, and Wodcon Hospital, Mumbai. She has been a principal investigator at multiple trials, has been awarded the top doctor Mumbai by the Times of India group from 2017 to 2020. She has many published papers and review articles and is a speaker at national and international forums. She is also a member of the executive committee of the ESI Diabetes India. A very warm welcome to you, Shaila. Looking forward to your talk.
Thank you very much. Thank you. First of all, it's always a pleasure being at this Wodcon meeting. We all know we share some not only fantastic science, but some fantastic moments with each other also. And I think that always adds to the fervor on, and to be very honest, I love all the guys in my life, but I always love the flavor of sisterhood that we share over here. So thanks for inviting me over here. Thanks for making me a part of this meeting. It's a pleasure being over here. Today, we are exactly 14 days away from Ramadan. To be very honest, it's exactly 14 days that our patients would be fasting. The issue now for us at all points of time are that how do we manage Ramadan? Do we allow our patients to fast? Do we not allow them to fast? What do we actually do during Ramadan? Is my screen in slideshow?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
And increasingly, when I remember a decade back, we all used to do what we thought was right for our patients. We were working by, I would say, our understanding about how to go forward. We were trying to do what it was always to be on the best of days. I still remember we used to be having these perpetual arguments with our patients that no, you just cannot fast. 10 years back, I used to tell my patients, you cannot fast, period. I do not want arguments about that. My patients with an equally burgeoned expression on their face would say, hello, I am going to fast. And then it was like almost like, okay, like you're on the opposite sides of the table and you're just wondering how to sort this entire issue out. We have moved a long way from there. Believe me, a long way. The reason I'm saying we've moved a long way because now we are at a point of time where, yes, we are having conversations which are much more fruitful with our patients. We are educating our patients before Ramadan. We now have medication available to us, which does help our patients fast safely during Ramadan without too many of the complications that we conventionally associate with Ramadan. And we now, as a group, have more guidelines for us to understand how to manage diabetes better in Ramadan. The issue is, do we really apply those guidelines also Those are some of the issues that we have as far as management of our patients are concerned. So some of the questions that we always have at this point of time is, do we fast? Do we not allow our patients to fast? What is the risk? Is it going to be very risky? Is it okay if my patient fasts? You're allowed to fast. You also have the other end of the spectrum where some of my patients tell me, no, ma'am, I think it's not safe for me to fast. Do you really think it's safe for me to fast? And when you tell them, yes, it's safe for you to fast, then that expression, can't you just tell me it's not safe for me to fast? Because then, okay, I am really allowed not to fast. How do you assess these patients? Are there some guidelines as to how do we assess our patients when they decide to fast during Ramadan? And of course, the multi-million-dollar question, if your patient does decide that I am going to fast, what do you really do about it? So when you look at the entire Ramadan as a month, one thing which I want to put across to this audience, you'd always wonder why your patients have these arguments with you prior to Ramadan. It's because Ramadan is a very, very important spiritual as well as social event. Practically, if be very honest with all of you, if we are not fasting and women are exempted from fasting when they're menstruating, this would come as a shocker to most of you all, but as women do get up in the morning, have suhoor with the rest of the family, and finally have iftar with the rest of the family, because it is very, very difficult. I would not say difficult, especially if you are even outside the house. People frown if you actually eat something during Ramadan. We do not face it so much in our country still, but yes, in the other countries, you do face a lot of dogma and stigma if you eat even during the non-fasting hours. So most of the patients, during the fasting hours. So most of the patients actually, even if they are not actually fasting by convention and we may be having water, those patients would not be actually having a significant meal during the fasting hours. Because fasting involves, you cannot eat food, you cannot drink water, you cannot have any oral medications. Fasting permits you to take injectables if required, as long as it doesn't give nutrition. Again, there will be certain points which I'll be bringing out across over here, because there's often a lot of confusion about fasting also, which starts from simple things like pricking. But we need to understand that the only thing which is not allowed during fasting is through the mouth, things which give nutrition to the body. Other than that, you can do whatever is required. There is no reason why you cannot do it when you are fasting, because the most important thing is that the Quran says that fasting is not for hardship. It is not intended to create hardship. You are exempt from fasting if you are sick. You are exempt from fasting when you're pregnant. You're exempt from fasting when you're traveling. But as I said, it's not only a spiritual occasion, it's a social occasion. And because it's a social occasion, because it's an entire family, it's an entire community which is fasting together, there is a lot of other pressure on the patient. And that's the reason the patients will insist that, no, I need to fast. I want to fast. Fasting actually is started by convention. It is compulsory after puberty. But most of the Muslim children will start fasting by the time they are 4 or 5 years of age. Even children as young as 4 and 5 years of age do fast. And the first fast of the child is actually an occasion which is celebrated with great fervor in families. So, we need to understand the social implications of this month. It is actually, when we talk about Ramadan, it is not a month. We don't say, okay, Ramadan is a month. We say, oh, Ramadan is coming. Oh, Ramadan Mubarak. The reason Ramadan Mubarak is said because it is a month which is associated with a lot of blessings. And everybody who doesn't fast feels, oh my God, am I not being blessed enough? Am I just not doing what I'm supposed to do? And if we as clinicians understand this, I think it makes our job much more easier. I think as a clinician, it is very important. Now, when I have a conversation and we have learned, we have grown. Now, when I have a conversation, my first sentence would be, I want you to fast. Now, let me understand how I can allow you to fast. The patient is on my side of the table then. The moment my question is, are you going to fast? The patient is on the opposite side of the table, because the patient feels that I am not actually interested in making my patient and allowing my patient or helping my patient fast. And that itself leads to a significant amount of conflict. The majority of patients do fast every day during Ramadan. We have been studying what kind of trends we are seeing as far as patients are concerned. Last year, we did have an IDF poster where we published about what patients actually do during Ramadan. This year, we are again studying that, and what we are realizing is that with education, this graph could change. With education, patients who are in the high risk are now more willing not to fast because they understand there's a certain risk. But yes, as of now, the data shows that a significant number of patients are going to fast every day. Almost 67.6% patients fast, almost 67.6% patients do fast every day, and 32% patients fast for more than 15 days. And when you are talking to the patients, we need to also understand from them how often they need to fast, because the last 10 days of Ramadan are supposed to be the most important when most of your patients fast. When you talk to them about fasting, please don't forget to ask them about feasting, because feasting is something which is also contributing to a significant extent to the complications that we see in our patients, for example, hyperglycemia. Because hyperglycemia, mind you, friends, is a very, very often ignored problem during Ramadan. Hypoglycemia has been a problem which has been addressed, which has been looked at, medications adjusted. Our entire focus is always towards hypoglycemia, because agree, it can be life-threatening. Agree that your patient needs to be educated that you have to break your fast if you have hypoglycemia. But hyperglycemia can also contribute to a significant extent to the glycemic variability. And the feasting which takes place during Ramadan iftar is something which is actually mind-boggling. And we need to understand that we also need to educate our patients that that feasting, which is occurring during the iftar periods, actually negates to a significant extent all the physical benefits that potentially you could accrue from Ramadan, considering that it is actually a prototype of intermittent fasting. And because of the feasting, you do not see all the other benefits that you see of intermittent fasting that you would see with a month of intermittent fasting, which is done with so much of rigor. This year, again, we have Ramadan in a hot month. It is in Mumbai. We all know it has become very, very hot. So we will need to emphasize and re-emphasize to our patients that you have to be very careful about dehydration, and you need to consume water in your non-fasting hours as much as possible. We tell all our patients to keep a separate bottle of water. And the reason we tell them to keep a separate bottle of water because it helps the patient quantify better how much water they are drinking, how much fluids they are drinking. And we try to tell them to avoid all kinds of high calorie liquids as much as possible, because this year Ramadan is going to be 15 hours of a significantly hot Ramadan, especially in our city. You will often hear a number of our patients telling us, ma'am, it's not the fasting which really gets to me, it's the lack of sleep. Patients get up, mind you, at 4 a.m. in the morning to do their suhoor. The ladies in the house, unless you have a house where the men are actually cooking, but most of the time it is the ladies in the house who are getting up at least 45 minutes to 1 hour before to have everything ready for suhoor. If they have a family, they have to look after. Sleeping patterns really are affected significantly during Ramadan, because you're practically getting up at 3:30. After you finished your suhoor, the morning prayers which are said almost 20 minutes later down the line. So you are actually awake, friends, from 3:30 to almost 5 a.m. in the morning. You would wonder why I am telling you all this, because unless we understand this, we would not be able to treat our patients with the empathy that they require. These patients would then stay away. When we are all working our routine hours, these patients would most probably getting up again at 7 or 7:30 to send their children to school or to college, or children have slept for that much time and are going to school and college fasting. And working, of course, parents are again going and doing whatever their routine work is. So you have a decreased sleep time, you have a delayed sleep. And mind you, in the night, again, most of the families during Ramadan would not be sleeping before 11 and 12 a.m. for the simple reason that the Taraweeh prayers which are done, which is a prayer which involves almost 45 minutes of praying, is generally conducted between 9 to 10. So by the time people have actually slept, it's going to be 11:30, 12. We hope that we're able to come up with better data this year as to sleep patterns. But yes, this is what is happening, where they have decreased total sleep time, decreased sleep period time, decreased REM sleep duration, decreased proportion of REM sleep, and all this is finally going to affect their sugars at some point or the other. As I said, this is what the kind of glycemic variability you see. The red graph is the graph of the fasting patient, and you would see this typical upsurge which happens just post iftar because of all the high calorie food that is consumed universally all over the world. And this is a universal phenomenon. It has nothing to do with our country. This is something that is seen universally. As far as hypoglycemia is concerned, as I said, yes, there is an increased incidence of hypoglycemia, a number of studies which show that a significant increase of hypoglycemia, but I'm sure these numbers have improved now because we are now managing our patients with better medication. The issue then remains, how do we actually manage our patients? The Crete study found that 1/3 of us actually do not see any published Ramadan guidelines or recommendations and still feel that it is good enough if we are treating our patients according to our experience, which may be very good. I am not questioning that at all. What I am suggesting is that we use our guidelines to help us manage our patients better, because we all as a group know that when you are talking about guidelines, they are only meant to help you. Finally, these are going to be individual decisions as to how best you would manage your patients, because guidelines are not going to be able to cover each and every situation that you see in your patient in a busy clinic OPD. Ramadan patients, I mean, we have, believe it or not, see patients at 12 a.m. one night prior to Ramadan, at 1 a.m. one night prior to Ramadan, because though we keep on telling our patients, we keep on educating our patients that you need to see us 6 to 8 weeks before Ramadan, we still have not reached a point where we've been able to convince all our patients to do that and assess the risk. Yes, there has been a change. There's no questioning that. A significant change from where we have started, but still we have not seen the day where all our patients come 6 to 8 weeks before Ramadan, which is the ideal period, because that is the time when you would stratify your patient. You would identify the risk that is going to be occurred by the patient due to fasting, and you are going to then plan what your patient requires in the subsequent month. Now, when you are doing risk stratification, there are 2 or 3 things which are very, very important. One is, of course, a detailed history. One is the patient's experience during previous Ramadan. The third is your patient's ability to manage diabetes. And of course, a complete evaluation by you as to what is the risk as far as this patient is concerned. Structured education is going to involve a number of factors, which I will get into a few minutes. And according to that, according to your risk stratification, you are going to be deciding whether you can allow your patient to fast or you do not allow your patient to fast. And then you would have the conversation which is required. Our risk stratification changed last year, friends. I was fortunate to be a part of that risk stratification score. And why did we decide to change that? With a lot of brainstorming, and believe me, there was a lot of brainstorming as to do we really need a change in risk stratification. And what was realized is that our previous risk stratification maybe is a little too rigid. Maybe we are being very dogmatic when we are saying that all our patients who are 70, who are elderly, should not be allowed to fast. We are putting them in high risk rating. When you are putting a patient in high risk rating, it has a certain moral obligation for you, because the religious organizations have now accepted the risk stratification, and the religion also says, no, you should not be fasting. You are at a high risk of fasting. And that, mind you, is an enormous amount of responsibility on the shoulders of the people who are actually writing the risk stratification. So when you are doing anything which has implications for your patient, which is going to have implications for the fasting, then you know that you need to be very, very careful about what you are saying, because it has certain religious implications, which have to be at some point of time answered, if not to others, definitely to yourself. There are certain Ramadan-related factors, certain diabetes-related factors, and certain individual factors which actually decide what kind of risk your patient is going to be having while fasting. And that is where this risk stratification tool comes in place. This is available online, very, very easily available. You can download in practically 1 minute. And though you are doing this in clinical practice, I'm sure everybody listening on to this today is doing this in clinical practice, but it still helps when you have something a little more concrete in front of you. Because when you have something very, very concrete in front of you, you are able to immediately look at it and immediately understand whether you've missed out on some part of it. These are scores given to different factors which we thought are very, very relevant as far as fasting goes. These are all factors. For example, if the patient is having hypoglycemia unawareness, we give it a score of 5. And I'll get to you in a few minutes as to why exactly on what basis this scoring is and how would you interpret this scoring. Again, if self-monitoring of blood glucose is not done, which we believe now is mandatory when you decide to fast, but you would be shocked that 30% of my patients, believe me, data which we are in the process of collecting, 30% of my patients do not have a glucometer, do not plan to buy a glucometer. And they told me very cheekily, ma'am, you've been managing from so many years. Why are you so insistent that I pick up a glucometer this year? So you do have a lot of work still to be done. If you look at some of the, as I said, again, pregnancy, strictly no as far as fasting goes, especially with diabetes, absolutely not allowed. Patients' treatment would decide what kind of influence it would have on their risk of fasting. And that's the reason patients on multiple daily mixed insulin injections have been given the highest score. But mind you, when you look at therapy, as I said, because of the change in therapy, things have become much more easier for us and our patients. And the other therapy, not including SU or insulin, has got a score of 0. That means our DPP-4 inhibitors, our SGLT2 inhibitors, metformin, pioglitazone all go in that score where it is practically 0 risk if those patients decide to fast. So when I'm talking about a risk score, 0 to 3, you would basically mark whatever points are required. For example, if you're talking about a duration of diabetes more than 10 years, if you're saying hypoglycemia less than once time a year, if you're saying this patient is monitoring but not suboptimally, you would then collect this score. For example, this will become 1, 2, 3. And on top of this, if this patient is on insulin, it would become actually 6. And as I've shown you over here, a score of 6 would become moderate to high risk. And this patient then would be at a moderate to high risk for fasting. So if your patient is at low risk of fasting, has accrued a score up from 0 to 3, should be allowed to fast. A score between 3.5 to 6 because should be advised not to fast. But as I said, if the patient insists of fasting, please speak to the patient and try to make it as safe an experience as possible. And who are in the high risk category should not be allowed to fast. I know I'm running out of time. This is a pre-Ramadan education which could focus on 6 key areas, as I said. We've already done the risk quantification. The other area which I really want to concentrate on is the blood glucose monitoring, which I think is very, very important. And we need to understand that our patients need to monitor their sugars. One very important message we give our patients is if you're not willing to monitor, you ideally should not be fasting. A very, very dramatic statement, but it helps in at least 30 to 40% of our patients actually pick up the glucometer and actually start monitoring their patients. The monitoring which is recommended is very, very extensive, but most of our tell our patients that at least monitor twice daily at different points of time, again, similar to the staggered monitoring that we do for our pregnant patients, so that we get some idea at the end of a week as to how you are doing during Ramadan. The nutrition plate, which we all know about. What I am going to be talking over the last 2 minutes, which are left to me, is as far as metformin is concerned, as far as acarbose is concerned, as far as TZDs is concerned, and as far as SGLT2 inhibitors and GLP-1 receptor agonists and DPP-4 inhibitors are concerned, we are fortunate enough to continue the same dose. No dose modification is required, friends. The only thing which I tell our patients if they're on SGLT2 inhibitors is to increase their fluid intake, mandatory. Short-acting insulin secretagogues, I would be careful. I would reduce their dose. I would redistribute the dose. And in any kind of sulfonylurea, I try to avoid giving it to them at source, especially this year because of the long work fasting hours and the significantly hot month. I generally try to adjust my SUs as much as possible at iftar if my patient is well controlled. If my patient at baseline is not well controlled, has a high HbA1c, then yes, we would reduce the dose of SU at Sehri and continue giving the patient at Suhoor. We do not initiate GLP-1 receptor agonists just prior to Ramadan. We are not initiating SEMA at this point of time, but yes, patients who have been on SEMA from the last, say, example, 1.5 months would continue on SEMA and continue on the GLP-1 receptor agonist without any problem. As far as insulin is concerned, we all know that we would reduce the morning dose by 15 to 30%. We continue the morning dose, which we are taking at iftar. And what we all do at all points of time is monitor our patients pre-suhoor and pre-iftar so that you can then adjust their doses. And these dose adjustments are made every 3 or 5 days. The last slide of the day, despite the many risks, as I said, people will fast. So before Ramadan, we need to assess them. During Ramadan, stay connected with them. And after Ramadan, please follow up them and discuss their medication and regimen adjustments so that we can actually see to it that our patients can fast safely and we can offer them a completely hassle-free spiritual experience. Thank you very, very much, and really sorry for overshooting time.
Thank you so much, ma'am, for this wonderful insight on Ramadan, which is coming up soon. I think if we have time, we'll take up questions at the end of the session. We move on to the next talk, and it's my privilege to introduce Dr. Bharat Sabu, who is the Chief Diabetologist and Director at Prayas Diabetes Center in Indore, and he's the organizing chairperson of Asia Diabetes Forum Masterclass in Diabetes 2021 and organizing president of Madhu Prayas Conference. He is a faculty at various international and national conferences with international research publications, and is received the Best Oral Poster in IDF 2021, winner of the RSSDI USV Award, and winner of the upcoming researcher in Diacon 2021, and author of a book. I'm sorry, the chat is taking up. Okay, I invite Dr. Bharat Sabu. His topic for today is structuring exercise for various age groups. Do we need to strictly follow the guidelines? Over to you, sir.
A very warm good morning to all of you. And it's really a little strange for me because I'm the only male on the dais which is visible. And I'm really thankful to Dr. Benny ma'am for considering me for this. I was very happy when she called me up for this, and I was really excited to be the part of the show. I again thank Dr. Shaila ma'am for a wonderful talk. It was really a wonderful talk, and we really loved to listen to it. I again thank my chairpersons and the kind introduction by Ami Ben. So coming to the topic, and I will try to finish it in crisp 15 minutes, structuring exercises for various age groups. So do we need to strictly follow the guidelines? Actually, this is the take from this, actually the talk. So the flow would be introduction, then a brief about why should one exercise, what is the need to exercise. Then we will come to the core agenda, exercise for various age groups. And then the second core agenda, which is with me, do we need to strictly follow the guidelines? And then I will conclude it. So we all know that the levels of physical inactivity are rising globally. And thanks to COVID pandemic, it has increased. Now, it is again known that it is one of the major risk factors for non-communicable diseases. And by physical inactivity, we say inability to achieve the recommended level of physical activity for health, which is optimal. Now, it is described as a pandemic now. We are again dealing with one more pandemic along with diabetes, obesity, CVD, which is physical inactivity. Because only 1 in 4 adults, they fully meet the physical activity guidelines which are there for aerobic and muscle strengthening activities. And this is the data from Garmin, and this is the 2021 average intensity minutes, which tells us then in India, we are really lagging behind most of the countries in terms of exercise. So this is the data source from Garmin, and it is a validated data, which we have, and a very recent one of 2021. Thanks to the COVID pandemic and strict lockdown, they are also contributing to it. Now, coming next to the data from WHO. WHO warns that 80% of our young adolescents who are 11 to 17 years old are not exercising. This is a worrisome figure. India is there with 73.9%, and it is really worrisome for our future generation. The global inactivity, if we talk as a whole, in adult, the most active nation is Uganda. A very surprising data to me also when I searched the literature. And we are at 34% of global inactivity level. So we are not 1 in 4, we are 1 in 3. 1 in 3 is inactive. Now, the data says from the Lancet, 34% don't do enough physical activity. And 44% are female. On this forum, it is surprising to say, but it is the fact that 1 in 2 female are not achieving their optimum physical activity level. In spite of them being saying in our OPD that I do daily course every day, I do all the work in my home, but still they are lagging behind in the activity level. And 25% of men in India were insufficiently active. Now, the inactive people, we all know, are 20 to 30 times more likely, 30%, sorry, more likely at risk of death compared to active individuals. And it is the 4th leading risk factor for global mortality. Now, the inadequate level of physical activity again contributes to the monetary burden to the society. And it is estimated that a $117 billion in annual healthcare cost could be avoided if we become physically active. So why should one exercise? I think we have enough reasons, which I have explained. But we all know that there are 2 types of benefits with exercise. One is immediate and another is long term. A single bout of moderate to vigorous activity even can improve our sleep quality, can reduce our anxiety, and it can even reduce our blood pressure. On a longer run, it can improve our brain health by delaying the Alzheimer's. It improves the heart health. We can prevent a lot of cancers with the help of physical activity. We can achieve a healthy and optimum weight. The bone strength improves and the balance and coordination is maintained. So the risk of fall is reduced. So dementia by 30% is reduced, hip fracture by 68%, depression goes down by 30%, a breast cancer risk by 20%, a colon cancer by 30%, and a type 2 diabetes reduction in up to 40% patient, cardiovascular diseases by up to 35%, and all cause mortality by 30% just by the help of physical activity. It could also prevent 1 in 8 cases of breast cancer, 1 in 8 cases of colorectal cancer, and 1 in 12 cases of diabetes mellitus, and in 1 in 15 cases of heart disease also. So these are the potential benefits. Along with it, you have multiple benefits also, which are there associated with exercise. So now, how the guidelines have evolved for the aerobic physical activity. Now, this is something really interesting. In pre-1980 era, we were focusing on exercise performance, cardiac rehabilitation, and all these things. And these are continuing till date. But the change has come in the target population. In 1920 or pre-1920 era, we were targeting healthy adults and patients only with cardiovascular disease. Then in 1980 to 2000, we came up to the idea of including general population also to the target physical activity criteria. And now we have included pregnancy, disability, and chronic conditions also. There is one more subtle change which has occurred over the period of 40 years. Previously, we were focusing only on the aerobic activity. Now we are focusing on aerobic, muscle strengthening, and balancing exercises which have been recently included. Now, in the aerobic segment, the intensity has also got a change because we are now shifted from the VPA, which is the vigorous intensity physical activity, to moderate to vigorous intensity physical activity, and also a guideline which says replacing sedentary behavior with LPA. Now the frequency is still changing but continuing since what we have past 10 years ago, and it is around more than 1 day per week. Volume is the most important. So total volume of exercise is now coming to a 4A. The duration, previously we used to say continuous for 15 to 60 minutes, but now the bouts of any strength will do provided we are reaching our volume. And volume, what the volume says, it should be a moderate physical activity of more than 150 minutes per week and a vigorous physical activity of more than 75 minutes per week, or a mixture of these two. And it is still continuing. So the target activity level is 150 minutes for moderate physical activity, and 75 minutes for vigorous physical activity. Now, how to structure the exercise or physical activity for various age groups? So it is divided into 4 groups of age groups. I would say 5. 1 to 5 is also one group. 5 to 17 years, 18 to 64, and more than 65 years. So for the early years, birth to 5 years, what does it do? It builds relationship. It maintains health and weight of the baby even. It contributes to brain development. That's why it is important. It improves the sleep of the baby, and it encourages movement and coordination. So the 1 to 5 year age group should target for 180 minutes per day. And it can include a tummy time, and it should be a tummy time of at least 30 minutes across the day for under 1 year kids. This is mandatory by guidelines. Now, they should dance, they can play, they can bike, they can scoot, they can do whatever they want to do. The target is 180-minute activity per day for 1 to 5 years. Don't give smartphone to them, make them active. Now, when they are little young, 5 to 18 years, it helps in building the self-confidence, it develops coordination, it again maintains weight and improves sleep, it makes them feel good, and it also improves their concentration and learning. And now the aim is for an average of 60 minutes per day across the week. It can include any activity which is spread throughout the day, like running, walking, swimming, skating or sports, or any workout, dance, whatever they want to do. So they should be advised for a 60-minute of activity per day. Now coming to our adult and older adults, I have told you numerous benefits of exercise. So the exercise level is 150 minutes of moderate intensity exercise per week and 75 minutes of vigorous intensity exercise per week. But the catch is to add a strength building exercise on at least 2 days a week, which most of the patients are missing. They should lift light weights if they are not comfortable with heavy weights. They should do yoga, and they should carry heavy bags. Also, a recent inclusion is balance improving exercises 2 days a week, which can include a slow dance, tai chi, and they should also minimize the sedentary time. So this is how the exercise structuring has changed over the year, just merely from being an aerobic set of exercises. Now we have a balanced set of exercises, balancing exercises, and also the reduction in sedentary time. But the important thing which is there is the benefit. So there is an overall benefit of reduction in type 2 diabetes, cardiovascular disease, reduction in falls, joint and back pain, and cancers. Now coming for the pregnant woman, this is again a recent inclusion because it helps to control the weight gain, it reduces high blood pressure problems, and it improves mood, which is very commonly disturbed in pregnant females. It also improves the sleep of the pregnant females. So throughout pregnancy, we should aim for at least 150 minutes of moderate intensity activity. They can do muscle strengthening activities if they are permitted by their gynec twice a week, and every activity counts. So the bout of at least 10 minutes should be there. They should listen to the body and then adopt to the exercises, but be cautious. They should not bump the bump. Now, after delivery, for women after childbirth, from birth to 12 months, how does it help? It improves fitness, it improves mood, it improves sleep, it improves the tummy muscle tone and strength, and it helps to control weight and return to the pre-pregnancy weight. So the aim is again 150 minutes of moderate intensity activity, but they should include pelvic floor exercises as soon as they are permitted to do. And they should also do a muscle strengthening activity twice a week. And depending on the delivery, they should start their exercise regime. They can continue to be active while breastfeeding. It is causing no harm to them and the baby as well. So they should start, but they should restart very gradually under the guidance. Now, this is to summarize for preschool, children, adult, and older adult, as I have told you. Now, this was the guideline. So do we need to strictly follow the guidelines? And what if we are not hitting the mark which is given by the guidelines? This is an article from ACC, and it shows that regular exercise is critical for health and heart health. But it says that the patient who exercise lower than the recommended, they still have significantly lower mortality risk. So whatever we do is beneficial, even if we are not hitting the mark. Still, if we are doing something, it is beneficial to us. Again, a paper from the Society for Reproduction and Fertility, gauging the effect of various exercise modalities on male reproduction function. So it shows that in just 6 months of moderate and even low intensity exercise, it improves the sperm quality significantly. Now, again, a paper regarding the physical activity and well-being in healthy adult, it shows that the light intensity physical activity, it reported higher levels of psychological well-being and lower level of depression. But when the exercise shifted to moderate intensity, they had higher psychological well-being levels and the pain levels were decreased. So the intensity of exercises affecting different levels of psychosocial well-being. But still, the take is even the light intensity exercise works. Now, modeling the economic health impact on children's physical activity. This is again a beautiful paper which showed that in just 25 minutes of exercise, which is way below the recommended, the loss of medical cost which occurs to the diseases reduces by 62.3 billion. So whatever we do counts actually. Now again, the 50-minute daily exercise, is it a reasonable target in older adult? The paper again shows that the low level of activity, which is half even of the recommended amount, was associated with a 22% reduction in deaths of older adults. Now, the Association for Resistance Exercise and Independence of combined with aerobic exercise. So what is the effect on metabolic syndrome? Even under 1 hour of resistance training per week, if done, which is way below the recommended guideline, was linked with a 29% lower risk of developing metabolic syndrome. The effect of acute exercise on mood cognition was also seen, and it was seen that a single bout even of physical activity improves the brain function, enhances mood, and decreases the stress level. So any level of exercise is beneficial. Even if it is a single bout, it will help, as shown in this paper, where we saw the effect on the inflammation in the body of exercise. So moderate exercise session of 20 minutes even stimulates the immune system and it suppresses the inflammation in body. Now, to sum up these things, I just want to say guidelines are there to stay and they should be there because they are the lighthouse. But if we are not following the lighthouse, we should make our every move count. We should do whatever we can do, because you can see with this graph, the benefits start coming even from the 30 minutes of exercise. The 150 minutes is optimum, 150 to 300 is the recommended range, and after 300, the benefits take a plateau, but the risk and harm increases. So doing some physical activity is better than doing nothing. If you are doing nothing, you are at risk. If you are doing something, you are actually prevented from many things. Now, so what to do at home? They can do the cleaning course, other things. They can take stairs in place of the lift. At work and in commutation, they can walk. They should not actually sit idle for long hours. And these are the things which a patient, if he is not able to follow guideline, can do to reduce his risk of the various disorder. Now, the essence is in being active, sit less. You need to build strength also. And now you need to improve your balance also to reduce your chances of fall. So the 2 day per week is the algorithm for strength building and balancing exercises, and 75 minutes of vigorous intensity and 150 minutes of moderate intensity is still the lighthouse. So you can't just avoid it by saying that we will not follow the guidelines. We need to follow the guidelines, but if still you are not able to follow, it will not harm you so much if you walk or if you will not sit idle for long. So to summarize, any amount of physical activity is better than none. You should do whatever you can do, whatever is possible within your range. The best is to follow guidelines, but if you are not able to do, start with little and gradually increase. because every physical activity counts. You should also focus on muscle strengthening twice a week, and you should avoid being sedentary. And then again, you need to focus on your balance to avoid the risk of fall. With that, I thank you all for the patient listening.
Thank you, Dr. Bharat. Thank you for the wonderful talk. And all of us have understood the importance of exercise. I hope next time when we have this data, we have more women doing the exercises and we don't have this dismal number. And we, of course, we should emphasize as clinicians the importance of exercise in preventing lifestyle diseases. And with this, I think we should move on.
Yeah.
Thank you, Dr. Bharat. Wonderful talk.
Thank you, ma'am. Thank you.
Thank you for joining us. And now I have pleasure of introducing our next speaker. She's a very prominent and very well-known figure in all diabetologists. She's Dr. Anjana Mohan. She's Managing Director of Dr. Mohan's Diabetes Specialty Center and Vice President of Madras Diabetes Research Foundation. MD, Diploma in Diabetology from UK, FRCP and FACE. She has various papers to her credit. She has various research areas like prevention of diabetes, epidemiology, physical activity, and very good papers on metagenomics also. She's achieved Outstanding Women Achievers Award from Dr. MGR Medical University and Young Investigator Award by RSSDI. She has various papers and in national as well as international journals. I welcome Dr. Anjana for joining us in this conference today. Her topic today is going to be, are we able to achieve enough regarding our treatment goals? Welcome, Dr. Anjana.
Thank you so much, Dr. Alka. As usual, it's an absolute pleasure to be here. A special thanks to Benny ma'am, to Purvi, and all the lovely ladies here. I see Usha Shriram ma'am, Shilpa Joshi, Ami Shefali. It's wonderful to be here on a Sunday morning. I can't think of a better way to spend this day. So I've been listening to the last two talks, and Dr. Bharat Sabu and Dr. Shaila Sheikh have been such good starters to the day. And what a good active start to the day regarding diet and physical activity. Now I've been asked to speak about whether we're doing enough with our diabetes control and care. So let me just try and find my slides, which are here. And one second. Yes, can you see this?
Yes, yes.
Super. So, and I'm going to try and get rid of that. 1 second. Oh, no. Right. So achievement of treatment goals in diabetes, are we doing enough? So I'd like a disclaimer before I start. This is data that has just been accepted for publication in Lancet D&E and has not yet, it's still under, it's in press and it's still not come out. So this is really, really hot data. So I'd like you to not quote it till it's actually out in the journal. So I have no conflict of interest to declare for this talk. I'm going to show you data from the ICMR INDIAB study. Now, this study has looked at the prevalence, not just the prevalence, but the burden of diabetes and all related complications. So physical activity, Dr. Sabu, maybe we'll send you some data on the physical activity data in men, women, etc. from the INDIAB study. There's diet related data that's also, by the way, in press. There's data on obesity, hypertension, etc. From every single state in the country. So health being a state issue in India, how this started was that we started asking, what are the numbers for India? Do we have data on diabetes, hypertension, etc.? And is this representative of a country like ours that's huge and so diverse? So then when we went to ICMR, they told us that we had to do this state by state in order to make policy differences. And that is why that was the genesis of the INDIAB study. Now today we have data from all the states. So there's 27 states, 2 union territories of Delhi and Puducherry, Chandigarh and Puducherry, and the National Capital Territory of Delhi. Okay, so that's, I'm going to show you data from 1,13,000 individuals in India, which is representative of this country. Naturally, for a country like ours, you can't do this study overnight. So we've been doing this for a long time now, and we have data on all of these states that are in various colors except J and K for obvious reasons. Now, this is the prevalence of diabetes. And throughout the talk, you're going to see this color coding that's happening. Blue stands for males and pink stands for females. Sorry, cliched, I know, but just for colors on a slide, right? So here you have the prevalence of diabetes in males and females. We have it overall, 10% in male, 9.3 in female. When this was published a little earlier, these numbers were a lot lower. Now, remember, I'm not just talking about urban alone, city alone, rural alone. This is the whole country, right? And when I say urban areas, also remember, these are not just metropolitan cities, but they have urban, peri-urban, all of these included. Even then, you will see stark differences between the urban and rural India, but slowly these numbers seem to be catching up, and this appears to be the situation today. So women are slightly lower, just decimal point differences between men and women, and we'll go into the other details soon. So now what about self-reported versus newly diagnosed? So men, for every man, there's a 0.7. This is again national. I haven't gone into regional things here. Women are 1:0.9. So let's say for every female who's diagnosed with diabetes, there's at least one lady who's not diagnosed still. So that's still a huge burden. If you think we have lots of numbers of diabetes today, there's as big a number, especially among women, that's still not been diagnosed. So this is what that data tells you. But let's move on straight to what I'm supposed to be talking about, and that is comprehensive diabetes care, the ABCs of diabetes. Now, why do ABCs matter? Of course, it matters for all of our complication risk, microvascular as well as macrovascular. And I do not have to describe that to this group. So let's go on to it. What are the goals that we have considered primarily? And I'll also tell you about the sensitivity that we've done. As all guidelines recommend, A1C less than 7, BP less than 140/90, and LDL cholesterol less than 100 are the main goals that we're looking at. So for this, now out of the 113,000 that I told you about, we have to take those with self-reported diabetes. We have obviously excluded newly diagnosed because we're looking at care. So those with self-reported diabetes have been included in the study. Now let's move on to A1C. So again, same color code, okay, male and female. How many of the population have an A1C less than 7? That's the first one, called good. 7 to 9 is fair, and more than 9 is poor. So among men and women, really not much difference, okay? We have about 30-35% of the population who are in good control. So that leaves the entire other lot in either fair or poor control. So again, I have not taken age-wise differences and all. This is just an overall sum of the population. We do have sensitivity by age and all that, but this is just the pool data that I'm showing you. So men and women, not much difference in reaching A1C of less than 7. It's about 35%-ish. Now, what about urban and rural areas? Again, not too different. So the color coding for urban, by the way, is red and rural will be green. So 34% urban and 37% in rural. So this is 7. If you go 7 to 9, then these are the other figures that are shown here. So again, not too different, 35%, 36% male, female, urban, rural. We're still at the same level of control. We still are not doing, only about a third of our population has reached good control of sugars. Now let's look at this region-wise, okay? And that's the beauty of InDiab. So just before I go into this, you have central, north, south, east, west, northeast shown here. And again, blue is male, pink is female, and there's a green overall also there. So north, which are the states that are included in north here? So you can look at where you are located. So we have Chandigarh, Delhi, Haryana, Himachal, Punjab, and Rajasthan. This is the grouping of north. South is undivided AP. Kerala, Karnataka, Puducherry, Tamil Nadu. So that's in the south region. East is Bihar, Jharkhand, Odisha, West Bengal. West has Goa, Gujarat, and Maharashtra. Central is Chhattisgarh, Madhya Pradesh, Uttar Pradesh, and Uttaranchal. And Northeast are, of course, all the northeastern states. So this is the grouping. So overall, again, we find that the West and Northeast are doing slightly better. So remember, we were at 30, 35. So rest of the country, look at it. It's just in that same kind of range, 35, 36 there. Whereas the West and the Northeast, slightly better control, we are able to see. Men and women, nothing very significant, some places little here, there, but no significant differences across the groupings. Now, this is SMBG. Dr. Shaila Sheikh was talking about it. And, this is about how many people among those with self-reported diabetes are actually checking their blood glucose to monitor. So SMBG. So you have, again, male and female. So the orange bars are all diabetic subjects, the entire pool. And the blue here is insulin. Those on insulin, how many are checking? So total diabetes, it's 16%, 16.7. So male and female is a little lower. Always SMBG levels, we've found that women, I don't know, test less than men. And among those with insulin also, it's about 37%. So these are people on insulin who possibly need to be testing a lot more. There's only 36, 37% here that we are showing. Again, now this is urban and rural. So urban is obviously doing a little better, significantly better than rural. And in urban India, almost 1 in 2 people on insulin at least are checking. So that's the good news. Rural areas is a long way to go, and we still have major differences between urban and rural. Now, how often are people checking? You say they're checking, but how often? Daily is only 5.5%. So even among those who claim to be checking on insulin, of course, this has type 1, type 2 together, but type 1 is a very small percentage. This is national data, remember, not hospital data. So we have weekly about 40% and another 40% checking monthly. So that is the point to note. So although they're saying they're checking, how good is their checking, or how is it going to help them by doing an SMBG once a month, right? So that is the other issue we're dealing with. Weekly, we're a little better with that one, but still we have very few actually doing daily sugars to see that their sugars are under control. Now, what about blood pressure? Blood pressure is better than diabetes control and flat across the genders or sexes. So we have about 48, 49% both among women and men who are achieving the blood pressure targets. Urban, rural is doing better. More than 50% of people with blood pressure with diabetes are able to control their blood pressure less than 140/90. And region-wise, again, it looks like there is overall about a 50% male and female. These bars look a little confusing, I'm sorry, but overall it's about 50%-ish across the various regions. Cholesterol. So here you have three things that we've looked at: total cholesterol, triglyceride, and LDL, LDL being the primary focus. And this is very important because till now, we haven't talked about male-female differences, right? But here you will see that women have significantly less control of their LDL and total cholesterol compared to men. So now this is a question as to why. So is there a medication difference? And I'll show you the medication use soon. But in BP, there wasn't anything significant. In sugar, why is the lipid level not being controlled? So that's a good question that we're asking. Both LDL cholesterol, total cholesterol control is significantly less in women compared to men, as shown in these graphs. Urban, rural, again, there are slight differences here. Rural is slightly lower in their control of cholesterol compared to the urban areas, especially for LDL. Region-wise, again, here, there's one little thing that I'd like to say. The Northeast stands up separately, okay? So the rest of the country is like one bar, around 40%. Northeast is doing a little better. So again, here, there may be ethnicity differences when you look at the Northeast and the mainland, but it looks like a separate little column, and the rest are one bar. So lipids, there seem to be more differences than blood pressure and A1C. Let's go on to the medications for all of these. So these are diabetes medications. The color coding is, as I've told you, urban, rural, male, female overall. The first column is any glucose lowering agent. The next one is OHA and the next one is insulin. So you can see that for those with self-reported diabetes, about 11% are on insulin. OHA use is good. And there are not remarkable differences between urban areas, rural areas, men or women. Women are, by the way, slightly higher compared to men when it comes to taking their medications, at least reported, right? Blood pressure, again, women are doing a little better on terms of taking their blood pressure medications compared to men. And these are the other no remarkable differences between urban and rural medications. Lipids. So remember we said control was better, that was worse in women compared to men. And this is in spite of the tablets being this, these are all statin use, right? So statin use is across the board about 15%, men, women, everything. And in spite of that, women are still not having good control. So there are other issues that one has to start thinking about. These are logistic regression charts. Okay, I'm not going to go through this in entire detail, but just to say, we've done it separately for A1C, for blood pressure, for cholesterol, and there's a combined. And the red ones that you can see for quick reference are the ones that have come out significant. So just to say here that for the combined ABC, okay, and this is attainment of the goal, right? So, so here females had, for combined ABC, I'm just going to go through that one. Females had a less chance of attaining compared to men for combined ABC. Urban areas again had a less chance of attaining. Higher the education, more the chance of attaining your ABC goals. Duration of diabetes, again, more duration, less chance of attainment. So these are the combined ones. We've also looked at activity and all of that. I'll show you that in a few minutes. So now let's look at access and care. We asked people whether they were going to private healthcare or government healthcare, and this is across the country. Of course, as we do know, most people still are going to, there's even urban, rural all put together. Even in rural areas, people are going to private healthcare. And this can be either a private practitioner, a hospital, or a corporate, or whatever it is. But this is still private healthcare, and government use, although is the highest in rural areas, still is about 30–40% in our country. And this includes government hospitals, district hospitals, major medical college hospitals, etc. across the country. System of medicine. There seems to be a lot of talk about whether, allopathy is good, bad, not so good. 83%, no matter what anybody says, 83% of our country still uses allopathy and believes in it. Some people combine allopathy with some systems, and that's about 6%. Ayurveda alone is 1.8%, and others all put together. So we have data on Siddha, Unani, this, that, across the entire native medicine. So irrespective of what you possibly hear, people still believe in us. People still think that, we're doing a good job, and they still trust us. And that was the great news as far as I was concerned, at least. Okay, so health habits. We talked about smoking, alcohol, fruit, vegetable, and physical activity. So here I've just shown you the male-female data. Of course, the smoking and alcohol is not a surprise across the country. But look at fruit and vegetable, although not significant for the 5 servings. So this 5 servings of WHO fruit and vegetable is not at all used in our country. So we have had to build another one, the 3 servings, because it's like in single digit when you start talking about this 5 servings. So when you talk about fruit and vegetable, women are really bad when they eat less of all the healthy stuff, as you possibly know. And physical activity, like Dr. Sabu was saying before, it's terrible among women, okay? And there's more data. I'm not showing it in this paper, but this is what we show here from INDIAB. So you can see the clear differences in men and women in this slide. This is a heat map of various states. So on the y-axis there you have all the states, and across the top, just at one go, we're telling you how the country performs in terms of A1C, blood pressure, systolic and diastolic, cholesterol, LDL, HDL, all of those, triglycerides, smoking, alcohol, fruit and vegetable, physical activity. So the red, it's color coded, okay? Red is the worst, orange is like in between, and green is good. So you can see A1C is all in orange. blood pressure is a lot in the greens, but then you take the health habits, go to the far end, okay? Physical activity is almost fully in red, fruit and vegetable is not good here. And, even the lipids, so those seem to be just one shot, across the various NCD parameters where we need to put effort, where where we are orange and red. So, right, so I'm going to conclude now and say that only a third of individuals with diabetes have good control of their glycemic status. We're doing a little better with BP control. We're almost at 50%. LDL cholesterol is in between the two at about 43%. The proportion of individuals attaining all the three glycemic targets is only 7.7%. Shame on us. No significant differences in attainment of glycemic targets between urban and rural. There's not much difference between men and women either. And there's quite a lot of heterogeneity between regions and among states. A majority of individuals still rely on private healthcare, that's 62%. Less than a fifth performed any blood glucose monitoring. Of course, this was better if they were on insulin. Higher education, male sex, rural residence, and shorter duration of diabetes were associated with better achievement of goals. And thus, we still have a lot to do to be able to get our patients to better control. Thank you.
Thank you, Dr. Anjana. Thank you, Dr. Anjana, for a wonderful talk. Any questions, Madam Rami?
So, yes, ma'am, Usha ma'am.
Anjana, fabulous talk as usual. I was just intrigued. I'm glad this lead into my talk on hypertension. People are doing well with hypertension. But as far as lipids, they believe that women are not given more powerful statins. So that may be compared to men. So that may be one of the reasons why, even though they're given the same, the percentage is the same, maybe it's not, more powerful statins. So that's something that maybe we should look at.
That's an absolutely fabulous point, ma'am. I think so too. Maybe we don't have data on that. We do actually. We could look at it and see which they are taking. So that's a really good point. The other thing that I was thinking of, ma'am, women, because there's a general thought that we're protected against cardiovascular disease. So this hesitancy to, take the statin, or they may be taking, but they'll take it 3 times a week or something like that, So that overall idea that women are more protected could lead to, so we don't have complete data on compliance here. We're just on whether you have a prescription and whether you're taking, so we don't have complete data on compliance. So that could be another issue. But that's a really good point. Thank you.
It could be possible that the adherence of the therapy is quite poor, because you said ABC is just 7.8%, close to 8%.
Yes.
It could be the adherence of
Could be,
therapy. Yeah,
Could
if
be,
you look
sir.
at across the globe, even across the globe, the work done by various people said that the adherence to treatment, whether it's hypertension, diabetes, or lipids, in fact, lipid is just pop a pill, but still the adherence is poor. And that's the reason why I think we see such a small figure.
Yes, sir. Yes, sir. That's a very, very valid point. So yes, it could be. We have still to, get more data on that.
That was a lovely talk, Anjana, and it's an eye-opener, actually. I mean, I was really scared, 7.7%, and it's terrible. And what's happening to our women out there with gestational diabetes and PCOS, I think we need to start statins pretty early, even not even looking at their lipids if they have these risk factors. And I like Dr. Bharat also saying that, exercise should start from 0 to 5 years. Bharat, I think you have given the right message, because we don't allow our children to play, and they don't even have enough parks to play. And Dr. Shaila, extremely good insights into Ramadan. I think now we have guidelines and we should follow them. And the best part was you said that even pregnant ladies are not, they may not fast, but you see in our practice, they are the ones who fast as well. And it's so difficult to control them. Excellent session.
So moving on to the next session, thank you, my co-chairs, and thank you all the speakers for such a wonderful deliberation. Moving on to the next session on 9 months, I invite the chairpersons for this session. Dr. Anjana Mohan was just given a wonderful talk. She's the managing director of Dr. Mohan's Diabetes Specialty Center and vice president of Madras Diabetes Research Foundation. Dr. Shalini Jaggi, consultant diabetologist and director, Life Care Diabetes Center, New Delhi, and member executive council, RSSDI National and secretary, RSSDI Delhi chapter. Dr. Sheila Sheikh was just also given a wonderful talk from Mumbai. I request the chairpersons to kindly take over. So, Dr. Anjana.
Thank you so much, Ami. And it's once again a pleasure. I don't think Dr. Yajnik sir requires any introduction to this audience, but since this is a conference and an official presentation, I will take a few minutes to introduce this doyen of diabetology amidst us today. Dr. Yajnik is the director of the diabetes unit at Pune. He trained both in Pune and in the UK. He's known for his description on the thin fat Indian, and we all know the YY paradox. He brought that to our country. He's currently the president of Sneha India, that looks at the natal effects of health in adults. He is the honorary member of MRC and so many different organizations. He's received the Helmut Meinert Award of the IDF and the David Barker Medical Medal. So I am not at all surprised on that. Congratulations, sir. And he has a number of very, very important publications, is a member of various organizations, and is a very sought after speaker. So welcome, sir, and over to you. So you're on mute. Sir, you're on mute.
You got a notification to unmute yourself.
Sorry. Yeah. Okay. Thank you, Anjana. Thank you for a wonderful talk and a very kind introduction. So look forward to interacting with you on what I'm going to speak. I've chosen a slightly controversial topic, a GDM who benefits, mainly because we have now, of course, an epidemic of GDM. India would have a very large number of cases, a big burden. But I think there is a need to just take a pause and look at some of the practices, because I think there is an issue here. I'm going to start by saying, which I usually say, mine is the only diabetes department in the world where the logo is mother and baby. And that, of course, speaks for our interest in pregnancy as a determinant of the NCD epidemic in the world. Gestational diabetes, as we define today, it's diabetes diagnosed during gestation. And I'm going to raise two questions. First, do we really know what is diabetes in pregnancy? And are we sure it's only gestational? So first, begin with the first question, whether we know what's diabetes in pregnancy. This is the mother of all sort of studies for current thinking in the criteria for diagnosis of diabetes. That's happened. And if you look at the 4 outcomes they had, namely larger baby, cesarean section, neonatal hypoglycemia, and the cord serum C-peptide more than 90th centile. In some ways, all related to baby being big. And then they put it across the 7 glucose categories with increasing sort of monotonic concentrations. And you see all the 4 parameters are a continuous association with the glucose, whether it is fasting, 1 hour or 2 hour glucose during OGTT. There is no hint of any threshold, except perhaps for the neonatal hypoglycemia, where the highest glucose, sort of whatever 7th tile, had a much larger risk. Otherwise, it's all monotonic and continuous. But after showing this beautifully, they provided an expert advice to define some cut points, because I think that's what their mandate was. Whether that does us any good or not, I'm not really sure. That also reflects in a series of different criteria for diagnosis of diabetes in pregnancy, which have come around. And as we know, IADPSG criteria have not been accepted by many countries, notably in UK. There are nice criteria. Denmark has suggested something else. Australia has their own things. India has our own sort of DIPSI criteria. So that itself tells us that people in different countries and different situations talk about different glycemic states as pregnancy diabetes or gestational diabetes. Are we sure it's only gestational? I trained in MD and in Oxford in early 80s, and that time this was a new entity after the 1979 NDDG consultation. And that time they admitted that some of these women might actually be diagnosed before, or they had diabetes before, but it was not diagnosed because they had not tested. And there has been some debate on this in literature, but we insisted on calling it gestational. There have been recent attempts to actually diagnose it earlier in pregnancy, because the current standard epidemiological approach is to diagnose it between 24 and 28 weeks of gestation. And a series of them have been given. What is notably missing here is glucose. People are shy of measuring glucose or doing more work on glucose cut points in early pregnancy to define an abnormal condition, and they will come up with all sorts of things, including miRNAs or some glycated fibronectin or whatever. Basically, what it shows is that there are a whole lot of metabolic endocrine abnormalities, even in early pregnancy, though we insist on diagnosing it somewhere here. It just tells us that our point of diagnosis is not correct, and whatever is there, we are diagnosing at 24 weeks, is already there in earlier stages. Even fetal growth is different in women who are subsequently diagnosed gestational diabetes. And this is a slide from the Born in Bradford study. I picked it up because it's a very nicely done study in South Asians and the Europeans. And as you can see, much before they did the glucose tolerance test around this time, the growth of the baby is different. Especially interesting, the head circumference and femoral length, abdominal circumference are all lagging behind in early pregnancy. And that is what was actually described when I was training in diabetes, is a characteristic of babies conceived in pre-gestational diabetes, notably type 1 diabetes. So this finding is not very different than what we see in pre-gestational diabetes. What they have not shown here is CRL. Even CRL is smaller in gestational women who are diagnosed gestational diabetes later on. And then came this quite interesting paper from Kaiser Permanente, where they wanted to define abnormal lipid concentrations in women who were diagnosed in their system with GDM, but had been through the system and had some measurements before. And therefore, they were able to look retrospectively and showed that women who were diagnosed with GDM were actually slightly older. They had a higher family history of diabetes. Their pre-pregnancy BMI was higher. Very interestingly, their glucose was higher. Surprise. Cholesterol, then HOMA-IR, higher insulin concentration. So all the abnormalities which we associate with type 2 diabetes were already there when they were tested in the system years before, gestational diabetes was diagnosed. So that was a one very definite proof. Even better proof now is available in our studies in Pune. The Pune maternal nutrition study, as you know, started in 1993 in women from before they conceived. And then they gave birth to children, daughters and sons have been followed up. And out of 357 daughters who were born, 195 by 2020 February, that's when we stopped for COVID, had become pregnant. So married and become pregnant. So we have now data on these girls in pregnancy, but interestingly also at 18, 12, and 6 years of age, and also their birth characteristics, and interestingly also mother's OGTT during her pregnancy. Very interesting story. I think this is the only place in the world where we have it. I'm just now going to show you something which we submitted as a late breaking. I withdrew it because I'm not going there. But these are the plots of various parameters in girls who were in the highest quartile of fasting glucose in pregnancy. That is what we call gestational hyperglycemia in them. And we are able to trace their body size, that's height and BMI, their glucose and insulin, their HOMA parameters, and their disposition index, etc. I would concentrate on these two blocks. One is fasting plasma glucose, and other one is the disposition index. The girls who were in the highest quartile of fasting glucose in pregnancy, let's call them gestational diabetes, had higher glucose throughout their life course. They are not higher only in pregnancy. It's not a de novo thing. At 18 years, at 12 years, and at 6 years. So, I put one more point. That's 24 years. That's after delivery. So they had higher in delivery, higher before that at 18 years, 12 years, and 6 years. And continued to have it higher after delivery when we measured them at 24 years of age. In other words, people whom we diagnose hyperglycemic at any point have been tracking like that from very early age. And it's that our first test was at 6 years. I'm sure if we had measured them before, they would be high. And interestingly, it was not HOMA S or HOMA beta, which was abnormal in early years. It was the disposition index. So their beta cells were not responding adequately to the prevalent insulin resistance. And that was again present right from childhood and continued through adolescence and early adult age. I think this is the best proof anywhere in the world that what we call gestational hypoglycemia is just a tracking of glucose from very early life. Is it important? I'll tell you why it might be important a little later. So we learned that short-term outcomes in a GDM for mother are increased risk of PIH, cesarean section, preterm labor, and infections. And for baby, birth defects, that's been mentioned in literature and again reported recently, which clearly tells you that actually these women had higher glucose from before pregnancy during embryogenesis. Then all others are related to macrosomia or abnormal outcomes if there is very bad pregnancy, and metabolic outcomes in the perinatal period. Are we able to prevent any of these by treating gestational diabetes as we do by diagnosing it in the third trimester and then zapping them with various things? These are the two famous randomized control trials of treating GDM, one done from Adelaide, Acute trial, and one London, which is the multi-center US trial. For mothers, treatment of GDM, the way we do it, reduced risk of preeclampsia. In one study, it reduced risk of cesarean delivery. In both studies, it increased the risk of induction labor, though it was significant in one, not in the other. So what we are able to reliably reduce the risk of is preeclampsia, maybe cesarean delivery. But we increase the risk of induction of labor. For the child, serious complications were reduced as a group, but SGA was similar, LGA was reduced, and macrosomia was reduced. So we are able to reduce baby size by controlling mother's glucose, and this should be obvious to us because baby depends on maternal macronutrient transfer for its growth. So that's the Norbert-Frankel's fuel-mediated teratogenesis. So in summary of all such studies, what we find is there is a reduced risk of selected important outcomes like preeclampsia and others which are mostly related to large size baby. So we are able to reduce the size of the baby and associated complications, but many other neonatal metabolic abnormalities or severe complications may not be affected. For long term, mother has a risk of type 2 diabetes and cardiovascular disease. Baby has similarly a risk for obesity, diabetes, neurocognitive outcomes, and CVD risk. Has any treatment of GDM of RCT shown an effect? Now for the mother, we have this great paper from Nikhil Tandon just a couple of weeks ago. It's in JAMA Open. I think all of you should read it. And I'm just going to give it a little bit more time because it's such a fantastically done study. And what he concludes is that this study found that a large proportion of women in South Asian urban settings developed dysglycemia soon after a GDM-affected pregnancy, and that a lifestyle intervention modified due to COVID pandemic did not prevent subsequent glycemic deterioration. So this, of course, suggests that alternate or additional approaches are needed, especially among high-risk individuals. In other words, treating GDM during pregnancy and putting them through an intervention subsequently did not prevent diabetes. That's the outcome for the mother. For the baby, in Acute study and in London study, there are two long-term outcome reports. There was no reduction in the obesity, that's BMI Z-score. Height was similar, weight was similar in babies who were born in diabetic pregnancies as opposed to non-diabetic pregnancies and in those who were treated and not treated. In London trial, they measured more things. So they measured blood pressure, they measured lipids, that's HDL, triglycerides, and LDL, and they measured glucose and central and generalized obesity. None of these outcomes were reduced by treating maternal gestational diabetes in pregnancy the way we do it. What's the Indian scenario? Majority of pregnancies are unplanned and no preconceptional glucose measurement or other advice is given. GDM is quite commonly diagnosed with reported figures of 10 to 25% using mostly local criteria, which are not based on outcomes. They are WHO criteria applied only for 2-hour value. That was almost 20 years ago. This number is, of course, a big burden because we deliver almost 25 million babies every year. Majority of women, once they are diagnosed with GDM, receive quite intensive treatment, and we have guidelines for fasting, postprandial, weight gain, this, that, etc. And cost of GDM pregnancy is much higher. There is a substantial rural-urban and socioeconomic inequity, as again Anjana pointed out in her findings in the INDAAP study. National average birth weight in India is 2.8 kg. And in NFHS4 in different states, still 15 to 25% of babies are less than 2.5 kg, which is what we call LBW. This is very different than European baby, where the average birth weight is 3.5 kg. In ODMs, that's offsprings of diabetic mothers, birth weight in most of the clinics is approximately 100 grams higher. LGA is majority of reports less than 10%, and SGA is still not uncommon. So this is the Indian scenario. Please concentrate on this. And once you diagnose GDM, then thresholds for everything are lowered: investigations, inductions, cesarean section, NICU screen, etc., etc. And we have seen that treatment of GDM does not reduce the long-term risk for the mother or the baby. Again, I'll show you something. And we have very few long-term follow-ups. There's a notable one from Mysore, that is Kitiveni's, and now from Pune, which we will soon publish. We certainly know RCTs have been done in India to look at the benefits. This is a follow-up of my PhD student, Sonali, who followed up 200 children born in diabetic pregnancies and 177 controls born in non-diabetic pregnancies. This is in a diabetes unit, which is very interested in pregnancy diabetes treatment. We do it intensively as per the given criteria, but what do we find? At an average of 15 years, in those above, like say 10 years of age where we do an OGTT, 5% had diabetes and 37% pre-diabetes. Compared to ONDM, that's offsprings of non-diabetic mothers, where 20% were pre-diabetic. So double the risk of pre-diabetes and a much higher risk of diabetes at young age. This is despite intensive control in pregnancy. And even in those below 10 years where we had only a fasting or random capillary blood, their glucoses were higher. So it starts very early in pregnancy. So in a way, it's very disappointing what we get in the long. One of my contentions is that we systematically miss the periconceptional period in a pregnancy where most of the fetal programming happens. And what is actually influenced by periconceptional, preconceptional period is gametogenesis, fertilization itself, implantation, embryogenesis, and placentation. Vital processes for the development of that individual, and the dramatic reprogramming of epigenome, which happens within 48 to 72 hours of conception. And woman doesn't even know she's pregnant at that time. As you are aware, I have now given quite an extensive sort of lectures on this, that the whole DNA methylome is completely stripped off and re-established within 48 to 72 hours of conception. And that is the time a whole lot of programming through DNA methylation is likely to happen. And we completely miss that by diagnosing someone way down the time at third trimester. And the famous embryologist from UK, Louis Wolpert, said, it's not birth, marriage, or death, but gastrulation, which is truly the most important time in your life. And this happens within 5 days of conception. So very profound thought which he had given. Recently, we have followed up the children, as I said, more than 850 pregnancies treated for diabetes. And what we found was that the size of the baby at birth was actually largely determined by maternal glucose levels. And these bars, color-coded, are red are type 1 diabetes mothers, blue are type 2 diabetes mothers which became pregnant, and yellow are mothers who were diagnosed with GDM. If you look at maternal BMI, type 1 women were the thinnest and type 2 women were the most overweight obese. If you look at ponderal index of the baby, highest ponderal index in babies of type 1 mothers, highest abdominal circumference and waist circumference in babies of type 1 mothers, and largest skin folds again in babies of type 1 mothers, despite the type 2 and GDM mothers being bigger. And what happens when we follow them up later in life? All that is actually gone. The babies of the type 1 diabetic mothers have normal BMI. They have slightly elevated abdominal circumference, which is not significant. And their skin folds are similar to the babies of normal glucose tolerant mothers. So the factors which determine the adiposity and size at birth are very different than what is determined later in the life. And I think this point needs to be hammered out. It has been mentioned in literature in passing in many papers, but we are now actually writing a paper to make sure that people understand this, because this has a great public health message. Prevention of obesity in the children born in diabetic pregnancies might be possible by concentrating on the postnatal period, the family environment, and the usual risk factors. I'll finally sum up by saying great sort of work which was done by Andrew Hattersley, first based on glucokinase mutation, but subsequently, I dare say, because of my influence, also admitting about maternal nutrition. That's how he gave me a visiting professorship in his department 15 years ago. And what we know is that the birth weight is determined by supply of nutrients as well as genetics of the baby. And both of these combine to determine the size. There are very interesting combinations, whether these genes come from father and mother or both. And this needs to be taken into account. But we cannot forget nutrition. India is suffering on this side, in addition to having genetic predispositions like Western world. But we really cannot forget that our babies are suffering because of undernutrition, even though mother might have type 2 diabetes or gestational diabetes or whatever we call, and therefore the size of the baby at birth is lower than the Western world. And that should actually dictate a whole lot of our thinking. So take home messages. One is there is a lot to learn. Always, I am still learning. I am just trying to understand and beginning to understand. All the decisions should be sensitive to local situations. We are right, left, and center quoting ADA or ESD or other guidelines. We sit expert committees who just modify a few words here and there. And it's a tale of two entirely different worlds. We cannot base all our decisions based on the Western literature. We need a national database and registry. We should follow Anjana's advice, maybe invite her to set up one like this. Ethical interventions are necessary because we need to make sure we don't do any harm, because we are using advice entirely from a different population where overnutrition is rampant. And we need personalized guidelines depending on that pregnancy's need. Diagnosing GDM in pregnancy, I think, is too late. You might shoot me for that, but actually I think that is what is the major issue. Preconceptional detection and correction is what's needed, and which means we doctors should lose our control over this, hand it over to public health people. We move from clinic to community. All the big business around GDM, I think, needs to be shifted to the pre-conceptional stage and handed over to the public health and the government. Thank you very much for patient listening. I'm prepared to take the flak.
Thank you so very much for that wonderful talk, so detailed, so good. I think questions are at the end of this session, if I'm not mistaken. Benny ma'am, is that right?
Yes.
Yes. Okay.
Yeah.
Okay. So I will then hand over to the next chairperson, Dr. Shalini Jaggi.
Thank you so much, Dr. Anjana. Good morning, everyone. And after that excellent talk by Dr. Yajnik, it was very, very eye-opening. I think a lot of things to take home from here, a lot of ideas to be built up. Thank you so much, sir, for that great session and those insights, a lifetime's work indeed. With that, we now move to another great session by none other than Dr. Usha Shriram. I think she has led the women and diabetes, the preconception, post-conception care, and all the different issues on women's health. And she's been our flag bearer, one of the torch bearers who's always fought for that importance to be given on the gender-based management of so many different NCDs that we talk of, especially when it comes to diabetes. To introduce her, she is the head of Department of Endocrinology, Diabetes and Metabolism at VHS, President ISBMR, founder DIVAS, as well as DD Project, of which we all have been working together for the last 2 years. Ma'am has a special interest in GDM, women's health, osteoporosis, preconception care, and medical ethics. And without taking much time, it's all yours, ma'am. Another NCD, hypertension in pregnancy. Welcome.
Thank you, Shalini. And what a difficult talk to follow. What an amazing talk given by Professor Yajnik. And also, like you said, it's opened our minds and eyes in such a big way. And I've been harping on this preconception care, and I think he has completely nailed that. So we should start working on that. And I've been talking to Dr. Sunil Gupta about GDM registry, about which you know. So I think we should get to work. So I'll share my slides now. Can you see them?
Yes, ma'am.
Yes, ma'am.
Okay, great. So when Benny called me and asked me to speak on hypertensive disorders in pregnancy, for a brief second, I was thinking like, I would like to speak on glucose and things like that. But then I realized that our focus is now on pregnancy as a window to future chronic disease, and how can we prevent NCDs in women. So nothing like addressing each one of these. And Dr. Yajnik has very nicely shown what gestational diabetes does to PIH. So from those counts, and I'll show you some very important data for India. So first is, we've always been kind of myopic about, pregnancy in the sense, everything, preconception and other prenatal interventions, interconception focus, everything has been on just the pregnancy outcome, the index pregnancy outcome, and the health of the baby. And the health of the mother has always been seen only in the context of threat to the baby's well-being. And we have missed opportunities to address women's health issues longitudinally, over a long period of time. And this is, I think, the essence of the talk that I'm going to give, which is we need to do interventions early. And I think this is great segue from the previous talk. If you see fetal life or infant life, and then pregnancies, the plasticity there, and then subsequently when we really start intervening in middle age and old age, and hardly, that's just putting a band-aid on the problem and not really preventing or doing much for women's health. And I really urge people to read this article, which by Rajiv Gupta, in where he says hypertension is the most important non-communicable disease risk factor in India. And look at this in terms of the global burden of disease study from 2015. If you look at specific risk factors, and this is for mortality in India, when you look at specific risk factors, high blood pressure ranks number 1, then comes high fasting glucose. Even though if you look at a cluster of risk factors, air pollution and dietary risks go up. So if you look at the WHO data from 2017, there are about 295,000 maternal mortalities globally, and 94% of those deaths occurred in low resource settings. Having said that, I think we have done well from the maternal mortality point of view. I'm not sure what has happened in these 2 years of COVID and lockdown, whether things have been, rolled back. And most maternal deaths actually felt to have been preventable. And if you look at causes of maternal mortality globally, hypertensive disorders of pregnancy feature in the top 5, and extremely strong evidence for hypertensive disorders of pregnancy and a woman's future health. And I'll show you some good data on this. Over 250,000 preeclampsia pregnancies, and over 5 million normotensive pregnancies have been compared. And then the preeclampsia associated with ongoing health issues for mother. We've always traditionally looked at high-risk pregnancies as a one-off phenomenon. Okay, she had preeclampsia, or she had gestational diabetes, or had preterm delivery, or a baby was born low birth weight. And after looking at Dr. Yajnik data again, where he showed that anywhere up to 25% of babies are born low birth weight. So if there are 25 million births in India on an average per year, or somewhere in that ballpark, and if we have 10 to 15% GDM, 10% or more hypertensive disorders, and if 15, 25% are born low birth weight and we have preterm, we're talking some number like over 10 million women per year at risk for future chronic disease. So now you can see the real burden of disease. So now my talk actually begins, and I'll just quickly go through definition, classification, consequences, and what's the pathologic basis for all this, and pregnancy as a window to future chronic disease and solutions. And it's very kind of important to understand the different things. So chronic hypertension is hypertension that precedes pregnancy or develops before 20 weeks. So 20 is the magic number. Then there is preeclampsia and eclampsia, and I'll show you some definition, some more information on that. It's new onset hypertension after 20 weeks and associated with proteinuria or end organ dysfunction. Gestational hypertension is new onset hypertension after 20 weeks, but without proteinuria or other preeclampsia findings. And then superimposed on chronic hypertension, of course, you can have chronic hypertension and preeclampsia. So this in addition to white coat and masked hypertension and things like that. So if you look at the hypertensive disorders of pregnancy, I already mentioned the 20 weeks, and I talked about the proteinuria and other end organ damage. And it's important for us to classify clearly, because how we approach these women, and in terms of risk stratification, it's very important, and not put them all into one bucket or one basket and look at them together, but actually know where these women fall. And if you look at the pathogenesis of preeclampsia, I'm not going to go too much into detail, but there are risk factors which could be genetic, immune-based, some other acquired risk factors, impaired trophoblast invasion, and then decreased uteroplacental perfusion, which is very important when we are dealing with people with type 1 diabetes and type 2 diabetes, pre-gestational diabetes, placental hypoxia, and a whole bunch of factors, as you can see there. And very important, these angiogenic factors that are circulating, because some of them have been developed as markers. And then, of course, the complications that set in, and finally, you can see the serious consequences of preeclampsia, everything from hypertension to cardiomyopathy, and I'll show you the future risks. So in a normal pregnancy, there is increased heart rate, increased plasma volume, leading to increased cardiac output, some degree of eccentric LVH, but they all return to normal postpartum. But if somebody has pre-existing cardiovascular disease or some impaired placentation or those risk factors I mentioned, you can see the antioxidants are go down, oxidative stress is going to go up, and multiple other factors are at play. And then you have endothelial dysfunction, vasoconstriction, systemic vascular resistance goes up, concentric LVH happens, and then postpartum cardiomyopathy and other cardiac modeling changes. And what's important to keep in mind is many of these changes in women with preeclampsia and chronic hypertension and preeclampsia superimposed on top of that, it persists, and that is what actually sets them up for future cardiac disease. And another nice illustration to show you whether it's coronary artery disease or asymptomatic heart failure or symptomatic heart failure, aortic stenosis, mitral regurgitation, so many changes happening, and accelerated vascular aging among women with hypertensive disorders of pregnancy. Chronic hypertension, which we know is a very frequent problem, accounted for 64% of the association between hypertensive disorder of pregnancy and incident coronary artery disease, and 49% of association with heart failure. Heart failure is something that's not in our radar. It's something that we really need to keep in mind. And you can see all of this cascading onto what we call this maternal syndrome or maternal placental syndrome. Now, moving to what are the consequences of this, since we are a group of diabetologists and endocrinologists and physicians largely in this meeting, we need to know what are the consequences of this for the future, especially. Look at the DALIs and the mortality and future hypertension. Very, very important. Metabolic abnormalities. So it's not like it happened during the pregnancy and then it went away. Metabolic abnormalities, inflammation, oxidative stress, hypercoagulability, all of which are part of a normal pregnancy. In fact, pregnancy should be looked at as a stress test. And then there's endothelial dysfunction, future hypertension. Very important. And you could have it a recurrent as well. And I'll show you what that could lead to. And even this impact is lifelong. And you can see age at study enrollment, and then the history of this is no hypertensive disorder versus having hypertensive disorder and prevalence of hypertension. And then this phenomenon is something we need to keep in mind. When you add each of these risk factors one to the other, the subsequent risk of whether it's coronary artery disease or stroke or heart failure or mortality goes up exponentially. This slide very nicely illustrates that, and you can see when you add preeclampsia to small for gestational age. And small for gestational age is something, again, we absolutely need to prevent by good maternal nutrition. So, and also increased risk of cerebrovascular events in women who have had hypertensive disorders of pregnancy. Look at this. Ischemic heart disease is higher, stroke is higher, venous thromboembolic events are higher, and mortality is much higher in these women. And women who have a recurrent preeclampsia versus non-recurrent, the risk is again much higher than in the women who have the recurrent PE. And one area of interest to us today, we are talking about women and diabetes. This hypertensive disorders of pregnancy increases the risk, number of times by which the risk of postpartum diabetes increases. That is also something for us to keep in mind. And preeclampsia and risk of cardiovascular disease and cancer in later life. This is a big systematic review and meta-analysis. And I just want to show you some of those data as well, because this is a very good meta-analysis that has been done. Let me just move this a little bit. So this is very important for us to look in terms of hypertension see this. Sorry. Non-fatal ischemic heart disease events in later life. You can see all of these are double or more, all maternal placental syndromes. And sorry, this is not moving.
Ma'am, press once on the screen, then try to move.
Pardon?
Click on the screen.
Click on the screen. Okay.
And then try to, yes.
Thank you, it worked. Okay. So everything is at least 2 times higher, and that is what I wanted to, really stress by showing this meta-analysis. Fortunately, and this is venous thromboembolism, early and late preeclampsia combined, again, at least 2 times or more. The one good news is cancer seems to be not particularly increased, and this is with preeclampsia, but we know with diabetes, cancer is much higher in in women with diabetes, 29% more in women with diabetes compared to women without diabetes. So what is causing this future risk? The mechanism underlying the relationship between hypertensive disorders of pregnancy in younger women and cardiovascular disease later in life is somewhat unclear, but could be explained by sharing of pre-pregnancy CV risk factors or to direct impact of hypertensive disorders of pregnancy on the cardiovascular system, conferring a state of increased susceptibility to future metabolic or hemodynamic insults. If so, the prevention of hypertensive disorders of pregnancy itself would become all the more urgent. And I think there what we have talked about so far about preconception care and care of children and care of pregnant women, so the cycle goes on. So, and they're vulnerable from the start because there is this cardiac remodeling that is happening to the women who develop preeclampsia. Now, I'm kind of coming towards the end of my talk to talk about what is it that we can do and what should we do in a lesson learned from Gdm pregnancies. If you see here, if the woman has Gdm and there is in her first pregnancy and then in her second pregnancy, and then what happens to her NCD risk and healthy diet, lifestyle, and body composition, preconception reduces the risk later. And then with each pregnancy, as you can see, their risk is going up. So we need to intervene before the first pregnancy. And if we have missed that window, at least we should intervene in the inter-pregnancy interval so that it influences the next pregnancy. Because if you don't do that, each pregnancy increases the risk considerably. So as I think I went backwards. So when you look at transitioning to postpartum care, even women who had severe preeclampsia, only 52% attended their 6-week postpartum visit and 21% were still hypertensive. So just like Gdm, this again is a very big problem in terms of postpartum follow-up, in terms of longitudinal care. I know that Professor Nikhil Tandon studies a little bit of a depressing and downer that major changes did not happen with glucose, but then we need to keep trying. Look at this one. Even in people who had the hypertensive disorder of pregnancy, the one who had the higher BMI had the cumulative incidence of hypertension was higher in them. So which means keeping the BMI down is helpful. Look at the physical activity. I know that Anjana will like this. If in the women who had hypertensive disorder of pregnancy and high physical activity, you see the red arrow, how much lower it brought it down. So physical activity helps all women. And we also should start looking at hypertensive disorder of pregnancy as a window into women's future cardiometabolic health. And all the traditional ASCVD risk factors, smoking and diabetes and obesity, physical inactivity, hypertension, dyslipidemia, we inquire about all this. But when it comes to women, I don't think when they have a CV event or they come in for any procedure or even for a master health checkup, we're not asking them about preterm delivery, hypertensive disorders of pregnancy, or Gdm or autoimmune disease, breast cancer treatment, depression, small for gestational age infants. All of these are the new emerging non-traditional ASCVD risk factors. And if we ask these questions, we probably will bring these women, keep them on a, I hate to use this, but a tighter leash and keep following them closely and do the mitigation that we need to do. And we really need to, follow this. So you can see ASCVD risk enhancer, they've now introduced conditions specific to women like preeclampsia, premature menopause, but that needs to come into practice and we need to be aggressive with these women. So in terms of prevention and treatment, when they have the problem, treating them and starting aspirin early, that's important. But prior PE, multifetal gestation, prior hypertension, diabetes, renal disease, autoimmune disease, these are all people who are at high risk and they need obviously to be in close watch. What does not benefit seems to be things like bed rest and fish oil and folic acid and garlic and all that. But potentially there are studies that showing definitely exercise helps. Metformin has some benefit, and pravastatin, there's data to show may be helpful in preventing PE. So that brings me to the end of my talk. And I think this is something, again, we need to bring into our preconception care model. And thank you so much.
Thank you so much, Usha ma'am, for that excellent talk. And I think when we talk of the key to NCD prevention, it's not only gestational diabetes, hypertension. I think it's important to focus on the preconception and the interconception period if we actually want to, stop the NCD load that we are all buried under. So thank you so much. I'll request you to stay back for the question answers at the end of the last session. And I'll now invite Dr. Shehla, my co-chairperson, to introduce our next speaker, Dr. Sunil Gupta, sir.
Ma'am, that was fantastic, Usha ma'am. It's always a pleasure listening to you. And it somehow always feels like music to my ears. I love listening to you and I love learning from you. Thank you very much for that fantastic lecture. And it gives me great pleasure to introduce none other than Dr. Sunil Gupta. Other than everything which I'm going to talk about him, a close friend. We work together on his diabetes education programs, a very, very socially motivated person, if I'm allowed to say that, with fantastic patient outreach. So he's also the National Diabetes President, National President Diabetes in Pregnancy Study Group. We all know that, DIPSI 2021 to 22. The National Treasurer, RSSDI 2019 to 2022, with a number of rewards. The Outstanding Young Person of the World 2002 Award in USA. In the Guinness Book of World Records, Limca Book of Records, number of awards. If I go into all the awards, I'll end up not having any time for the actual lecture. So yes, a PI for a number of trials, number of awards. It's a great pleasure to listen to Dr. Sunil Gupta. Over to you, Dr. Gupta.
Thank you, Shaila. I'll just take, thank you for your warm introduction. I'll just take 30 seconds to upload my slide. Yes, here it is. Hopefully they're visible and I'm audible to everyone.
Yes, they are.
Yes.
Thank you very much, everyone. My today's duty has been made very difficult by Dr. Beni and Dr. Neglur sir. The talk today is hypoglycemia and diabetes during pregnancy, how low we can be. I'm trying to, of course, thanks to everyone, the Wodcon team and everyone who's here. There's no conflict of interest for the session. Now, this topic, as I told you, is going to be a little tough for every one of us because there are very rare occasions that we talk on this particular topic in pregnancy diabetes. We are more focused on the clinical diabetes or clinical part of the glycemic hyperglycemia in pregnancy. But I feel one should know that this is one of the most important clinical part of diabetology in pregnancy or diabetes in pregnancy. So we will have some slides on introduction, hypoglycemia in GDM. We have some data for pregestational diabetes type 1, some data comparing type 1 versus type 2. One important data coming out with the hypoglycemia in different trimesters and the risk factors of hypoglycemia and prevention and the carry home message. The greatest limiting factor in diabetes management is none other than the hypoglycemia, whether it is pregnancy, whether it is non-pregnancy, whether you talk about type 1, whether you talk about type 2, whether you talk about secondary diabetes, whether you talk about pregestational type 1, pregestational type 2, or even GDM. Hypoglycemia is one of the major concerns, and most of the OBGYNs have a lot of phobia and fear about hypoglycemia, despite knowing that though we have data which says that hypoglycemia is of concern, but still somehow the GDM women have quite a high threshold for hypoglycemia. They sustain hypoglycemia, and few of the trials, which are landmark trials in diabetes and pregnancy, have shown that hypoglycemia is not a major concern and things need to be still clarified further. To introduce the topic, in pregnancy, maternal plasma glucose levels have a direct relationship with the adverse neonatal outcome. Uncontrolled hyperglycemia is associated with maternal adverse event. We have heard from both the key speakers before me, and also related to perinatal outcome. Optimal glycemic control in women with hyperglycemia in pregnancy is essential to prevent these complications, but hypoglycemia is an important complication, particularly in those women who are on insulin therapy. If the fasting is between 60 and 90, it may increase the risk of hypoglycemia. However, the effect of maternal hypoglycemia in pregnancy is not very clear. Hypoglycemia is more frequent during pregnancy versus non-pregnant women, and occurs almost up to 70% of the pregnant women who require insulin. Plasma glucose during pregnancy are almost 20% lower in normal pregnant women, that is non-diabetic pregnant women, versus in their own women with GDM, as well as in diabetes pregnancy versus non-pregnant state. That means when you become pregnant, irrespective whether you are normal pregnancy, GDM pregnancy, or diabetes in pregnancy, your plasma glucose is going to be almost 20% lower, because your baby is continuously being fed and the mother is being fed intermittently. That is why especially fasting blood glucose is almost 20% lower versus in the same woman before the pregnancy. When we talk about normal glycemic profile in a non-diabetic pregnant woman, let us see how much it is. Traditionally, we say that 70% hypoglycemia in pregnancy is defined as a blood glucose as less than 60 or less than 63 with typical symptoms of hypoglycemia. That's how we traditionally define hypoglycemia in pregnancy. And what is here in our plate today is the fasting on an average through a study from Yojev almost to 15 years from now. Fasting never exceeds around, mean is around 62 or so, 75 plus minus 12. Mean blood glucose is total overall is 85, pre-meal 78, 1 hour 97, 2 hour never exceeds 105 plus minus 13. While the recommendation is less than 95, which I feel is very high for fasting, it should be DIPSI as well as other recommendations says less than 90. Mean blood glucose should not exceed 105. 2 hours should not exceed 120. This is another data which was published in 2021, where they have seen fasting is around 70, 1 hour 109. Mean blood glucose in non-pregnant state is around less than 100, 24 hours is 88, almost the similar profile as Dr. Yojev's data says. Neonatal hypoglycemia, when your blood glucose level is less than 30 milligram in neonates in first 24 hours, it is neonatal hypoglycemia. Of course, we are not going to talk on that. So when we talk about hypoglycemia or glycemic control in pregnancy, we have both the ends. At the extreme end, we have maternal hyperglycemia responsible for the, I'll just take the laser pointer also here. Yeah. The maternal hyperglycemia causing fetal hyperglycemia, causing fetal hyperinsulinemia, pancreatic hyperplasia, which is responsible for adult onset diabetes. We have heard this. Maternal hypoglycemia, if you have fetal hypoglycemia, pancreatic hypoplasia, again may be responsible for adult onset diabetes. So maternal hyperglycemia as well as maternal hypoglycemia, both of them are equally at causing a risk for type 2 diabetes in the adult life. And that is why we try to achieve blood glucose. The recommendations is fasting should be less than 90, HbA1c should be less than 6.1, and a 2-hour blood glucose should be less than 120. Most of the evidences have actually supported this document or this recommendation. There's a new terminology while going through the literature which we come across, and many of you must be listening this terminology for the first time, is masked hypoglycemia. Masked hypoglycemia is defined as the interstitial glucose coming from CGM level less than 50 milligram for more than 30 minutes without symptoms, which is detected through CGM. It has been observed in women with GDM, also treated with GDM also treated with insulin as pregnant women without GDM. More than 90% of the hypoglycemic events were nocturnal hypoglycemia. So masked hypoglycemia blood glucose going below 50 for more than 30 minutes. And it has been shown that most of them they are coming in the nocturnal time, that is after 11 and before 6 a.m. So this masked hypoglycemia, the reported prevalence is around 35% to 40% in such women. And we have to also take it into account that masked hypoglycemia may be one of the reasons which remains undetected because we don't do self-monitoring of blood glucose in such cases. Hypoglycemia is more, it has been hypothesized that hypoglycemia during pregnancy can potentially induce the adverse events that lead to fetal malformation. How dangerous it is? So it can cause fetal malformation in the first trimester, small for gestational age babies, poor neuropsychiatric development. The association between the level of hypoglycemia and diabetic embryopathy remains still uncertain. However, the historical studies like HAPOS or the ECOIs have not addressed the risk of hypoglycemia as one of the important effect on the pregnancy outcome. And the reported incidence of hypo varies in different parts. We have seen it is up to 35 to 70%. CGM data, now continuous glucose monitoring in pregnancy, has also come out with a focus on the magnitude, the duration of glycemic variability, the frequency of glucose fluctuation, which again has further actually emphasized on an earlier hypothesis. But when you get an unexpected fetal outcome, in that situation, even if the HbA1c is normal, even if your self-monitoring of blood glucose readings are normal, you might be having an undetected masked hypoglycemia or increased glycemic variability. In such cases could be the cause. Asymptomatic hypoglycemia with longer episodes are occurred in women with HIP treated with insulin. Masked hypoglycemia is diagnosed with less than 50, at least 30 minutes that I told you. Hypo were occasionally observed mid-morning and before dinner, so mainly in the nocturnal time. In addition, in women on insulin therapy, 40% had masked hypoglycemia and 10% on these women had hypoglycemia less than 40 milligram also, suggesting that the lower threshold for developing hypoglycemia. This is what I told in my introductory statement, that the threshold during pregnancy goes down. And CGM data has said that almost 40% has less than 50 masked hypoglycemia, but 10% of them even have gone below 40. The implication of this low fasting glucose levels in pregnant women without the HIP, it may need to have a research in the population. Severe hypoglycemia could have serious consequences, especially while hypoglycemia can be have embryopathic effects in rodent, no data on human side. Insulin-induced hypoglycemia in the last trimester may increase the fetal body movement and decrease the fetal heart rate variability. Relative hypoglycemia, that is low fasting blood glucose and a flat glucose tolerance test, frequently seen in even normotensive patient with women with having IUGR. Now, in retrospective pilot study, it was found that hypoglycemia was linked with greater number of special care or neonatal intensive admissions, high significance in number of women who develop preeclampsia. Hypoglycemia was increased in women who have less than 25 with pre-existing medical conditions, younger age women. Hypoglycemia was decreased in pregnancy was low in patients who were obese. Eclampsia was more common in hypoglycemic women. That means if you have a vasculopathy, if you have a preeclampsia, in the situation hypo is more common. So hypo patients are younger, have reduced pre-pregnancy weight, lower BMI, are more likely to develop preeclampsia than the normoglycemic women. However, study was limited as far as the design is concerned. Now, for this particular discussion, we have come to a conclusion or a understanding of the concept that in type 1 diabetes, we try to achieve intensified insulin treatment, try to achieve fasting less than 92 or less than 120, HbA1c less than 6. Now they say 6.5. If hypoglycemia is a concern, we say up to 7 is acceptable. So intensify insulin therapy, which increase the risk of hypoglycemia. Decrease in the hypoglycemia unawareness in type 1 diabetes, a big concern. Hypoglycemia unawareness and glycemic variability, all of them may become a risk to the baby if not being taken care properly. So risk indicators, what are the risk factors which have been identified in type 1 diabetes? The paper published in 2002 in Diabetes Care. If you have a history of severe hypoglycemia before gestation, I feel we are aware of this. Those who are having hypoglycemia unawareness and subsequent hypoglycemia further deteriorate the threshold. Duration of diabetes of more than 10 years, higher daily dose of insulin, and if your HbA1c is less than 6.5, these are the risk indicators for developing severe hypoglycemia in type 1 diabetes. There's again a data of gestational diabetes. There's a retrospective data around 500 GDM women on insulin or on oral drugs. And they have done weekly SMBG, and it was recorded in retrospective data collection. Higher rate of composite neonatal outcome in those who were exposed to maternal hypoglycemia, and composite neonatal outcome, which was macrosomia, neonatal jaundice, RDS, LGA, shoulder dystocia, neonatal hypoglycemia, and they have been compared with the women who did not develop hypoglycemia. It was found to be higher in those who had hypoglycemia, the neonatal outcome, versus those women who did despite they had on insulin, they were on oral drug, but they did not develop hypoglycemia. And this again a data which is shown on almost on the same line. What about the hypoglycemia what happens exactly? This is one of the another data which is very, very important, and is something new for all of you. The impaired hormonal counter regulation is a common feature in pregnant women with type 1 diabetes. The blunted glucagon and adrenaline responses during clamp hypoglycemia have been reported in diabetic pregnancies compared to non-diabetics, non-pregnant control subjects, and may render the pregnant woman more dependent on the second line defense mechanism like growth hormone or the cortisols if you don't have enough glucagon or adrenaline available. So growth hormone has well established hyperglycemic and insulin antagonistic properties and may exert its glycemic effects directly or indirectly by insulin like growth factor 1, IGF-1. In pregnancy, the maternal placental growth hormone levels increase and gradually replace the pulsatile pituitary growth hormone production. And from 20 weeks, the pituitary growth hormone level decreases and remains at a minimal level by the end of third trimester. Unlike pituitary growth hormone, the placental growth hormone secretion is continuously increases, which permits the analysis of random blood. It can be seen in random blood samples. The placental growth hormone is thought to be responsible for the pregnancy-induced increase in the maternal IGF levels, which peaks at approximately 37 weeks. And this is what we see in the normal pregnancy without diabetes. But what happens with diabetes is the IGF levels are significantly lower in women with type 1 diabetes, and this lowest in the early pregnancy when the incidence of severe hypoglycemia is highest. So if you have, because of the counter regulatory effect, because you have poor response to the growth hormone, poor response of the poor level of IGF level 1, you are type 1 diabetes with possibly known autonomic neuropathy or dampened glucagon response, adrenaline response. They also have growth hormone response which has been impaired, and you have poor IGF level, might again be responsible for higher incidences of severe hypoglycemia in these type 1 individuals. What about the how do you safeguard these patients in type 1 diabetes? If you use preconception aspart insulin or maybe lispro insulin, there's data coming from aspart insulin, so insulin analog. That insulin analog, if being started preconceptionally rather than during pregnancy, may result in lower risk of severe hypoglycemia in type 1 diabetes. So if you choose proper insulin, possibly it will be able to save these patients. Insulin aspart is at least as safe and effective as human insulin when used in the basal bolus therapy versus NPH insulin, and may potentially offer some benefits in terms of postprandial glucose control and preventing severe hypoglycemia. This data which is coming from aspart. Similarly, basal insulin, if you go for the insulin like Detamir, which has been approved, the only analog which has been approved formally versus NPH insulin, again you might save this patient from nocturnal hypoglycemia. Does hypoglycemia following a glucose challenge test? This is another entity which I feel newer for all of us. The hypoglycemia, you are talking about non-diabetic pregnancy. You have done the GCT test in these women or OGTT test, and the women develops after taking glucose, they become their blood glucose less than 70. And they have shown the following: a 50-gram oral GCT were matched with the next patient with 1 hour blood glucose between 88 to 140 and less than 180. And the preeclampsia was more common in such hypoglycemic women. So hypoglycemia following a glucose challenge test again increase the risk of preeclampsia. Now, pregnancy outcome of women with hyperglycemia and oral glucose tolerance test. Again, the same data which says less than 70 measured in 75-gram glucose associated with lower birth weight, small head circumference, and short body length in newborn compared to, so not only the diabetic women, but also non-diabetic with postprandial post-glucose challenge hypoglycemia may be a risk factor. Women with type 1 diabetes spend more time in hypoglycemia than women with type 2 diabetes. If you compare type 1 versus type 2 episodes and spending 3.5 hours with the glucose less than 70 versus around 1.8 episode and around 2.5 hours. So type 1 diabetics, they are for a longer duration than hypoglycemia versus type 2. Although women with type 2 spend less over time hypoglycemia, their risk of nocturnal hypoglycemia is almost similar. Women with type 2 diabetes spend almost 33 times lesser time in hypoglycemia versus type 1 diabetes. What about the trimester-based effect of fetus on fetus? Animal studies indicate that hypoglycemia occurring early in pregnancy may be teratogenic. Recurrent hypoglycemia leads to blood glucose fluctuation into hyperglycemic range despite excellent HbA1c control. Hypoglycemia in third trimester may be indicative of fetal distress. What about this is very important when you talk about hypoglycemia and understanding the insulin physiology. In early pregnancy, there's enhanced insulin sensitivity, and that is why in first up to 12 weeks or 14 weeks of pregnancy, there's high risk of hypoglycemia. Many women with type 1 diabetes will have to lower their insulin doses in the first trimester to avoid hypoglycemia. Around 16 weeks onward, the insulin resistance begins to increase. Total insulin dose will increase from 5% per week up to 36 weeks, and almost doubling of the insulin dose requirement at the time of term. The insulin requirement level off towards the end of the third trimester, where the placental actually gets because of placental aging. And if there is rapid reduction in the insulin requirement, may be a sign of a placental insufficiency, and sudden hypoglycemia any time during the follow-up of a case might be an indicator of fetal demise, and we should be taking this case as emergency. The insulin sensitivity then returns to pre-pregnancy level in the postpartum within 1 to 2 weeks. It does not get returned to a pre-pregnancy level immediately in 24 hours or so. It takes some time, 1 to 2 weeks. And that is why you should not go back to the pre-pregnancy level of doses of insulin. Rather, you should be giving almost 50 to 70% of the pre-pregnancy doses. In women taking insulin, particular attention should be directed to hypoglycemia prevention in setting of breastfeeding. Breastfeeding is directly proportional to the risk of hypoglycemia. So breastfeeding causes hypoglycemia, and erratic sleep and eating schedule further deteriorates this. Lactation can increase the risk of overnight hypoglycemia, and insulin doses may be accordingly adjusted. Mild hypoglycemia can be treated with the rule of 15. Just give 15 grams of glucose, wait for 15 minutes, again recheck it. Simple way. Moderate hypoglycemia may need some sugary drink, and severe hypoglycemia need medical attention. All pregnant women should be learned to manage their diabetes. They should learn to count calories, carbohydrate. Early recognition of symptoms is important for prevention. In view of nocturnal hypoglycemia, very important statement, you should suggest that pregnant women take adequate snacks, maybe protein-rich snacks before sleep to prevent nocturnal hypoglycemia. Frequent monitoring is must, education is must, use of analog possibly will save them. Use of CGM real time may help if they're on pump therapy. So finally, if I want to conclude this, glycemic control in diabetes pregnancy is tighter, always better. Unfortunately, we don't have any concluding statement at this moment of time, but this is the author, what he has concluded here is, with all its advantages in terms of maternal and neonatal outcome, uncompromised stringent glycemic control with normalizing of glucose values in the pregnant women with diabetes may not always be the optimal strategy. The observation that low mean glucose values are associated with an increased risk of fetal growth retardation raises concern that nutritional deprivation may have long in the short-term detrimental effects on the fetus. Adjusting target of glycemic control in accordance with the magnitude of the risk need to be considered before we decide about the targets and before we be aggressive for treatment. To conclude, hypoglycemia during pregnancy is not uncommon among women with GDM, women with type 2 diabetes with pregnancy, as well as type 1 diabetes. More common in the first trimester and later in the third trimester. Education of women in terms of early recognition and prompt corrective measures is must. Modifying anti-diabetic therapy appropriately is important. Maybe switching over to analogs. I have not added glibenclamide, and because it is not being approved in Indian context, but glibenclamide, which is a sulfonylurea, the only sulfonylurea which has been approved for its use in pregnancy, again may increase the risk of hypoglycemia versus when you talk about metformin. Prevention of recurrent hypoglycemic episode will have an effective effect on improving maternal and the fetal morbidity. So if you prevent recurrent hypoglycemia, as we know that hypoglycemia unawareness get exacerbated if you increase if there are recurrent episodes of hypoglycemia. This may again prevent the risk of severe hypoglycemia in type 1 diabetes as well as those type 2 or who are or GDM who are on higher dose of insulin. I feel with this I stop here. Thank you very much for patience listening.
Thank you very much. I think this was a mind-boggling session. And we have so many pearls to learn from. I have a small question for Yagnik sir. Yagnik sir, is he here?
Yes, ma'am.
So, sir, I think you have given us breaking news because for the first time we know that altered tolerance to glucose can happen in the preconception stage as well. And we are actually, and Madam Usha has really, stressed on the preconception stage, and she has imparted this information to all of us, saying that as soon as a young girl comes into the consulting room, and especially a married one, the first thing you should ask is, are you planning for pregnancy? She may come for whatever reason. And I think this is the right thing to do. Ma'am, thanks for that. But I want to ask Yagnik sir, any data on PCOS patients? Should we manage them with metformin because they're already in the insulin resistant state? And also, since they will get pregnant in future, and you have told us that glucose tolerance can get altered in the preconception stage, I don't know, I think Dr. Usha and sir can give their comments on this.
Okay, see, now we have national level data available on pre-diabetes in children. If you see that CNNS report, the Comprehensive National Nutrition Survey, that actually validated what we found in Pune Maternal Nutrition Study. In Pune Maternal Nutrition Study, we showed that at 18 years of age, 30% had pre-diabetes, and that CNNS shows between 5 to 10 years, there is 10 to 15% pre-diabetes, and between 11 to 19 years, it's even high. And there are pockets in the country which actually are the areas which are traditionally undernourished or with some other difficulties where this seems to be high, especially in Northeast. So the glucose intolerance as defined by current criteria is quite common even in children. And therefore, it's not that we should go backwards, we should go forwards. And therefore, checking glucose in children and adolescents should be part of whatever health surveys we are doing, either for health check in the school or at the community social gatherings or something. Now, that needs a bit of an organization. We also need to develop cut points. We also need to take family history. We need to take height and weight. Now, the whole attention in diabetes pregnancies is concentrated on obesity. Yeah, I mean, that's true. Everyone wants to talk about obesity. In Pune maternal nutrition study, at 18 years, 50% of these people were underweight, BMI less than 18.5. In the pre-diabetic boys, 1/3 of them were underweight. And amazingly, in the pre-diabetic girls, 2/3 were underweight. So obesity is an entirely non-existing risk factor for them. And we have been basing all our policies based on the Western suggestion that type 2 diabetes in the young happens in the obese people. Please read our paper in Diabetologia about clusters of type 2 diabetes in those who were diagnosed before 40 years of age. And 60 to 70% of them were severely insulin deficient diabetes. Therefore, the pathology in our people is severe insulin deficiency. We have a strong evidence that the beta cell response to prevailing insulin resistance is abnormal right from 6 years of age. And unfortunately, we were not able to measure pancreas in utero, but we have measured liver and kidney in utero in the babies when their mothers were pregnant with them between 1993 and 96. I haven't published that paper, it's being written up. Smaller liver growth in the 3rd trimester is a strong risk factor for prediabetes at 18 years of age. And Usha, you will be happy to learn smaller or slower kidney growth was strongly linked to blood pressure at 18 years of age. Again, first time anywhere in the world, human data of slow organ growth in the 3rd trimester predicting 2 common risk factors, glucose intolerance and hypertension. PCOS is again an added risk factor. We again talk of PCOS, obesity, insulin resistance. And then everyone writes that so many percentage of our PCO are not obese. So my first take-home message was it's time to think. And I think if we put together 5,000 PCOS girls across different centers and study them intensively, I think our understanding will be very different than what the textbooks are saying. PCOS again is thought to arise out of excess androgen exposure in pregnancy, that's in utero. And therefore, concentrate on preconceptional and in utero life and pay less attention to diagnosing GDM and hypertension in the 3rd trimester of pregnancy. I think we will do a great service to the next generation.
Thank you, sir. Madam, yes.
I just want to add one sentence to this. I think this absolutely, what can I say, crystallizes what I wanted to say. As far as PCOS and metformin, we absolutely must be sure we are using it only in people who have any degree of glucose intolerance only. We have to become metformin minimalists, especially because these girls and our mothers are underweight. And we put them on metformin, the babies are going to get smaller. And there is a secular trend and we are seeing that. So I think there are lessons from what Dr. Yajnik has told us, that we must be super careful about not over-treating moms with medications that could make them not gain enough weight and the babies get even smaller. So
yeah, Usha, only for those paper from Trandenheim in this thing, that lady who treated PCOD with metformin, followed them through their marriage and pregnancy and showed bad outcomes for non-communicable disease in their children. I just forget her name. She's a friend, but I just forget her name. Lady from Trandenheim. So there is evidence that if you are giving metformin, there might be trouble. Again, does it happen in everyone? Or there are, like say, risk factors for that toxicity also? Now, she came to me because she thought B12 might be the connection. By treating with metformin, it might produce B12 deficiency. And I had written about B12 deficiency in mother being a risk factor for insulin resistance in the child. So that's how she came to consult me. She was going to measure it. She hasn't as yet measured it, but there is a flag for metformin use.
So the thing is, how we diagnose the glucose intolerance is where we are getting into trouble. See, people are doing insulin levels, HOMA IRs, AO. We shouldn't do all that. Only a 75 gram, GTT, and look at the 2-hour value and actually then peg them as pre-diabetes or diabetes or normal. If we do the other things, fasting insulin and all that, we are actually doing a disservice to the girls.
Yeah, Usha, 75 grams is for those who are beyond whatever, 38 kg. In the PMNS, we use weight adjusted OGTT at 6 and 12, so 1.75 grams. Amazingly, the editor of Diabetes Care questioned me on that. So then I had to be a bit rude and actually answer. So on one hand, they want to follow scientific thing, but he wanted same glucose load for 6 as well as 18 years. How is that possible? So I think we need, that's why we need to think a bit more about it, that we need to concentrate on children and especially young girls to detect metabolic abnormalities in a simplistic manner, which will define their risk of future problem. And for me, measuring fasting glucose at 6 years actually predicts 70% risk of being pre-diabetic at 18 years. It's there in the Diabetes Care paper, which we published a few months ago. It's in December issue of 2021.
Thank you, sir.
And
Dr.
same
Sunil.
thing for blood pressure. Again, we apply adult criteria, and even in children, the impaired glucose tolerance and IFG are criteria from adults. And just now we can't get rid of them. And that's why I have done a continuous analysis by dividing them into quartiles rather than sticking to any particular level.
Thank you very much, sir. I think in the interest of time, we will move on to the next session. Extremely good talks by Professor Yajnik, Madam Usha, and Dr. Sunil Gupta. I'm sorry we have so many questions to ask you all because you'll have so much of experience, but there's shortage of time. And I thank the chairpersons as well, Dr. Anjana, Dr. Shalini, and Dr. Shaila Sheikh. Fantastic session. So now we move on to the next session. Ami, can we introduce?
Yes, ma'am. So moving on to the next session on first cry, I invite our chairpersons, Dr. Usha Sriram, who was the founder of Divas, Dr. Sunil Gupta, both of them we just heard with fantastic talks, and the part of our core committee, Dr. Purvi Chawla. I request Dr. Usha Sriram to kindly take over, ma'am.
What an incredible honor to be able to introduce my friend, Dr. Rajiv Chawla, who has held some very, very important posts and done great work, past chairman of the RSSDI Delhi chapter, past secretary of RSSDI national body, and he was the immediate past president of DIPSI and the immediate past president of RSSDI, has done incredible amount of research and work, and I'm delighted that we get a chance to listen to him today on a very important topic that is not addressed usually on lipids. Dr. Chawla.
I'm not able to put it to slideshow on the issue.
So the icon below.
I'll just stop sharing and share again. There is some problem with the. Yeah. Yeah. Can you see the slides now?
Yes, sir. Perfect.
Yeah. Good morning, everyone. All wonderful celebrities around. It's a great pleasure to be part of this very, very sought after conference year after year. Thanks, Dr. Benny, close friend, Dr. Naglur, and thanks, Dr. Usha, for those kind words. And at the outset, I'll say that, Dr. Benny, it's a good job which you has done to me, because you've given me a topic which is very, very unusual. For the first time, honestly, I read this topic and realized that unfortunately there are no guidelines yet by any organization which have alluded to anti-lipid therapy in pregnancy. So whatsoever I could gather was from various cohort studies, and I'll put it straight for the prudence for all of you to take a decision and try to do justice to the topic: roadmap to anti-lipid therapy in pregnancy. So flow of my session will be first to take you through the lipid metabolism in normal pregnancy, hyperlipidemia which exists in insulin resistant states, especially obesity, gestational diabetes, and diabetes mellitus, how placenta transfer of lipids and nutrient happens, the effects of maternal dyslipidemia, not only on maternal, but also on neonatal and fetal future outcomes. And towards the end, the topic was, in fact, to treat or not to treat and roadmap for that. In the end, I like to sum it up by giving you certain therapeutic options towards that. So we all know pregnancy is a unique physiological state in which the necessary metabolic changes must take place in the mother for an adequate fetal development and growth. So it is through energy reserves which are built during the pregnancy. Glucose is quantitatively, of course, the most important nutrient, but never forget amino acids and the role of free fatty acids for fetal nutrition and development. During the first 2/3 of gestation, there is an increase in mother fatty deposits thanks to hyperphagia and increased lipid synthesis through increase in lipoprotein lipase activity. And in the second and third trimester subsequently, LPL activity decreases, and there is a lot of lipolytic and catabolic activity caused by insulin resistance. Again, it should be viewed upon as a physiological mechanism. It leads to decrease in maternal fat deposits, and there is going to be an increase in triglyceride level towards the end pregnancy. So let me take you through the lipid metabolism. Well, this diagram again seems very, very complex, but to put it very, very simple, we know diet constitutes almost 90% of the cholesterol pool, and it is transported as chylomicrons, which are micellized fatty acids with bile, and these are absorbed through the intestinal villi, and it is acted upon by immediately by LPL, taken into the liver. From there, there is a sense of triglyceride and VLDL, which are released into the circulation. Well, LDL goes and gets attached to its receptor. It is the HDL which takes back the remaining cholesterol and brings it back to the liver. That is how a cholesterol mechanism and a normal lipid metabolism is seen in a normal person who is irrespective whether pregnant or non-pregnant. Moment there is a pregnancy, we know normal pregnancy is a hyperlipidemic state, which is primarily influenced by increments of estrogen. So with every rise of estrogen across the pregnancy from first trimester towards the end pregnancy, there is going to be a progression of pregnancy reflects the changes in lipoprotein, and these are very clearly depicted here. You could see as the pregnancy is evolving, estrogen levels are going on high, and so is the dyslipidemia keeps worsening. Again, a very complex diagram, but to put it simple, that it is the sex hormones or sex steroids which have a very, very important role on lipoprotein metabolism. The synthesis and utilization of cholesterol is very, very highly regulated. It's a very, very dynamic bidirectional phenomena. In excess, it is immediately deposited along with the arterial walls, leading on to atherosclerosis. But minded lipid metabolism simultaneously is also regulated by hormones like adrenaline, glucagon, insulin, as well as steroid hormones to keep it within the normal range during the pregnancy. So if you look the mean 10th to 90th percentile values for triglyceride and cholesterol in normal pregnancy, I told you triglyceride are going to worsen as is that there is going to be an increase in estrogen level and insulin resistance, which toward the end, I told you triglyceride will go high. So is the cholesterol. So the most consistent lipid change in all studies which have been seen is the level of triglyceride, which may show almost a 200 to 300% rise as compared to the pre-pregnancy level. towards the end pregnancy, almost near 35th weeks of gestation, and total cholesterol also increases at least by 30%. These are the mean values of VLDL, LDL, and HDL in normal pregnancy. So VLDL and LDL, I told you, increase parallel to the estrogen, while HDL shows a triphasic pattern. You could see that in the first trimester, actually there is an increase in HDL level. Subsequently, towards second and third pregnancy, then there is a dip. So it becomes something like a triphasic pattern of HDL levels. The increase in lipid metabolism actually add adaptation to increase delivery to the fetus. That is what I said in the beginning. It's a physiological change which is happening to increase the nutrients towards the fetus through the placenta. So lipid subtractions, fortunately, are maintained during the pregnancy. So it is a physiological adaptation for mother to protect herself also simultaneously from dyslipidemia. In certain women, well, those who have an inherent dyslipidemic predispositions, or those who had an altered pro-erythrogenic lipid profile even before pregnancy, or maybe it is dependent on the age of gestation, pre-lipid values, especially the triglyceride level and their body weight also. So everything taken together, body tries to keep this lipid subtractions within the normal range so as not much damage is done. So again, showing you the HDL having a triphasic pattern. In the first trimester, you see there is an increase in HDL level. Subsequently, after 16th week, it starts falling, and toward the end, HDL levels are a little lower or almost same what you have seen in the pre-pregnancy state. So to sum it up, physiological lipid metabolism in pregnancy, it shows triglyceride increase by almost 200 to 300%. Total cholesterol increases by almost 30%. LDL increases by 44%. HDL, I already told you, it follows a triphasic pattern. The inherent adaptation, again, emphasizing the same thing, is to self-regulate so as to self-protect against any atherogenic lipid profile or cardiovascular event which might otherwise happen in pregnancy. But unfortunately, in females, those who are obese, those who are already having GDM, or those who have already pre-established or pre-existing diabetes, their insulin resistance is at worst, and they are the one who are even likely to have poorer lipid and dyslipidemia. So moment there is an increase in insulin resistance or fall in insulin sensitivity, you will realize that there is going to be an increase in levels of free fatty acid. That is how, as the pregnancy grows, estrogen and progesterone increase, there is going to be an increase in insulin resistance, which increases free fatty acid levels and subsequently also the triglyceride towards the end pregnancy. So basal triglyceride, if you compare before pregnancy, during early pregnancy or late pregnancy, there is going to be a huge change in levels of basal triglyceride, more so in overweight females, because it is then directly dependent on their level of BMI. And so is also seen in obese females. They are at worst, in fact, in terms of having triglyceride level from early pregnancy toward the end pregnancy, because these levels are going to be extremely important. That is why I said that there could be maybe an increase of triglyceride by almost 300%. But well, these lipoproteins, lipoprotein concentration in women with GDM and normal glucose tolerance, again, if you try to compare them, GDM versus control, fortunately, GDM females, they have lower LDL levels as compared to the control group. It is the triglyceride levels which are very, very high in those females, those who have either GDM, pre-existing diabetes, or obesity, or they are overweight as compared to the control. So overall LDL HDL ratio in GDM may be actually lower as compared to the control because of lower levels of LDL. Again, a very complex diagram, how a hypothetic model of lipoprotein lipid transport across placenta could be suggested. I told you from the diet intake, there are going to be chylomicrons, which are going to be taken up by the LPL. It enters into the liver. There is going to be an increase in levels of both VLDL as well as triglyceride, and these are taken into the circulation. HDL takes back the remaining cholesterol into the liver for this to be transported across the placenta. And we know that placenta allows only a free entry of free fatty acid. Triglyceride actually are not directly transported to the fetus. So to put it simple, the flux of nutrients across the placenta is determined by many placental as well as extraplacental factors. Uteroplacental as well as fetoplacental blood flows are directly being determined by both placental as well as extraplacental factors. So this influences overall blood flow on flux along with nutrients, and this can be very well studied by ex vivo perfusion also. So you could see that from the maternal fetal flux, placental morphology and structure is going to be defined. It will also be dependent on the placental consumption of these nutrients and the number and intrinsic activity of trophoblast enzyme receptors as well as transporters. So here is maternal fetal barrier for glucose as well as for the lipid transport. These maternal nutrients, we know glucose and lipoprotein bound lipids are transported through the placenta by different mechanism. It is not the common mechanism for glucose as well as for lipoprotein bound lipids. Transport of glucose is obviously by glut. So it is being regulated only by maternal fetal concentration gradient. That is how we know that higher is maternal hyperglycemia, more it is going to impact the beta cell growth into the fetus. But VLDL and LDL, they bind to their respective receptor. These are LDL receptor related protein 1, LRP1 and LRP2, from where they get attached into and then get transported through the placenta. So mind it, if you have a persistent dyslipidemia or hyperlipidemia, which is physiological in pregnancy, but I told you certain situation, if mother is already having obesity or is overweight or is having a pre-existing diabetes or GDM, this dyslipidemia is going to worsen. And then these mothers are at a very high risk for developing preeclampsia because lipid peroxidation products are going to be high. So placental vessels will have atherosclerotic-like changes with foam cells and fibrinoid material getting deposited into the placental vessels. We are not talking about coronary vessels, into the placental vessels, increasing the risk of preeclampsia. Not only that, there are higher endothelial levels also. So lipids on an average are going to be 1.5 to 2 times higher in these females as compared to a normal pregnancy with preeclampsia. Moment you have preeclampsia, these females are at a greater risk for future cardiovascular disease, maybe stroke, maybe metabolic syndrome. And worst thing is, if you have very, very high triglyceride levels, this can lead on to pancreatitis. Not only it can induce pancreatitis into the mother, but it can also have lethal outcomes even for the fetus also, because it is not only mother who is going to get affected. I told you the utero-fetal transport across the placenta, that is also going to get affected moment there is a persistent high triglyceride levels, the transfer of free fatty acid levels, and a persistent dyslipidemia in pregnancy. So fetal growth in GDM and in overweight obese women not only is going to affect the mother, but it is also going to affect overall child anthropometry. And this has been beautifully depicted in this roller study, which recently got published. In this present study cohort, maternal blood lipid concentration in late pregnancy and in cord blood were associated with offspring anthropometry, which is very, very important to understand. So it is the maternal triglyceride concentration which are going to be associated with birth weight, and HDL will have an inverse relationship. If you have a higher HDL level, birth weight will not be high. But if you have persistent hypertriglyceridemia in the mother, this is going to impact the weight of the baby also over 6 months of age also. So there is a need to establish a recommended healthy blood lipid concentration during pregnancy, which unfortunately has not been yet defined till date. But I think there is a huge potential to modulate infant body composition by altering the mother's diet during pregnancy. So it becomes very, very important. Not only it is hyperglycemia which we need to address, we also need to address the lipids in that female so as to address the anthropometry into the child, because the risk for large for dead baby or gestational age with large weight is going to be again having a direct relationship with hypertriglyceridemia, fasting plasma glucose in the mother, pregnant mother's BMI, as well as maternal weight gain. All these are going to have a direct relationship with the large for gestational age neonate which is going to be born. So premature births are also not very unusual. It is not only that they will be large for dead, but even premature births might happen if there is a persistent dyslipidemia with cholesterol more than 220 or triglycerides simply more than 140. And mind it, usual average triglyceride in a pregnant female towards the end of pregnancy are as high as more than 300 milligram %. So future cardiovascular risk could also be defined by looking into the maternal lipids, because these fetuses are at a greater risk for developing atherosclerosis, because certain studies have shown that there will be fatty streaks which are present in the fetal aorta, which are related to the maternal hypercholesterolemia. And again, this study, fate of early lesion in children, a phallic study got published in Lancet as early as 1999 with 156 children, those who were followed till a age of 13 years. It was the atherosclerosis progress which was faster in those who were born to a mother with persistent hypercholesterolemia during pregnancy. So this established the hypothesis as early as 2000 that lipid levels exert a constitutive changes on gene expression and arterial lining and influence later on to have CVD in these adolescents. So it is not only maternal hyperglycemia which can lead on to NCD, but a maternal persistent hypercholesterolemia can also make difference in overall outcomes in these units as they grow towards adolescent and young age. So let's have a look towards and on lipid management during pregnancy. It has to be again a pre-pregnancy counseling. We must address to overall atherosclerotic cardiovascular disease before she conceives, and there has to be huge amount of awareness. As Dr. Usha and Dr. Yagnik sir also said, we need to again focus on pre-pregnancy counseling. We must emphasize on healthy lifestyle, weight management, and a good diet. Moment these females they get pregnant, again they require an appropriate prenatal care and appropriate treatment of atherosclerotic cardiovascular disease, maybe by simply lifestyle modification, weight management, and a blood pressure control. If it is a high-risk pregnancy, obviously you need to involve physician, maybe cardiologist, along with the gynecologist to address these issues. Of course, lactation is going to help both the mother as well as to the newborn in terms of overall CVD risk reduction in both. And post-pregnancy, again, a detailed atherosclerotic cardiovascular risk to overall reduce the risk of CVD in these patients. So lipid management options during pregnancy are very, very limited. Again, crux is we need to emphasize on healthy lifestyle, weight management, and blood pressure control. Diet and omega-3 fatty acids still go a long way in bringing down lipids, especially triglyceride, towards the normal. Those females, unfortunately, who have a homogeneous familial hyperdyslipidemia, they could be the candidate for LDL apheresis, or there could be at least a discussion on potential teratogenic lipid agents. I'll be taking you through on those. What are still likely to be safer in pregnancy, and bile acid resins are one of the options. But greatest dilemma is whether to treat these females with dyslipidemia or no. I think yes, to prevent complication not only in mother but also in newborns who are going to carry that risk of CVD subsequently in pregnancy. So the therapeutic options are still low-fat diet. Low-fat diet, as in a non-pregnant woman, can lower cholesterol by almost 20%. So not more than 300 milligram cholesterol, ideally maybe close to 200 milligram cholesterol on daily basis. Total fat has to come down ideally toward 20%. Saturated fat has to be less than 7%. PUFA could be as high as 10 to 15%, with MUFA being less than 10%. But maternal recreational activities will also go a long way. All upper body exercises which are approved by gynecologists or obstetrician could reduce triglyceride by 12 milligram and lower cholesterol also by 5 to 6 milligram. Of course, there is no association with HDL, that whether it will improve with those simple exercises. So treatment options for severe hypertriglyceridemia in pregnancy again rest on diet. Fibrates, well, gemfibrozil, certain evidences are there that this still could be safe. Phenofibrate experience is very, very less, so ideally it should not be prescribed. Fish oils, combinations, omega or Carlson with 90 or 50% omega-3 content could be used to reduce triglyceride. Medium chain fatty acids could be useful. Statins, niacin, resins, ezetimibe are actually not indicated. Statin, well, we know ideally should not be taken during pregnancy because risk of teratogenicity is very, very high, especially if it is being consumed in the first trimester. But unfortunately, in recent years, there has been greater prescription of statin to women of childbearing age, not only because of the fact that many of them are obese, they are getting married late or getting pregnant late. So by then they might be already on statin, they might have reduced physical activity, they might be consuming high-fat diets. Risk of not only pre-diabetes, diabetes and GDM in these females is high. And unfortunately, still pregnancy happens to be most unplanned event in lifetime. So again, they might actually conceive while on statin. So risk of teratogenicity goes up. Well, other drugs could be, again, I told you, ezetimibe, fibrates, and nicotinic have been associated with certain malformation in only animal studies. So these are classified as category C. Drugs in category B are actually bile acid sequestering resins or cholesterol or cholesterol, which is again classified as group C. There are no studies, unfortunately, on PCSK9 inhibitor in pregnancy, so it should be avoided. Now, someone having a heterogeneous or a homogeneous familial hyperlipidemia, dyslipidemia, obviously we know that there is, in any case, physiological 30% increase in total cholesterol, but these females might have total cholesterol more than 250 or 300. So until unless you address their cholesterol levels, they are at a very, very great risk for developing acute pancreatitis, which may be fatal not only to the mother, also to the fetus. So there could be a very strong need for taking them for lipoprotein apheresis. And here is a small data of 7 case studies which got published in 2016, again emphasizing that if you give them lipoprotein apheresis, it is very, very important to reduce overall risk in homozygous familial hypercholesterolemia. Those females who didn't opt for this apheresis, they actually later on died of myocardial infarction. A good adherence to lipoprotein apheresis during pregnancy actually resulted in uneventful deliveries, and it didn't have any side effects. So to conclude, hyperlipidemia and pregnancy is physiological. We need to understand the overall lipid metabolism. Pregnant women with monogenic hypercholesterolemia or severe hypertriglyceridemia definitely pose a challenge in clinical management. So there is a need to create management algorithms, which unfortunately till date are not there in any organizations. We must stick to diet, plasma exchange, or total parenteral nutrition at times, and maybe insulin may be considered to address the issue of hypertriglyceridemia in these females. Well, omega-3 fatty acids, whether you talk about eicosapentaenoic acid or doxo-1, these will definitely reduce plasma by triglyceride by 30%. The use of fibrates is limited. Gem fibrogel, I told you, still could be an option, but we need to discuss it with the family. However, several cases have been described in which fibrates were used during pregnancy and no teratogenic effects were observed. So it has to be with a written consent to address issue of persistent dyslipidemia that you may still consider fibrates. Statins are absolutely out because of higher risk of teratogenicity. So in the end, I think this pregnancy state must be viewed as a window of opportunity in screening future diseases and a modus operandi for primary prevention. All those females actually during pre-pregnancy counseling must be evaluated for atherosclerotic cardiovascular disease and dyslipidemia, at least a weight reduction, a dietary advice, role of exercise must be emphasized by the time they get pregnant, so that they carry a very lesser risk, not only for themselves, but also for the newborn subsequently. Thank you very much for your patience listening. I'll stop sharing here and stay back for the discussion towards the end.
Thank you very much, Dr. Rajiv Chawla. I feel now we go ahead this in the session of first cry. I really appreciate the names which have been given for all the sessions. Congratulations, Benny Man and the team. This first cry session, the second lecture, we are already running almost half an hour behind the schedule. We have now the session by none other than Dr. Shailaja Kade, and she's going to speak on the Professor Sheshaya's concept of focus on fetus for future, and she's going to speak on the developmental origin of health and diseases. And just to introduce Dr. Shailaja, can we just move over? Hello. Yeah, I feel Shailaja is presently the chair of Maharashtra State RSSDI. She has done FRCP from London and other colleges of Royal College of Physicians. She is also the fellow of American College of Endocrinology and Physicians, and professor in internal medicine and consultant diabetes clinic in Pune. And she has, to her credit, a lot of research work across the last 35 years. And she has the close associated with the KEM College KM in Pune, and she's co-author with many other projects across Central India and West India. She also has co-authored many good books like Drugs for the Heart in Diabetes, and the Diabetes Public Health, Diabetes in Developing Countries. With so many awards to her credit, I hand over this mic to a very close friend of ours, Dr. Shailaja Kade. Shailaja, over to you.
Thank you, Sunil. So I'm just sharing my screen. So can you see the slides?
Yes, ma'am.
Yes, it is visible.
Yeah, fine. Yeah. So good morning, everyone. Congratulations, Benny, for year by year beautiful discussions in your conference, which takes up some particular kind of a concept ahead and actually improves everyone, not only knowledge, but the day-to-day clinical practice. So thank you so much. So the subject given to me was general concept about DOHAD. And if everyone knows, actually this was fetal origin of adult disease initially, which was Barker's hypothesis, which stimulated worldwide interest to understand a relationship between low birth weight and the future risk of maybe cardiovascular and other future non-communicable disease risk. And this was mainly related to development of impaired glucose tolerance as well as CV risk, which happens if you are born small or low birth weight. That was the fetal origin of adult disease. Two names come into this, Professor Barker, of course, and Dr. C.S. Yajnik, because I think this concept was taken ahead by Dr. Yajnik. And now if you see fetal origin of adult disease, or call it as a DOHAD, the major work is done from India, from Dr. Yajnik's group from Pune. And if you are interested, we have a very interesting 45 minutes to 1 hour session in our RSSDI in April end, when Dr. Yajnik is really going to unfold the story, how it started from Barker's hypothesis, which he has taken ahead, that it born small and catch up growth, actually more harmful for the future diseases. So from this fetal origin of adult disease, the word was changed to DOHAD, developmental origin of health and disease, a rather more recent term from fetal origin, exposure to certain environmental influences during critical period of development and growth, how they have an effect later in life. It shows that the period from conception to early childhood, that is prenatal development to child growth, when actual organogenesis and rapid growth are happening or occurring, this period is critical to the immediate as well as the future health of the infant, which gets affected by many kind of a stimulus. It's not only low birth weight. Now the DOHAD hypothesis is proposing that altered environmental influences, which can be nutrition, as Dr. Yajnik talks about undernutrition, which is very, very important for developing countries, the different metabolism in pregnancy, pollutants, stress, and so on, during critical stages of fetal growth, which predispose individuals to diabetes and other non-communicable disease of later life. I remember 2019 ADA, I think the last ADA which we attended, there was a whole 2-hour session on endocrine disruptors. So a simple plastic use, chemical use in our day-to-day life, how it is exposing girls to get more gestational diabetes. So it has now, the concept is getting more wider. And here in DOHAD, similar pollutant stress also can have an effect on the baby's future life. So to explain, this may be a simpler diagram, but it involves a lot of complicated things. So undernutrition, or maybe some stress, physical, psychological infection, or what has been studied majorly is altered glucose, or mother's obesity, or mother's adiposity, which include maternal stress, can have an effect on the baby by changing gene expression. There can be change in the growth of the fetus. So fetus can be small when it is born at the birth. There can be organ structure difference. So the number of nephrons in the kidney or the liver can be decided by the influences in utero. I think the major work is done by Dr. Yajnik now in the world, where he has a data for 12 years of children from pre-gestational in his Pune maternal nutrition study till the children who are at least 10 to 12 years. So which is actually unfolding the story of Barker's, has taken it ahead much way. So in utero insults, which we understand only glucose and adiposity in clinical practice, but there are many more like high triglycerides in pregnancy has a direct correlation with the baby's adiposity. And when you say high triglyceride, I will come to our paper which was published from Pune KM. In a small 300 women, high triglyceride means that it was 116 mean triglyceride. So when we say high triglyceride, it is a continuous risk. It's not only glucose. So there are many things happens. There is epigenetics. So there is a gene expression changes, though there is no difference in the amino acid sequence, but the functions of the gene get adapted to the change, and that gets inherited, which is again called as epigenetics, beautifully explained again by Dr. Yajnik in his talks. So is the thought to reflect permanent effects of programming of unbalanced fetal development on physiological systems of the baby, which gets expressed in the future. So intrauterine programming may underlie the characteristic Indian thin fat phenotype and the current unprecedented epidemic of diabetes in the backdrop. So this is from the doctor. I will show you the title of this paper. So caring for the fetus for future. So I will be talking about few concepts, what we know. Though we have a lot of research going on about stress and the other factors, but what we know at present is glucose, is maternal obesity, maternal fitness, and of course, a few words about metformin. That at least we need to change right from today in our clinical practice. So this was the paper of Dr. Yajnik. There are many papers, but it is an Indian perspective where that he has contributed, and it's a story which we understand when we read this. So I recommend everyone, if someone is interested in Doha, to go through this paper. So hyperglycemia in pregnancy and non-communicable disease. So it is basically to identify at-risk mothers. So not only I will say this glucose in pregnancy, it's also the mothers, these young girls are at a very high risk of cardiovascular disease and future diabetes, as well as the babies. So both are at risk with that high glucose. And in Doha, we discuss mainly about the children. So in HAPO, if you remember, large HAPO study, 41% of women were at the risk of prediabetes and overt diabetes at the 11 years. So small glucose rise in pregnancy, there is a future risk. But when you come to the hard concept, baby's adiposity and birth weight shows a continuous risk. Though we talk a lot of cutoffs, I think, and there is a lot of discussion of postprandial glucose in pregnancy or diagnosis of GDM, but HAPO has very clearly shown many years back that there is a relationship with the fasting glucose also, which again has a continuous risk and there is no cutoff. So even a fasting glucose going up shows there is increased baby's adiposity and baby's birth weight. In India, we need to talk about adiposity. So there is a continuous risk with mothers, not only postprandial, as well as the fasting glucose. This is the largest study, HAPO, which has taught us that. Ethnicity is important in all the field of diabetes, wherever we talk. And it's much more important in India because ethnically we are different. And there is a lot of problems of fetal origin of adult disease which come. And it is studied so much that we know that fetal programming is important. So it's Asian Indians, so it is much higher diabetes as well as fetal undernutrition in pregnancy. So maternal glucose as well as obesity is the basic crimes which are happening, which relates to these Dohad concepts. So it's mother's glycemia and obesity. So children who were larger than average at birth and whose mothers developed gestational diabetes had a 43% rate of being overweight or obese, 2.5-8 times the likelihood of being obese among average size babies born to moms without diabetes. So children who are born to higher glucose, with higher glucose of mother in pregnancy, have a 43% rate of having more obese at their counterpart children compared to children who are born to non-diabetic mothers. So glucose intolerance on the risk of fetal macrosomia, we can say that odds ratio for risk of macrosomia, the maternal obesity is directly producing larger babies, macrosomic babies, and also overweight babies. And it's not only obesity, but also pregestational diabetes. So overall risk of big babies, fourfold higher in overweight, obese women versus women with diabetes. So obesity is playing a major role than only just getting a diagnosis of diabetes. So I think again, it must be a correlated risk where the adiposity, obesity with glucose, then so obesity in mother and pre-pregnant weight predictors of GDM or for the future risk of for the babies. I know Dr. Usha Shriram has taken this in a very big fit to be a mom, which says it's not as a mom, but also for the baby. And to avoid these hard problems, the girls need to be fit before they decide their pregnancy. This was Dr. Yajnik, though he's famous for his thin fat picture along with his Yudkin. I think first in his unit, what he started was thin fat Indian baby. I think way back, what it shows that these are two normal, both are normal babies. One is white Caucasian, one is Indian. But usually the body composition at birth in human is fat mass is 12 to 15% and fat-free mass is 85 to 88%. And the fat mass is mainly maternal metabolic factor decides the fat mass of the baby, which is 10 to 15%, 12 to 15%. So this fat mass is decided by insulin sensitivity pre-gestational, insulin sensitivity in late pregnancy, which increases quite a lot in the third trimester, then neonatal sex and gestational age and maternal weight gain. So as I said, maternal blood glucose, triglycerides, amino acids, everything is related to the fat mass of the baby. And again, the concept of Dr. Yajnik, though this baby is Indian, it is more adipose compared to the white Caucasian baby. Phone, yeah, thank you. So this is again a crucial thing that adiposity is important in India when you're talking. So this was a paper, babies born to mothers with GDM, how it is different. You can see these babies born to the normal mothers and babies born to the GDM mothers. Though the birth weight is not much different, you can see the subscapular fat, which is measured, is extremely different and it is significantly higher in babies who are born to. This is a better diagram which was published by Dr. Yajnik's unit, is that this yellow is the babies born to the normal mothers, red are the babies born to the GDM mothers. In yellow, in the left-hand upper side, you can see that birth weight is only less than 5% of the babies are above 90th centile for babies born to normal mothers, where babies born to the GDM mothers, 30% are above the 90th centile. So when you talk of macrosomia, the definition is above the 90th centile of whatever cohort you are talking is called as macrosomia. So 30% one are overweight. You can call them as macrosomic for that cohort. See the baby's fat mass. So this is thin fat Indian babies. So less than 5% are below for the babies who are born to normal mothers, but 55% babies born to GDM mothers are having more than 90th centile of body fat mass. So the adiposity is much more in these babies, which is a risk of future non-communicable disease and which we can avoid by having a good to fit mom with less adipose and normal glucose in pregnancy. So this is Pat Catalano's papers, which says that fat-free mass and the fat mass, which is correlates with mother's glucose values and also mother's obesity, pre-pregnant obesity. Pre-pregnant obesity. So BMI more than 25. So Pat Catalano has also shown that not only the glucose, but the baby's fat mass is actually correlates with the pre-pregnant obesity of these young girls. So again, we need to push these young girls to be fit and be more fit, which if you ask Dr. Yajnik, again, he will go back to the that you need to do something in the previous generation, but at least in practice, we can do that. The girls need to be in a better kind of a physical state. So factors affecting the growth and body, again, is Catalano's paper, as I was saying, that gestational diabetes, it is strongly related, but also pre-gravid BMI, it has strongly correlates with babies, a kind of a macrosomia or the fat mass. So obesity in mother and pre-pregnant weight are predictors of GDM as well as the future problems for the baby. So these girls, when they had GDM, prior GDM, they show metabolic syndrome and future risk of diabetes. The babies born to GDM mothers, what we call is actually diabetes begets diabetes. So this concept is very important. So a normal girl who gets pregnant, because of the pregnancy, this just gets fast forward. So that kind of a pre-diabetes, anyway, it doesn't happen in India, as we have seen in Ramchandran studies from Indian Diabetes Prevention Program. The normal course of going from IGT to DM is 9 years for Finnish population, maybe 5 to 7 years for Chinese. And in India, it was only 2 years from Ramchandran study. If pregnancy comes in between, there is almost no IGT. The girls directly become diabetic. The girls born to the IGT mothers, when they get pregnant, they have a very high risk of again having adiposity and gestational diabetes. And this, everyone has seen this figure that diabetes begets diabetes. So it's not only one generation we are trying to prevent problems, but even the future generation, we can prevent problems by controlling this glucose or adiposity in young girls. So it's both, so as it's also for mother, but today we are talking about fetus. And so just few words about metformin in pregnancy. So what we saw is maternal glucosis, maternal adiposity, maternal obesity, pre-pregnant insulin resistance, and pre-pregnant weight. Adiposity of mothers is very, very important for that high glucose, which can affect baby's future growth, which is actually a Dohard concept. The major studies done are about mother's glucose and the fat and the obesity and triglycerides. So unless these young girls is improved, these fetuses born to these girls will be more healthier, and then we can avoid the future non-communicable disease in these children who are born to the mothers who are obese or GDM. Few learnings from mixed study has come into, though it was a great study from the Janet Rowan from Auckland, New Zealand. So what it showed when these babies are followed up, and I think 2017, it was first she spoke about it in ADA. There is a reduction in insulin concentration in umbilical cord serum of metformin group was not seen, but the results were available only half the women. So this was expected that if you are treating by metformin, it will be more beneficial, but it was not seen. The follow-up showed more subcutaneous fat and less ectopic fat in children born to metformin group only in the Auckland group. So at 2 years, the metformin group compared to the insulin group, children had larger and mid-upper arm circumference. So total fat mass and percentage body fat mass bioimpedance were not different at the 2 years of age when the babies on metformin group compared to the insulin group. So at 2 years, children exposed to metformin had a larger measures of subcutaneous fat, but overall body fat was the same. What happened is actually at the 7 and 9 years follow-up, the children, there were 2 cohorts. The Auckland group showed a different results and the Adelaide group showed the different results. So this was discussed again, and now this concept is taken ahead. So Auckland group, 99 children were, it was heterogeneous. At birth, both groups were similar. At 2 years, metformin babies were bigger. At 9 years, metformin children had a bigger, DEXA showed increased fat-free mass. There was no difference in abdominal or subcutaneous fat. But that's what Janet showed, that is this that they are actually helping these children, the metformin. On the other hand, the white Caucasian group, which was a major part in the cohort of Adelaide from Australia, it did not show these difference. So metformin in pregnancy concept has what the effect on the baby has come forward after Janet published this study of TOFU, which is a follow-up of children who received metformin in pregnancy. Now, if you see the 2018, there was a very big ADA kind of a 5 hours of a session on this, where they first time found that effect of metformin in addition to antenatal diet and lifestyle. There is an intervention of fetal growth and adiposity, and this was another trial published in BMC Endocrine Disorders. It was a GROW randomized trial. So more than 500 women, more than 25 AM, metformin was given, and these parameters were measured of fetal biometry and fetal growth. Among overweight pregnant women, addition of metformin did not appreciably impact fetal size or adiposity, but those who were low, because this study only studied more than 25 BMI, So the metformin is acting differently, maybe in obese women and in the normal weight women. We do not know, but there are more and more studies are showing that this was actually first time put again in last few years, and this concept is gaining weight. Even ADA guidelines have changed. What it says that metformin stimulates AMP kinase pathways, and because of the mTORs, which are responsible for the metformin action, in the first trimester, baby has an anaerobic metabolism, and fetus doesn't, there are no mitochondria. So metformin doesn't cross in the first trimester. After the first trimester, in the second and third trimester, metformin can cross placenta, and there are mitochondria. So there is some aerobic metabolism starts in fetus. Because of the metformin's effect, which can have a growth restriction in babies in the second and third trimester. So how to use this in practice? I usually, when I see serial sonographies, as Dr. Sunil Gupta just said, that lowering glucose, you see the babies are going small on serial sonographies. And so too much of a control of glucose is not correct. Similarly, if the sonography is showing, I think we will discuss that, but metformin has some query that it may create growth restriction. So the recent meta-analysis concluded that metformin exposure resulted in smaller neonates with acceleration of postnatal growth. So that was Dr. Yajnik's thinks that if you're born small and there is a catch-up growth, there is a more kind of a risk for future diabetes or obesity in these children. So whether metformin can also produce a kind of a disease, that is question mark put by in ADA recommendation in even in 2022. So what ADA says now for recommending for clinical clinicians, oral agents are definitely an alternative, which has, but need to for more long-term safety data is needed. However, one thing is very clear that at least in women with hypertension, preeclampsia, we should not use metformin. Otherwise, recommendations are there, but one needs to see mother's obesity, mother's weight, how the baby's serial sonographies are showing in clinical practice when we take decisions of using metformin in, I think, second and the third trimester. So that's what ADA is saying. This is just one thing, again, that breastfeeding and growth trajectory from birth to 5 years of age among children exposed and unexposed to GDM in utero. So children exposed to GDM mothers, gestational diabetes, had a greater Z score values at 6 months and at 4 to 5 years. Breastfeeding duration was not associated with weight for any trajectory in any children. So to conclude, this paper says, last year's published, children exposed to gestational diabetes had a different growth trajectory in early life, but breastfeeding duration did not seem to influence. So that is one more thing. So GDM actually has a catch-up growth for these children born to GDM mothers. So not only it has a direct effect on baby's adiposity, even it is seen that there is a catch-up growth at 8 or 10 years or at the age of 5 years. So thank you so much. So I had this concept, tried to show you some papers from Dr. Yajnik about the DOHAD concept, as well as some clinical polls when we use metformin or when we treat pre-pregnant obesity or insulin resistance in the young girls. Thank you. Thank you, Benny.
Thank you so much, Dr. Kale. And we'll keep the questions at the end. Can we move on to the next session by Dr. Shalini Jaggi?
Yes,
Shalini? Yeah.
Good afternoon. It's been a lot of food for thought since morning, and these are the type of discussions we need so that it helps consolidate our understanding of principles that will impact many generations to come. Without much ado, let me introduce my very good friend, Dr. Shalini Jaggi, who's a consultant diabetologist and director at Lifecare Diabetes Center, New Delhi, the only lady expert on the Member Executive Council, RSSDI National, Joint Secretary of RSSDI Delhi Chapter, Governing Council Member, DIPSI, Secretary, RSSDI Delhi Chapter, and recipient of several important fellowships, and also tutor and faculty of Cardiff University, UK, University of South Wales, UK, and has had several other accolades to her very crowded CV with numerous publications ongoing, but special interest in women and diabetes. So we have none other than Dr. Shalini Jaggi tackling managing PCOS in women from preconception through pregnancy.
Thank you so much, Purvi, for that very, very warm introduction. And many thanks, Benny ma'am, Dr. Vijay sir, and all my friends here, Purvi, Ami, Shefali, Shilpa ma'am, for this honor to be here again every year. It's such a pleasure to be here talking about issues that are very, very close to our hearts. And ma'am, you made it very difficult for me. All stalwarts before me talking on such important topics. So it's a tough job, but I'll try to do justice to the topic you have given to me this time. So I think the stage has already been set by my previous speakers when they've alluded to all the different reasons why we need to focus on preconception, why we need to focus on tight blood glucose control, hypertension, why we need to focus on lipids in pregnancy, because it is not only the mother, her future metabolic risk, but also the fetus that is impacted. So putting in perspective, PCOS is again a very, very important entity that all of us need to be aware, because we know it is one of the most common endocrine as well as a reproductive disorder, affecting almost 5 to 10% of the female population. 1935 was the first time when people started talking about it, thanks to Stephen and Leventhal, who talked of the association of enlarged sclerosistic ovaries with amenorrhea, obesity, infertility, and hirsutism, putting them together as PCOS. Today, we know PCOS has variable clinical presentation, so it can just be an incidental finding on an ultrasonogram that a woman undergoes. She's completely asymptomatic, or she can present with a wide range of metabolic, gynecological, or dermatological presentations, which could probably be manifestations of underlying hyperandrogenism. She could present with oligomenorrhea or amenorrhea, infertility, or in young girls, a very common finding of hirsutism, acne, alopecia. So we know prevalence of PCOS among infertile women is 15 to 20%. Women with PCOS, 43 to 46% of them develop metabolic syndrome. Women with IGT, 40% have PCOS, and 85% in those with type 2 diabetes who have menstrual irregularities. So an area which we really need to understand. And the bottom line is, what lies at the bottom of everything is insulin resistance. So the hyperinsulinemia, as a result of the insulin resistance, that is the fertile soil for PCOS, not only reduces the SHBG production in the liver, it increases the ovarian as well as adrenal production of the androgens or the male hormones, the virilizing hormones. The LH-FSH ratio is deranged. As a result, there's increased level of the male hormones or the androgens, the hyperandrogenism, which is characteristic of PCOS, resulting in oligoovulation and ovulation and all the different manifestations of PCOS. So it's essentially a vicious cycle of insulin resistance, PCOS, and all the metabolic abnormalities that we talk of. Now we know insulin resistance doesn't come alone. It is the fertile soil for all the different NCDs, the cardiometabolic disorders we talk of, right from diabetes to hypertension to atherosclerosis, dyslipidemia, and all the prothrombotic states, the central obesity, and PCOS. So why do we need to know about PCOS? Is because it implies an increased risk for infertility, for obesity, type 2 diabetes, gestational diabetes, NAFLD, and metabolic syndrome, besides a cluster of increased risk for cardiometabolic risk, the cardiovascular disease, hypertension, and dyslipidemia. So this is the association of PCOS with metabolic syndrome. Like I said, hyperandrogenism is also linked with several components of metabolic syndrome. And we all know that women with PCOS definitely present with a much higher prevalence of metabolic syndrome with a positive association. And it is not only the obese PCOS, but also the non-obese PCOS women. Dr. Yajnik talked about this in his lecture, where we clearly know that hyperandrogenism in women who are non-obese PCOS, again, is associated with various components of metabolic syndrome. Further on, we know insulin resistance is often the precursor of diabetes, and we know that the metabolic profile of women with PCOS and diabetes, again, insulin resistance is the common feature. Oligomenorrhea is a surrogate marker for PCOS, and this predicts almost a 2 to 2.5-fold increased risk of diabetes, particularly in women who already have a family history of diabetes. 80% of women with irregular cycles have PCOS. So what we need to understand is there's a close association between PCOS and dysglycemia, and that is where it is important that we screen and are aware of this entity. You can see here, women with BMI even less than 25. There also, if you have PCOS, there is a significantly increased odds ratio for development of type 2 diabetes. And again, all the different BMIs predisposing women to PCOS. So how does it impact a pregnancy? If a woman is planning pregnancy, like I said, there is an association with infertility, so ovulation induction, we'll come to that in a little while. But if a woman with pregnancy, with PCOS gets pregnant, of course, there is an increased maternal risk, not only for early pregnancy loss, but like it has been described, gestational diabetes, preeclampsia, pregnancy-induced hypertension, gestational weight gain. And for the fetus, PCOS again puts the fetus at an increased risk of preterm birth, admission to neonatal ICU, as well as altered anthropometry. And we've seen Dr. Shailaja Kale's data, where she's talked about how the PCOS women who were given metformin, we've seen anthropometric changes, and I'll come to that in a little while. So it's important to reduce these different risk factors before conception, and that is where Dr. Usha also talked about the importance of preconception care. Dr. Yajnik stressed on the interconception and the preconception, because dysglycemia starts very, very early. So a closer follow-up and more fetal monitoring is needed during pregnancy, more so in women who have PCOS and eventually develop GDM, because the association of PCOS and GDM puts them at a very high increased risk, almost a twofold increased risk of preeclampsia and pregnancy-induced hypertension, a threefold increased risk of neonatal hypoglycemia, and all the other adverse fetal-maternal outcomes that we've been talking about. So it's important that all these complications are taken care of, and we know the metabolic similarities between women with insulin resistance, diabetes, PCOS, putting them at a very high risk for CAD, as well as the micro and the macrovascular complications of diabetes. So whenever we're looking at a diagnostic workup for PCOS, it has to begin with a thorough clinical history and a physical examination. Ask her about the menstrual history. Ask her on the fluctuations in her weight right from the time she was a child, the impact on PCOS symptoms. Look for cutaneous findings, look for terminal hair, the male pattern of hair distribution, look for acne, alopecia, acanthosis nigricans, skin tags. These are your clues to PCOS. Diagnosis can generally be accomplished with a careful history, a physical examination, and basic laboratory testing. Sometimes even ultrasonography may not be needed. Now, Endocrine Society advises clinicians to diagnose PCOS based on the Rotterdam criteria. We all know this. 2 out of 3 of these findings, it has to be either the presence of oligo or anovulation, clinical and or biochemical signs of hyperandrogenism, plus polycystic ovaries. And when we're talking of polycystic ovaries, this is what the picture looks like. It has to be either of the ovaries, either or both, presence of more than 12 follicles, each being 2 to 9 millimeters in diameter, with an ectodenstroma or an increased ovarian volume of more than 10 milliliters, besides the biochemical signs, which could be an elevated free testosterone, an elevated DHES, or a free androgen index with an altered LH-FSH ratio, along with the clinical signs, like I said, the terminal hair in a male pattern distribution when it comes to a woman coming with hirsutism, or the acne or the androgenic alopecia. So when it comes to the clinical presentation of women with PCOS, it is variable, like I said, could be asymptomatic. Essentially, in the adolescent period, it is essentially the presentation with menstrual irregularities or the cosmetic concerns of acne, hirsutism, or hair loss, as well as weight gain. Again, in the reproductive period, they essentially may present with infertility, and that is where you find out that the woman has PCOS. May even present with early pregnancy loss, as well as during pregnancy, PIH, GDM, or preterm delivery, like I said. And in the menopausal woman, again, all these components of metabolic syndrome, diabetes, and an increased risk of CA endometrium, and we know obesity is also a very important underlying factor here. So when it comes to managing the PCOS, I think we need to understand in the young, it is essentially a reproductive disorder. And as they get older, it is essentially the metabolic component, the metabolic sequelae of PCOS that are of concern. So when it comes to management, it has to be a multidisciplinary approach, right from a pediatrician to a dermatologist, gynecologist, endocrinologist, or a diabetologist, and a cardiologist, or even a geriatric physician. So everybody needs to be aware of this entity to tackle it as it comes. When it comes to the goals of management, clearly lifestyle changes aimed at weight loss, especially in women who are overweight or obese, or metabolic well-being is very, very important. The avoidance of the effects of hyperinsulinemia. We need to reduce the production and circulating levels of androgens, protect the endometrium against the effects of unopposed estrogen, which predisposes them to increased risk of CA endometrium. Contraception, very important, induce ovulation to women who are planning pregnancy. Plus, you need to target on lowering the risk of GDM in pregnancy, as well as reducing the risk of future diabetes and cardiovascular disease. Besides the psychological, the emotional well-being and support because of all the cosmetic reasons and the infertility, which can be a huge reason for depression in these women. So friends, addressing the lifestyle factors preconception should be the first line approach to reduce any further therapeutic strategies during pregnancy. So lifestyle management definitely aimed at weight loss is very, very important. Metabolic health needs to be targeted. So weight loss has been shown to have a significant role in restoration of ovulation in obese women with PCOS. Not only does it reduce the circulating free androgen and insulin levels, it increases HSBG and reduces the free testosterone. So it is essentially aimed at general healthy eating practices, maybe a calorie restriction when we are looking for a major weight loss. A 5 to 10% weight loss is all that is desired, which can lead to good results when it comes to ovulation induction, as well as physical exercise and individualized regime based on the patient. So summing up the management of PCOS, it essentially depends on whether pregnancy or ovulation induction is desired or not. If it is a woman who's come to you desiring pregnancy, you need to look at the anovulation or infertility. So here, this is where you have the ovulation inducing agents, clomiphene or letrozole, or the second line metformin also having a slight role. Insulin resistance needs to be tackled, and we all know metformin the best sensitizer here. Obesity, like I said, lifestyle modification, exercise and diet, hirsutism, all the cosmetic reasons, electrolysis, light-based therapies, and acne with topical creams if it is really distressing. Again, in a woman who is not desirous of pregnancy, of course, you need to correct the anovulation or the menstrual irregularity. So this is where the hormonal contraception, the combined OCPs come in, and also Mirena, the levonorgestrel releasing intrauterine system, and we'll come to these in a little while, besides metformin. Insulin resistance, like I said, obesity, especially in women who have IGT, people who are obese, that is where lifestyle modification along with metformin gives beautiful results. And of course, the cosmetic treatment of hirsutism and acne. So like I said, weight loss, a 5 to 10% weight loss sometimes yields good resumption of ovulatory cycles in most of the women presenting with PCOS. Insulin sensitizes the role of metformin. It improves not only the hyperinsulinemia, but also regulates the reproductive endocrine axis. It reduces the androgen burden, reduces incidence of GDM in some studies, and minimizes the risk for an adverse pregnancy outcome. Now we do have some data on metformin, which I'm going to discuss in a little while. Moving on to ovulation induction, be sure that you do a semen analysis as well as an HSG to complete the infertility evaluation before just attributing it to PCOS. Of course, ovulation induction with agents like clomiphene or letrozole is recommended by the Endocrine Society, and the impact on metformin on fertility is controversial. Few studies have shown good results, but we need more data. There has been a review in 2012, which actually concluded that the contribution of metformin to fertility isn't much. So when it comes to whether you need to combine metformin with OCPs, I think this is something where you need to be careful. There's inadequate evidence to recommend routine addition of metformin in PCOS women, like Dr. Shailaja ma'am also said. It is essentially recommended for adolescents who have already IGT or probably type 2 diabetes in addition to lifestyle. Of course, it has been shown to be as effective as a combined oral contraceptive for treatment of hirsutism. But in PCOS, metformin use should be restricted to only women with glucose intolerance or women who are struggling with weight. Based on recent data available, routine use of this drug for ovulation induction is not recommended. When it comes to using either metformin or OCP, of course, we know OCPs are less beneficial for insulin sensitivity. So this is where metformin has an edge at better reducing the fasting insulin. But of course, when it comes to oligomenorrhea or hyperandrogenism, OCPs are the drugs of first choice. Again, like I said, for women who are not desirous of pregnancy, of course, the focus is on the menstrual dysfunction and the endometrial protection. And this is where the hormonal contraception in the form of oral contraceptives or a dermal patch or a vaginal ring comes in as an initial medication for treating the irregular menses as well as hyperandrogenism. Small studies have shown that metformin is definitely able to restore regular menses in almost 50 to 70% women with PCOS, but let me put it categorically here that oral contraceptives have been shown to be superior to metformin for regulating menses and lowering androgen levels. And therefore, it's important that we decide on the use of metformin based on the certain indication, which could probably be IGT, dysglycemia, or weight. When it comes to which OCs, I think there are no studies that have demonstrated superiority of one over the other. So that is where you need to take a call based on the patient requirement. Anti-androgens may be added if there is a suboptimal effect after 6 months of therapy. Spironolactone is the commonly used agent, but it's important to understand that if you are using an anti-androgen, it's important to use contraception because there are reports of pseudohermaphroditism in male fetus. Again, hirsutism and acne, cosmetic treatment is important. Most effective first-line treatment for mild hirsutism in PCOS is oral contraceptives. Other therapies such as eflornithine cream can also be used besides the cosmetic procedures, electrolysis, light-based therapies, lasers, or intense pulse lights. Acne, again, hormonal contraceptives are first line in conjunction with standard topical acne therapies, and anti-androgens, spironolactone being the most common, may be added as second-line medications. Just a small note on myoinositol. There's a lot of talk on myoinositol in PCOS because we know that deficiency of inositol decreases PI3 kinase activity, contributing to insulin resistance. And it has been shown that probably increased myoinositol may increase insulin sensitivity by making more phosphatidylinositol available. But current guidelines clearly recommend that inositol is just an experimental therapy in PCOS, and we still need more data. Of course, we need more evidence to actually put it down as a treatment option when it comes to PCOS. Now, metabolic screening in PCOS, of course, you need to screen for the glycemic parameters, the lipid profiles, blood pressure, association with NAFLD. So you need to look at the liver enzymes. Women obese presenting with OSA, you need to screen for OSA, as well as all the cardiometabolic CVD risk factors. So this is where the preconception counseling and care comes in very important because it's essential to avoid an unplanned pregnancy. Offer women who are obese weight loss therapies. You may help them with exercise, individualized dietary advice, optimize glycemic control. A 75-gram oral glucose tolerance test in all women with PCOS who are planning pregnancy or who seek fertility treatment is very important, given the high risk of hyperglycemia and all the associated comorbidities in pregnancy. So all women with PCOS should be screened pre-conception with an OGTT for any level of dysglycemia which needs to be managed. And once they are pregnant, a GDM, the risk of GDM is very high. So a screening for GDM is very, very important. Of course, you need to also warn them on the risk of preeclampsia, PIH, as well as all the adverse feto-maternal outcomes. Like I said, PCOS increases the risk of GDM. So preconception blood glucose and BP screening and control are essential. Furthermore, a low sex hormone binding globulin level results in high free androgens that is associated with an increased GDM risk, and therefore low SHBG levels are early and strong predictors of GDM in women with PCOS, independent of obesity and the measures of insulin resistance. So this can be used as a surrogate marker to identify PCOS women who are at an increased risk of GDM pregnancy. Of course, we know IVF and all these treatments puts them at an increased risk of multiple pregnancies, again, an independent risk factor for GDM. So screening for GDM and optimal management of GDM is recommended in all women with PCOS who get pregnant. And like Dr. Yajnik said, we need to have an Indian problem to our solutions, Indian solution to our problems. And that is where we have the DIPSI guidelines, which talk of a single test, simple procedure. 75-gram glucose is given to the woman on a non-fasting state, irregular of the time of last meal. And if the 2-hour plasma glucose is more than 140, GDM is diagnosed. Now, since, like I said, these women may have a certain degree of dysglycemia early on, so the first test, preconception testing, of course, needs to be done with an OGTT. But once she is pregnant, in the first trimester itself, the screening has to start. And if that is negative because of the high risk of developing GDM later on, a second screening test must be performed again at 24 to 28 weeks. And in high risk ladies, maybe a repeat testing at 32 to 34 weeks is also indicated. Of course, glycemic targets in pregnancy, different guidelines coming out with different targets. And like Dr. Sunil Gupta said, DIPSI is very clear. You need to have intensive glycemic control. A fasting target of less than 90 and a 2-hour target of less than 120 is recommended. Most of the women with GDM, of course, 80% of them can be managed well with MNT and lifestyle modification. But eventually, as the pregnancy progresses, increasing insulin resistance, worsens the dysglycemia, and they may need pharmacotherapy, which is where insulin in pregnancy is the first choice. But of course, metformin has been used. When it comes to women with PCOS, randomized double-blind control trials comparing metformin with other therapies, even for ovulation induction in women with PCOS, have not demonstrated benefits in preventing spontaneous abortions or GDMs. And therefore, most of the current guidelines today say that there is no recommendation, no evidence-based need to continue metformin in such patients. So we all know long-term data on metformin is still lacking. A lot of gynecologists still use metformin in PCOS women to treat the insulin resistance and normalize the reproductive function. And because there is an increased risk of early pregnancy loss, there were a lot of papers which showed that probably metformin in PCOS could reduce this. Few observational studies have also suggested a lower risk of GDM and PIH in users, ladies with PCOS who were given metformin. But like I said, currently emerging data clearly shows that metformin does not really reduce spontaneous abortions or development of GDM, and therefore no need to continue metformin. And another reason is babies with metformin slightly increased risk of prematurity is seen. This is PEDMET study, women with the PCOS given metformin and followed up. Their babies were again followed up post-birth. And like Dr. Shailaja also stored, this is another study which shows that children in the metformin group had higher BMI Z scores than those in the placebo group. The increased BMI in children exposed to metformin born to PCOS mothers indicates a potential risk of inferior cardiometabolic health in these, and adults. Implications for their adulthood are still to be seen. Coming to postnatal effects of metformin in PCOS context, like Dr. Shailaja also showed, infants born to PCOS mothers who were continued on metformin all through pregnancy, infants were heavier than those in the placebo group, born with larger head circumference, born with higher weights, higher glucose levels, strong trend towards elevated systolic blood pressure, high LDL cholesterol. So I think this is something we need to take a step back and reconsider. Again, PCOS women with pregnancy, management has to be intensive, assessing fetal growth and well-being, scans, ultrasounds, dating anomalies and growth time to time as indicated. Tests for fetal well-being as indicated. Close monitoring is required because, like I said, increased risk of PIH and preeclampsia. Of course, if there is pre-existing hypertension, she's on ACE inhibitors or ARBs, you need to reconsider, put her on the safer options. You need to stop statins if there's statin intake before pregnancy. Again, all the teratogenic medications in pregnancy need to be avoided. Low-dose aspirin, especially in women with pre-existing diabetes, 100 to 150 milligrams per day, starting at 12 to 16 weeks. Folic acid if she already has dysglycemia. So this is a table that actually summarizes how the pre-pregnancy, antenatal and postpartum care is required, the conditions that are putting different phases of pregnancy, the increased risk for conditions and how you need to manage those. So pre-pregnancy, like I said, very important to tackle obesity, diabetes, hypertension. Pregnancy, the weight gain in PCOS ladies is much higher. So that is where you need to put them in touch with a registered dietitian who can give them proper advice on the weight gain recommendations and the proper diet. Of course, screening for GDM is very, very important, and postpartum follow-up, very, very important in terms of weight loss, ruling out type 2 diabetes, persistent hypertension, breastfeeding difficulties, which are commonly seen in women with PCOS as well as the GDM, and postpartum depression. So I said it's very important to support them emotionally as well. So to summarize, PCOS is not merely a reproductive disorder, but also an endocrine disorder that affects almost 5 to 10% of women in the reproductive years and is the most common cause of ovulatory infertility, represents as a spectrum of disease with variable presentations, right from asymptomatic to all the cosmetic presentations. Pathophysiology, it is essentially the insulin resistance and the androgen excess that underlies PCOS, and diagnosis is very simple. Keep an eye out, simple history history, simple clinical examination, along with a few simple tests and an ultrasound if required is important. Current treatment options I discussed, essentially it is lifestyle management along with a combination of OCPs and insulin sensitizers where metformin does have a role. It's important to diagnose PCOS because of the potential long-term consequences. So it is not only that hyperandrogenism and infertility that PCOS causes are distressing to young women, it is also the metabolic sequelae, the increased cardiovascular risk, the increased risk for diabetes that is responsible for long-term morbidity and mortality. We know that GDM complicates 40 to 50% of PCOS pregnancies independent of age, race, ethnicity, and multiple gestations. And the women with PCOS and GDM, like I said, increased risk of preeclampsia, PIH, increased risk of neonatal hypoglycemia besides all the adverse outcomes. And therefore, regular screening and optimizing management is very, very important. With that, I'll end the session and we can take up the questions. Thank you so much.
Thank you so much. I think this was a very good session. Excellent talks delivered by Dr. Rajiv Chawla, Dr. Shailaja Kale, and Dr. Shalini Jaggi. And in the interest of time, we move on to the next session. So I thank all of you speakers and also Dr. Usha Sriram, Dr. Sunil Gupta, and Dr. Purvi Chawla. Sorry, we are just 45 minutes.
Thank you so much, ma'am. Pleasure being here.
Thank you, madam. Wonderful being with you people.
Thank you, sir.
Thank you, everyone. Now moving on to the next session on master stroke, and we really have our masters along with us. I invite the chairpersons, the lady herself, Dr. Benny Neglur, who has been leading this conference right from the front. My guru, Dr. Vijay Panikar, an absolute pleasure to have him. And Dr. Mary D. Cruz. I invite the chairpersons to kindly take over.
Thank you so much, Dr. Ami. And we are in now with the masters here. So I have great pleasure in introducing Dr. V. Mohan, and I'm sure he is the face of India. He's known to everyone here and really doesn't require introduction. We know that he's an astute clinician as his chairman of Dr. Mohan's Diabetes Specialty Center, and he has been mentoring not only physicians, but also diabetologists, many of whom are present today, and they were present yesterday as well. So he's also a great researcher, and his special interest as his talk today is on epidemiology of diabetes and its complications. And when I gave him a call that you have to speak on something related to gender, he said, okay, let me pull out my data. And then very next day, he sent an email to me, yes, I have 30% of my patients who are women. And I think he's presenting this data on epidemiology of diabetes and women, global and Indian, for the first time in our conference. He, of course, has received so many awards and fellowships. And if you name that, I think it'll take half an hour or so. He's presented so many papers, and he's put India on the map of the world. And he's also a Padma Shri, B.C. Roy Award, B.R. Ambedkar Award, and also the specially mentioned Harold Griffin Award from the ADA. So I invite Dr. Mohan to deliver his lecture.
Hello, everyone. I would like to record my heartfelt thanks to Dr. Benny Neglur, the organizing chairperson of the 6th Women in Diabetes Conference, or Wodcon. I'd also like to thank Dr. Vijay Neglur, Chief Advisor and the Program Director. I'm very honored to give this talk at this meeting because Dr. Benny Neglur told me that I'll be one of the few males to be speaking at this meeting. It's an all women's meeting, I understand. I've not spoken before at this meeting, and therefore I'm very privileged to be among all of you all to give this talk. And I also have some new data to share with you. The topic of my presentation is clinical profile of type 2 diabetes in women. Is it different? And this comes to you from Dr. Mohan's Diabetes Specialty Center. I'm just going to show you 2 slides about the INDIAB study because you've all heard about the INDIAB study. And the INDIAB study is important because it is perhaps the largest diabetes epidemiological study ever done in the world, definitely the largest in India. Also, it's a representative study. That means all the 27, 28 states, 2 union territories and national capital territory of Delhi are included. That means the entire country is included with a sample size so far of 113,043 individuals. That means 113,000 individuals in a representative epidemiological study. That's why I said it's the largest epidemiological study. And of course, Dr. Anjana, whom you all know, who's also speaking at this meeting, is the chief author and the main architect behind this study. I'm just showing you 1 or 2 slides from here, just to show you the status of the prevalence of diabetes in India in males and females, males in blue and females in pink, in urban India, in rural India, and all over. And this is based on more than 1 lakh individuals. You can see that the prevalence of diabetes in women is slightly lower than in men, not appreciably so, but it is slightly lower in the urban areas, in the rural areas, and therefore in the total. There's not a huge difference, and we really don't know what this difference is due to, but many studies have shown that in men, the prevalence of diabetes is slightly higher. But when you calculate the large populations, it doesn't mean that women are exempt from diabetes, and there's a huge load of diabetes in women as well. And as I'll show you in the rest of the talk, in fact, there are special challenges as far as women and diabetes is concerned. Now, the data I'm going to show you today is new data. It has not been published before. And, we are talking about a real world study. You may say in an epidemiological study, you'll get certain things. Of course, it's representative of India, but that's not what we see in our clinic. To our clinic, different types of people get referred. There are some studies from India published earlier, but most of them are small studies. Now we have to match something like what INDIAB had. So again, the data I'm showing you now is based on our clinical records, just in a 3-year period between 2017 to 2019. And it's based on nearly 1 lakh diabetic patients, 100,000 diabetic patients. The aim of the study was to compare the clinical and biochemical profile as well as the complications in men and women with type 2 diabetes presenting to a tertiary diabetes center. So this is the kind of clinical profile I'm sure that all of you who are diabetologists will probably be seeing in your own clinics. Now, getting straight into the data, what the slide shows you is the prevalence of or the distribution. I can't call it prevalence because it's it's a clinic-based study. But what is the distribution of the males and the females with diabetes across our clinics stratified based on the age group? And you can see in blue is the males, and in pink is the females. And you can see that at younger age groups, if you see 25 to 34 years, 35 to 44 years, it's the men who have the frequency of the distribution in the men is higher than in the women. But after that, by age 45 to 54, which clearly coincides with menopause, you can see that the women are taking over now, and there's a greater distribution of the diabetes in the women compared to the men. And this remains so almost up to 65 years and beyond. So this gender difference, if any, of the males presenting earlier to the clinic at younger age groups is completely nullified by age 45 years. By this time, the women are now the ones who have the higher prevalence of diabetes. Now, this slide shows you some general characteristics. The age of these close to 100,000 people in the clinic taken from our electronic records, about 62,000 males and 36,000 females. Now you may say, why is this big difference? Is there any bias in this data that there are so much more males than females. I would request you, unless you're running a special women's clinic, I would request you to look at all your data, and you will find, because this has been consistent over the last 40 years for us, that males tend to visit the clinic more than females. And this again is one of the gender biases, where women will say, it's okay, my health is not that important. The husband should go because you're the, the wage earner, usually. Now, of course, it's changing, but generally, the men, if they get any disease, including diabetes, they tend to go to the clinic first, and the women tend to stay behind. So this ratio of about 62:36, that kind of a ratio has been constantly at our centers for the last 30, 40 years or more. Now, of course, the men are taller and the men are heavier, but if you look at the body mass index, which is a more representative index of the weight of the obesity than the weight itself, you'll see that in the women, clearly the BMI is higher. So the main BMI in men is 26.3, where it's 28.2 in the female. So clearly the BMI is higher. So obesity rates are higher in the females. Now, again, that is shown here, that if you look at extreme obesity, more than 30 BMI, it's only 15% in the males, whereas it is 31%, almost double. 11,000 women out of the 36,000 have a BMI more than 30. So here's the first message for all of you, that obesity is increasing very rapidly in our clinic population, and therefore the challenge of treating type 2 diabetes in women is definitely there, and we'll see that as we go along. And therefore, maybe even the use of certain drugs which help to reduce weight, like the SGLT2s or metformin or the GLP-1 receptor analogs, etc., may be needed more in the males than in the females. And of course, we need more data from that. Now, if you look at non-vegetarian percentage, not much difference between males and females. But look at physical activity. Now, if you look at the number of women who are not doing any physical activity at all, among men, it's 47% who don't do any physical activity. It's almost 60% in the women, 58.7%. And if you look at the men who get more than 150 minutes a week, this is what the WHO recommends that they should be getting. Quarter of the men, 25%, are getting their 150 minutes per week, as compared to 12.9% of the females. Again, it is half of the women, who are only 12% of the women are getting even 150 minutes a week. We all know that's not enough. It's only 30 minutes a day and 5 times a week. Even that, only 12% of our women who are coming to us, our clinic being a private clinic, is a relatively middle class and above clinic. And even in that population, hardly 12% of the women are doing enough physical activity. Not surprisingly, smoking is much, much less in women. Alcohol is also very much less. Probably if you go to rural areas, you might find it's a little higher, but clearly it's a male-dominated thing, the smoking and alcohol. And there are not too much differences between men and women as far as the treatment is concerned. One would think women are not taking insulin or something, but we could not find much of differences. So our treatment pattern is concerned, it's almost the same. Now let's look at the actual level of control. Now, if you look at the fasting plasma glucose, it is worse in the females. Postprandial plasma glucose is worse, and HbA1c is also worse compared to males. Now, we all know that women have a higher HDL cholesterol. That's a kind of a quality test for this data. And you can see that the HDL cholesterol mean is 39. That's why the cut points for low HDL is below 40 for men and below 50 for women, as you know. So you can see that the males are also having low HDL and the females are also having low HDL, although in absolute terms, the HDL concentrations are higher in the women compared to the men. The LDL is also higher in the women compared to the men. But the ratios are a little better because the HDL cholesterol is higher. There's no difference in the renal function between men and women. Now, this again shows you a stratification of 3 glycemic parameters: fasting plasma glucose, postprandial plasma glucose, and the HbA1c. Similar to the data which I showed you earlier, you can see that at younger ages, up to about 35 years of age, it's the men who have higher fasting glucose, much higher postprandial glucose, and higher HbA1c. But you can see again by age 44 or 45, the women take over now, and their glucose, fasting glucose is worse, their postprandial glucose is worse, and their HbA1c is worse. So there's something protecting women. Maybe it's the estrogen, I don't know what it is. As far as the cardio-metabolic, the abnormalities are concerned, the younger women seem to be protected. But by the time you come to the age of menopause, women are just like men, if not worse than men. Now, interestingly, we had some data on asthma and COPD. No big difference between males and females. Surgery, we saw whether it was more in males and female, major surgery, and no big difference between males and females. But look at cancers. The overall cancer, if you take all cancers put together, and of course, being a retrospective study, we could have missed a lot of cancers, both in the men and the women, no doubt about that. But having said that, in the men, and the same way, just like you miss in the men, you can miss in the women also. And therefore, these rates are probably much higher, I would submit to you. And also, this goes back over a period of time. So maybe the cancer rates were low and now it's increasing. But having said all that, the cancer rate overall in men was 0.6%. It was 1.3% in women. And this for large numbers is very significant. There's a doubling or increase, double the rate of cancer is seen in women compared to men. And obviously, breast cancer and cervical cancers would be on top of the list. We are trying to get a breakdown in a more granular manner between the differences in the cancers between men and women. Of course, it will need a much more detailed study. We are doing some studies on oral cancer, and that also we'll be able to show you. But overall, cancer rates are higher in women compared to men. Look at hypothyroidism. Now, it's not that the women get screened more for hypothyroidism or the men get screened more. The protocols are the same for men and women. And again, we don't do a thyroid function test in everybody. I cannot tell you that in all the 62,000 males and all the 36,000 females, we did a thyroid function test. Many may not have been able to afford. But from this data, 3.5% of men have hypothyroidism compared to 12.5, almost 4 times higher hypothyroidism in women. I might have suspected it, but I didn't think this difference will be so much stark. And I think this is the first data on such large numbers in a diabetic population showing that hypothyroidism is much more common. Now, looking at the complications rate, again, the screening for the complications is the same, both in men and women, not that men get screened more or women get screened more. But if you look at the overall retinopathy rates, it is lower in females. Neuropathy, slightly lower. Microalbuminuria, almost the same, maybe slightly lower. Peripheral vascular disease, not much of difference. And cardiovascular disease, not surprisingly, much higher in men. And this is definitely significant. So you can see that despite the higher, slightly higher sugars and the HbA1c, the complications, virtually all the complications, microvascular and macrovascular, if anything, slightly lower in women. We know about the cardiovascular. We know that estrogen protects. But why the retinopathy, nephropathy, and neuropathy should be slightly lower in women deserves attention. And we'll be looking into this, whether there are any genetic factors and so on. Data on this size of sample, to my knowledge, has not been reported. So definitely it's worth looking into. And this is another way of looking at the complications. We have calculated the odds ratios and given here the confidence intervals, the odds ratios here, and the confidence intervals shown in brackets here, and the level of significance. and we have taken males as the reference. So if anything, if the females have 1, that means it's the same, complication same. It's more than 1, that means females have more, and less than 1 means females have lower incidence of complications. And you can see retinopathy, nephropathy, neuropathy, it's all lower in females, 0.67, 0.90, and 0.76. So what does 0.67 mean? There's a 33% lower occurrence of retinopathy. What does 0.9 mean? 10% lower. Neuropathy 0.76 means 24% lower. Cardiovascular disease 42% lower. Peripheral vascular disease not much a difference, just reaches statistical significance about 0.8% lower. And therefore, to conclude, ladies and gentlemen, this brief presentation of mine, but based on very large numbers, I would like to tell you that the number of men presenting to diabetic clinics outnumber women. And this is clearly a gender bias in those coming for checkup to private diabetes centers. I've seen this earlier when I was working at my father's center, and I've seen the same thing here. And I'm sure all of you are seeing the same thing. At younger age groups, diabetes prevalence is higher in men, but after age 45 itself, these age differences disappear. Overall obesity rates much higher in women compared to men, and this can have therapeutic significance. Physical activity rates very much lower among women. Control of diabetes was worse among women. Hypothyroidism and cancer was much more among women, but in general, complication rates, both microvascular and macrovascular, seem to be less common in women. So my take-home messages from this brief presentation is that we definitely need more focus on women with respect to control of diabetes, and probably do more detailed studies. And another point I'd like to make is that at the diabetic clinic, we have a wonderful opportunistic opportunity for opportunistic screening for hypothyroidism and cancer. 12% of women having hypothyroidism, even without doing it as a prospective study, it'll probably double if we do for all women. And cancers, for all women above, say, 40 years of age, if we routinely screen for at least the common cancers, breast cancer, uterus cancer, cervical cancer, and so on, doing pap smears or mammograms or whatever you think is relevant, I think we can pick up a lot of cancers and thereby reduce the morbidity and mortality in women. And I think the diabetic clinic can be taken as a kind of a platform to screen for cancer as well. And that, I think, is my last slide. And I would like to thank all of you, particularly Dr. Benny Neglur and Dr. Neglur for inviting me for this very prestigious Wodcon conference. And I wish your deliberations all success. My plea to you would be, come up with definite plans of what needs to be done in women, circulate it to diabetes centers like ours, what kind of projects need to be done, what kind of support needs to be given. Among women, I suppose you'll discuss more freely among this, and let us all try to implement that so that we can help our women to improve their health, at least as far as diabetes and its complications or the comorbid conditions, coexisting conditions are concerned, because a woman is the fulcrum of the family. And if we improve the health of the woman, the health of the whole family can be improved. So on that note, thank you once again and goodbye.
Thank you so much, Dr. Mohan. Indeed, a fantastic data that you have presented, and this is presented for the first time. So Wodcon is very lucky to have this data with us. And surely, sir, we will follow your advice. I think we will build up some initiative with Madam also, Madam Usha, to build up a data and chalk out what should we do to improve the outcomes. So I invite Dr. Vijay Panikar, who will introduce Dr. Shashank, who will be our next speaker.
Hi, good afternoon. Shashank doesn't need introduction. I think he's omnipresent like Omicron everywhere. And he's going to talk on Omicron, Tu Chupi Hai Kahan. Shashank has been he's currently the IDF Southeast Asia chair. He has been president of the Indian Academy of Diabetes. He was the former president of the Association of Physicians of India, RSSDI, and the obesity thing. And most importantly, he was awarded the Padma Shri in 2014. He has published numerous publications. And he's a genius actually. He knows. His IQ is very great. He doesn't eat much. He's on nuclear fuel, but he's a wonderful speaker. And more important than that, he's my friend. Shashank, it's all over to you. Where are you? Shashank?
At the onset, I would like to thank Dr. Benny Naglur and the entire group of women team, and I wish all women very happy International Women's Month. The topic allotted to me, though I'm an endocrinologist, is Omicron third wave, will another wave come? A lot of Omicron COVID is predictably unpredictable, and what I say today may not hold true tomorrow. Whatever I'm going to do in the next 10 to 15 minutes is going to give you a very quick overview of where we are in terms of Omicron, and then probably I'll be happy to answer any question and answers which will be there on the same. Now, Omicron had two features. One was there was a feature of camp which was inevitability, that it's mild, it is not virulent, it causes very mild disease, there is no need to worry, all pills can work, and there is a lot of hybrid immunity. And there is also an avoidance gap that, hamsters, mice, cultures are not equal to people. People who are aged, immunocompromised, and which is what we are seeing in UK, we are seeing in Asia, we are seeing in Europe, people are dying. And, the breakthrough infections are quite a lot. And most medicines are not available. And that is the avoidance camp. But clearly, Omicron was a new variant. It had more than 30 spike protein mutations, and multiple parts of the virus got mutated with more than 50 viruses. Probably came from Africa, Botswanian region, and was detected in South Africa. It had an edge in target failure, clearly which was evidenced. And therefore, compared to the earlier variant, which was beta, gamma, or delta, which were far more virulent to the lungs, this new variant, which is Omicron, probably had more transmissibility, immune invasiveness, but was less virulent, caused nose and throat COVID, but did not cause lung COVID at all. So fastly transmissible, super mutant are not unknown, replaced Delta completely on planet Earth, is more transmissible. Clearly breakthrough is common, immune escape is common, and immune escape is common both for natural infection as well as for vaccines. However, the severity and virulence is less. Clear trends now available worldwide, and we can see that the third wave from India is almost gone, and this is how it replaced completely in South Africa the various things. So compared to the Delta, which had far less mutations, Omicron, you can see here in this graph, is flooded with it. But the people who are most vulnerable, even from Omicron to die, are elderly, male gender, hypertension, diabetes, obesity, chronic heart disease, COPD, asthma, chronic lung disease, chronic kidney disease, chronic liver disease, any congenital or acquired immune deficiency conditions, people on steroid or immunosuppressive drugs or transplant recipients. So obviously the comorbidities amplified the risk of hospitalizations, and clearly this virus had a clear-cut 500-fold viral competitive advantage. Now, there has been a term used by others called Deltacron, which is a mixture of Delta and Omicron, but that's not true. No other virus is now currently in a variant of concern or variant of interest. In Israel, there has been a diagnosis and detection of a new variant, but still it is under investigation. But currently, globally, what is prevalent is predominantly Omicron, and some parts of the world also have Delta. Alpha, Beta, and Gamma virtually disappeared. There are three types of COVID which we get. People who are totally unvaccinated, no past history of COVID, are called naive infections. People who are vaccinated partially or totally or had a booster dose are called breakthrough infections. And people who are reinfected are called reinfections. Now, the old COVID virus, 80% had mild or no symptoms, 14% had severe symptoms, and 5% needed ICU care. However, in the Omicron world which we live today, there are three variants, BA1, BA2, and BA3. Worldwide, it is BA2 which is prevalent. In India, BA2 and BA1 almost had an equal prevalent. Initially, BA2 was seen in East India and Central India. Now it was seen all over India. In Mumbai city, where I live, almost 100% is BA2. 95% is mild or no symptoms. Only 4% get severe symptoms and only 1% need ICU care. And obviously it is the robust immune system which works very well. And most of the Omicron is restricted as mild stage 1 disease and very little is as a stage 2 disease. Of course, we are in the evidence-based medicine era and space. And in that space, the medications are very few. The simple tip for every COVID patient is to isolate and do a simple CBC with red cell width and NLR with a CRP. If they are elevated, obviously you need to chase. And if you are in a vulnerable group, you need to admit. And the pulse oximeter is the key. So the COVID Vital Care 7 is if there is fever, if there is tachycardia, if there is tachypnea, if the blood pressure or sugars are high, if the pulse oximetry 6-minute walk test is positive, and be connected with digitally with the patient. Pulse oximetry is the key. And the old COVID timetable was 7 to 14 days and 14 to 21 days. But the new COVID timetable is 5 to 10 days. Post-COVID, however, long COVID is still seen in Omicron for 3 months. It is the right approach, right time and right medicines. Don't rush for antimicrobials or antiparasitic agents. Insist on talking to the patient on the phone. Don't forget antiplatelet statins, anticoagulants in high-risk cases. Save every life. Obviously, inhaled steroids have a role. And it is the risk, high-risk patients like senior citizens, COPD, cardiometabolic diseases, obesity, CKD, immunocompromised who need to be cared. Very high vulnerable populations like solid organ transplants, blood cancer and active chemo patients, dialysis, immunosuppressive therapies, primary, they are the ones most likely to die. And therefore, there are a lot of therapies now. Antivirals are available, oral injectable, antibody therapies are available, anti-inflammatory therapies are available. But home isolation is the key. Isolation is the key. Managing people at home is the key. There are a lot of very good guidelines by Ministry of Health, Government of India. But who should be hospitalized? Somebody is breathless. Somebody has persistent fever for more than 3 days. There is a desaturation, persistent pain on the chest or pressure on the chest, mental confusion or severe fatigue and myalgia. And obviously that is the key to admit. Mild cases can be managed at home alone and then they can be discharged. Moderate cases have their own thing. There are excellent advisories for everybody available. Monoclonal antibody is very popular in the Delta wave, but may not be very, very efficient as far as the Omicron wave is concerned. And it is most useful in people who are at risk to deteriorate or die. Obviously, these data is emerging in Omicron and Delta world too, but people who are highly vulnerable, probably the monoclonal antibodies might make a difference. As far as the antivirals are concerned, molnupiravir is an oral agent. Hit hard, hit early it's a chain terminator event. And in senior citizens above 50, if they have comorbidities, and particularly there is persistent fever, more than 24 to 48 hours, it may be worthwhile giving molnupiravir. It's a simple agent to be used. 4 tablets of 200 milligrams for twice a day for 5 days. But don't use it in young people, don't use it in pregnant people, don't use it in people planning reproductive outcomes, so on and so forth. The important thing about molnupiravir is in day 3, the viral load drops down dramatically and the person becomes non-transmissible, beautifully absorbed, safe and tolerated, no drug-to-drug major interactions. Don't use it in pregnancy, lactation, pediatric populations. Can be safely used in renal hepatic impaired population and geriatric population. So obviously it's a reasonable agent to be used and has been available now in India. The nirmatrelvir and ritonavir had just got approved this week by the government of India. It is again a protease boosted, ritonavir boosted protease inhibitor. Excellent results. It is fundamentally 2 tablets of nirmatrelvir 150 milligram with ritonavir 100 milligram. All 3 tablets taken twice a day for 5 days. This will be available in India soon in the next month and can be very beautifully positioned in the same way as molnupiravir. So if you look at the monoclonal antibodies, molnupiravir as well as the Paxlovid, these are 30 pills over 5 days, and they reduce the risk of hospitalization by 10 to 7% in molnupiravir, that is 30% efficacy, while the Paxlovid will reduce the risk of hospitalization from 7 to 1% or 85% efficacy, and monoclonal antibody reduces the risk of hospitalization from 10 to 3% and 70 to 80%, but is only useful for Delta. Omicron, the data is not available. Injectable remdesivir is also another popular agent. 3 days you can give it intramuscular also, and that data has been shown to be useful. So we have a lot other agents, of course. I'm not going into details of that, like steroids, etc. And I would like to really thank the organizers that we still are talking about COVID. Though COVID probably has gone, 2-3 things are very clear cut. The first thing with the current Omicron is that in India, the third wave is over. But we still need to be on the guard. There is a lot of natural as well as population as well as vaccine-induced immunity. But there is a large unvaccinated population which can still harbor the virus and can cause deaths. So we need to go to a world which will be a zero COVID death world and zero severe death or severe illness from COVID. That's the first principle. The second principle which we need to understand is worldwide, there is still Omicron around and there could still be a new variant of concern. So as far as masking is concerned, as far as distancing is concerned, as far as air ventilation is concerned, as far as vaccination is concerned, we still need to follow COVID appropriate behavior. It is very unlikely that in the next 3 to 6 months, there'll be any major wave in India unless and until a new variant of concern emerges and we break all COVID appropriate behavior. Stay safe. I'm very much with all of you. I once again thank Dr. Neglur and her entire team of all the ladies. My salute to all the ladies. And I really thank them for allowing me to present a very quick glimpse of Omicron, what's new today. And I'll be more than happy to answer a lot of questions and some pearls of wisdom. Thank you very much.
We will be taking the questions at the end of the session, isn't it, Penny?
Yes, I think so.
Yes.
Dr. Shashank is not here, no? He told me that
Yeah,
he will
he's-
take his
he's
question.
He's joined. He's joined.
He's joined?
Yes, ma'am.
Okay, then he will take his question because he will take his question and then we can go to the speaker, next speaker.
Why are you in a mask, Shashank? Are you in some danger zone?
No.
Can you hear me?
Yeah. I'm in a meeting, another meeting.
Okay.
Well, Vijay, what's your question?
No, the question is, are you forecasting a fourth wave anytime in the future?
So as far as India is concerned, it's most unlikely. We do have a lot of Omicron still around, the BA2 variant. What we are seeing in South Korea, China, is all BA2, which we had in mid-December to mid-January. So the likelihood of another wave coming in the next 3 to 6 months is most unlikely unless we get something called as a recombinant. Recombinant means a Delta and Omicron getting together, like what they have picked up in Israel. But all this is a very low probability. So I see that it is unlikely a disruption which may occur because of any other variant coming, unless we get a new variant like Omicron very quickly, very rapidly. But if you ask me, with the current population immunity, natural and vaccine related both, the likelihood of a disruption in India is very low probability in the next 3 to 6 months.
Good to hear that. Any questions, anybody?
Yeah, Dr. Shashank, will this be a vaccination which will be annual now? We have already taken the third dose.
We don't know. It could be annual, it could be every 6 months. The vaccine data is early generation. Current vaccines are not sterilizing vaccines. Current vaccines could be either related to preventing severe disease and death. So we don't know what is going to be the frequency of dosing. In Israel, they have given 4 doses. Pfizer has recently recommended 4 doses. But these mRNA vaccines are not very robust. They see a lot of breakthrough infections. Covaxin data is yet to come. But I think the nasal vaccines, which will come in, will be sterilizing vaccines, and they will be the way to go. So I think we need to wait for another year to know the pattern of vaccination strategy. But vaccines will be needed either annually or every 6 months or seasonally. But COVID is likely to become cyclic or seasonal. As it goes, it will stay with us and it will become endemic.
Can I ask questions, Shashank?
Yeah, Vijay, go ahead.
Yeah. The Tata Diagnostic have introduced the OmiSure diagnostic method to diagnose Omicron. How it is important in present pandemic when the routine genome sequencing takes quite a lot of time. This is quite rapid. What is your opinion about this?
So it basically picks up the H gene mutation and the deletion of the H gene. So it has its limitations because BA1, BA2, and BA3 are the 3 variants of Omicron. And because these are 3 variants of Omicron, only the BA1 and BA3 are picked up by the H gene deletion of OmiSure. While the BA2, which is a Sleeth variant, which is the one which is dominating, is not picked up. But it's an easy tool to know. So a lot of people get OmiSure positive and they are negative and they think it is a delta, but it is not actually a delta, it is a BA2.
It can't pick up B2. Yeah.
You know, there are other labs like the ID lab in Thane, etc., which can actually pick up to complex PCRs, a rapid diagnostic, but it costs 8,000 rupees. So very clearly we see that you are right. You can use it as a tool. If it is positive, it is good. If it is negative, it doesn't mean BA2 is ruled out.
Yeah. Thank you.
Thank you, Shashank. I think, Benny, let's go to the next speaker.
Next speaker, Mary, Dr. Mary.
Yes, I'm here, Dr. Benny. Yeah. And good afternoon, everybody. It is my privilege to introduce the next speaker, Professor Dr. Krishna Seshadri, an American board-certified endocrinology, diabetes, metabolism, and internal medicine consultant at Chennai Diabetes and Endocrine Clinic. He's recipient of the P.N. Shah Oration of the Endocrine Society and Dr. Sam G.P. Moses Oration of RSSDI. Has funded translational research currently on circadian rhythms and metabolism. Associate editor of the Journal of Diabetes in Developing Countries, editor-in-chief Thyroid Research Practice, editorial board member, Indian Journal of Endocrinology and Metabolism, member of the Curriculum Expert Group, National Medical Council, and his technology interests are clinical decision support device and EMR. He will be speaking on the impact of metabolic inflexibility on diabetes. How may we regain flexibility? Professor Krishna Seshadri.
Can the most asked question in any conferences, can you see my slide?
Yes, yes.
Yes, we can.
You hear me. Thank you so much, Dr. Neglur, and everyone else in this organizing group for inviting me to this very, very important conference and allowing me to tell my story. So this is an interesting story, and to talk about metabolic inflexibility, we need to go back a few million years to understand what is it that we have disrupted. So this is my agenda, a little bit about human evolution, a little bit about sleep and light, we'll talk a little about metabolic switches and flexibility, a little about its clinical correlates, and of course, I will leave hopefully enough time for you to at least whet your appetite on the questions. I'll finish probably by tomorrow morning. The first question, the first thing to ask ourselves is we are on the top of the evolutionary chain in many ways. Still, of course, we confront a lion in front of us, but we are on the top of the evolutionary chain. And we have done this by two things. Three things. One is by standing up, but that's actually a co-product of the other two things. The first thing is that we developed a very large brain, right? The second is that we gave up progeny. If you look at, we have some of the least amount of, we gave up having a lot of progeny so that we can devote time to building up the progeny that we have and providing them an evolutionary success. And that is why adolescents last, in my case, up to 54 years. I'm still dependent on my mother. And therefore, and for many of us, it lasts much longer. So we and the chimp are the only species that have known adolescence. We and the orca whale are the only species that has life beyond menopause. Elephants in captivity. So we have a large brain and we have less kids. Now remember that the brain is like a fetus. It's an obligatory glucose consumer. It takes ketones, we can talk about it, but it loves glucose. And therefore, we needed to make sure that glucose is available to the brain all the time. And for glucose to be available to the brain all the time, two things happen. One is a mechanism for the other organisms not to suck out the glucose. And we started storing a lot of fat. So whenever there is a need where glucose is not in demand, the fat comes to the rescue, provides an alternate source, but there is a mechanism to divert the glucose to the brain, and that's insulin resistance. When a cell becomes resistant to the action of insulin, it cannot take up glucose, it has to use fat obligatorily. Now, generally, when is glucose not available? Glucose is also not available when you are under stress. And therefore, the body knows only one way to respond to stress, and that's inflammation. Any kind of inflammation, whether you eat more, whether you're sick, ill, you have Omicron, you have any other microns, or you abuse your body, there is inflammation. I've talked about it in very, very, very many settings. But just to tell you that the link between insulin resistance and inflammation is quite high. Why is it? It started as a phenomenon to divert fat to these organs and divert glucose to the brain. You should be clear that similar things happen in pregnancy. But so with this basic information that we have, let us think about the things that we have done into playing with nature, and then I will move forward. We have started consuming more food, more frequent food, a change in the quality of food, processed food. We are the only species that eats and hunts and kills for pleasure, right? We live to eat and not eat to live. We have more light, less sleep, disturbed sleep, a change in the circadian rhythm. We have less physical work, more sedentary time, more screen time. We have greater stress, no downtime, and we have less sunlight. So clearly what is happening is that a hardwired, long-standing, evolutionarily conservative mechanisms, which are there to protect us and they're interlinked, have become predatory. So as we start storing fat, one of the things that happens, and I won't spend too much time on it, is that, remember I said the fat and insulin resistance, accumulation and insulin resistance go in hand. One of the first things that happen in these fat cells is the change in the mTOR pathway, which is a very protective pathway, remember. When this is present and it causes insulin resistance, obesity adds to it. The first thing that happens is MCP1 gets transcribed. Nothing to do with the men. It's got everything to do with monocyte chemoattractive protein. This occurs here, and then it causes the macrophages in the bone to start producing cells that come into the abdomen. And the Jugalbandi results, that is both in the adipokines and the cytokines, that leads to fat becoming ectopic. This I have spoken in many fora. But let's talk a little more about this light sleep cycle, because I think that is the key to understanding metabolic flexibility. It's not something that we did not know. It's something that we have overlooked because of our obsession with Western science. We forgot some of the things that our ancients have talked about already. Here is Charaka, Nidhrayatham Sukham Dukkham, Pushtihi Karshyam Balabalam, Pushta Klabita, Klibata Jnanam, Ajnanam Jivitam Nacha. Happiness, misery, nourishment, emaciation, strength, virility, sterility, knowledge, ignorance, life, and death depend on proper or improper sleep. We spoke about it many years ago. And this is, of course, the Rig Veda that talks about sleep as being like a tree in which the birds come to rest. So why is sleep necessary? So if you see a big hotel or an airport, you realize that the deep cleansing occurs at night when no one is there. Sleep is a mechanism by which the body can be cleansed of its toxins. What we know, and there's a beautiful article, I don't know if those of you who've not read it, Huzel et al., amazing work. It took her three months or the above to train a rat to be able to sit still on a confocal microscope and actually go to sleep. What she showed was the brain shrinks its size by about a third, allowing the channels to be exposed and the CSF to go deep into it and cleanse it. And that's really what sleep does. It's a housekeeper of the brain. But it's not just sleep. It's probably also light. And this is the Aruna Prashnam, which is from the Taittiriya Upanishad. That's it. Sarvasvad Bhanavadhari Tasya Paka Visheshana Smritam Kala Visheshana. That light and heat comes along with it are the keepers of time. And why is this important? That these rhythms are maintained by the light sleep exposure. One of the earliest studies in diabetes by Ken Polanski, I remember this article as being one of the first I read as an endocrine fellow, a decade later almost, and how the rhythmicity in diabetes is changed. One of the earliest things that occur is the insulin-glucagon reciprocity, which Roger Unger so beautifully talks about as lost in diabetes. That there is a circadian rhythm to insulin and everything else, and that rhythmicity is the first thing to be lost in diabetes. This is again showing circadian misalignment in glucose tolerance, very early studies. And it's linked to inflammation is well known, because you see this particular study, this is showing what happens to the human transcriptome in patients who are sleep restricted. And most of the ones that are upregulated are inflammatory neurons and inflammatory proteins. Indeed, if you change an animal from a light dark to a dark light cycle, you will see that the insulin secretion is altered, it's lower. This is the islets, remember? And if you have also predisposition to diabetes, this becomes worse. Our own study was published about 10 years ago, that talking about a change and an association between the A1C and the quality of sleep. Recently, we did this particular work in animals, and thanks to my colleagues, especially Dr. Balaneru, for having done this work along with us. And what we did was, we looked at animals, we looked at fisher rats. Remember, rats are night feeders, but what we did is we reversed their cycle. But we also put a few of them in the G3 group on a nurse's shift. Of all the people that we take care of, the nurses are affected the most, because they have rotating night shifts. And see what happens. This is the glucose. These are the triglycerides. This is the cholesterol. And can you see that in the group that has the rotating night shift, see what is happening at the end of 3 months. But here is something even more. This is the pancreatic beta cell. Our original objective was to look at FOXO and its transcription, and whether this was being mediated by FOXO. But just to let you know that we didn't find FOXO translocation in this particular study. But what is interesting for you to review here is, this is the pancreatic islet. This is normal circadian rhythm, normal looking pancreatic beta cell. Already hypertrophied beta cells with some amount of change occurring in the reverse light period, light to dark or dark to light. See what's happening in the nurses group, or the rats that are pushed to the nurses shift. Actually, fragmentation, vacuolation, and degradation occurring in these particular rats. So that brings us back to this very ancient cycle, which is the energy sleep cycle. It's preserved, it is hardwired, it's present in all of us. That, depending on whether you're a night feeder or a day feeder, you have X amount of work that you've done during the light, and X amount of conservation, rest, and recuperation and recharging that has occurred during the dark. Glucose in plants, glucose is the ultimate product of photosynthesis. And therefore, during the light cycle, it accumulates. And there is a cleansing activity and recharging activity that occurs during the dark. That's true of metazoa and all the others. This is mediated by the clocks that are present in both the central as well as in the peripheral clocks, and these can all be done. Why is this? My physiology teachers would tell me that the ultimate purpose of life is conversion of ATP to ADP in black. And this is done in the powerhouse, which is the mitochondria. And remember that there is a movement of the ions through the respiratory cycle, ultimately leading to a leak of a single ion, very small amount of reactive oxygen species that are produced. And this is maintained, and normally this is supplied by the TCA cycle. When glucose is present, its entry is pyruvate. When glucose is absent, its entry is acetoacetate. So the liver is a supplier of glucose. If you fast, so the liver supply actually stores about 700 to 900 calories, right? And it takes about 14 hours for it to be exhausted. And then fat takes over, or 6 to 7 hours for it to be exhausted. Then fat takes over. And then fat oxidation occurs, and it enters through acetoacetate, and ketones being one of the important parts of this. Many of us who started using AGPs, many of us saw that the glucoses were getting unusually low and not picking up at the night. That's simply because during extended fast, the glucoses actually do go that low. What is important and something that we have learned just recently is that glucose and fatty acids, they control their own metabolism. When glucose is high or even detectable to a large extent, it promotes its own metabolism and it suppresses fatty acid metabolism. When fatty acid is present, it promotes its own metabolism. The ability of not being of the glucose metabolism continuing, despite when it is not required, is something that we call hysteresis. The translation of this word hysteresis can be called the legacy effect or the metabolic memory effect, where the glucose propagates its own metabolism. But what we now know is that, for example, glucose is present. When it's increased, right, it works through pyruvate. It suppresses pyruvate dehydrogenase. And what it does is the insulin that is present also suppresses fatty acid. The place where it enters the cycle is pyruvate. The fatty acid cycle occurs. There is no hydrogen ion leak. There is not much of ROS. And it works. On the other hand, when glucose is absent, fatty acids are present. They work predominantly through PPAR alpha, and importantly, this particular enzyme, carnitine palmitoyl transferase 1A, they suppress the pyruvate dehydrogenase. They increase acetyl coenzyme A and enter the cycle. There is a slightly more ROS production, but what it also does at this particular point of time, it stimulates autophagy, it stimulates longevity, and it does all of these. What we know in diabetes, and sorry for the lack of reference, is that when you have diabetes, right, the flexibility of the cell to switch from glucose to fatty acid is reduced. Why does this occur? It occurs because of glucose increasing its own metabolism, and therefore there is no movement from glucose metabolism to fatty acid metabolism. At some point of time, both of these start occurring together. When these occur, this is not efficient, and therefore at some point of time, the hyperglycemia itself induces tissue damage. So normally there is a coupling of the respiratory chain. A small amount of uncoupling occurs to allow the hydrogen ion to come in and to be released. But if this occurs excessively, you have ROS. And therefore, one of the basics and fundamentals of beta cell dysfunction is the respiratory chain dysfunction that occurs because of excessive uncoupling that occurs in the UCP2 mRNA. So when you have a lot of fat cells and you have glucose that is present together, the body moves from a state. So when you're eating all the time, when you're not giving a clear difference between a fasted and a feasted level, not allowing fasting to occur for sufficient amount of time, eating after sunset, when your metabolic switch has to take place, and light being an important part of the switch, sleeping at odd hours, eating at odd hours, having bedtime snacks. Just to give you a simple example, in ancient India, there were only 2 meals, right? One in the mid-morning and the other before sunset. Why? How do we know that? We know that when it's offered in the temple, there are only 2 mantras. One, in the morning, Satyam Tattvena Parisinchami, I offer it as truth. Same, truth in a different word. The evening, Ridham Tattvena Parisinchami. Again, and remember, there was a tradition of offering food and then eating. So only 2 meals and nothing in between, right? And that's really what it was. That's really, really, really what it was. And what happens when you do that, when you break this ancient cycle, a lifestyle that is not aligned to our ancestors, not just necessarily humans, but also the plants and the metazoa from which we come from, you get metabolic inflexibility. So what is happening here? Glucose is still present. Fatty acids are still present. What does glucose do when it is in excess? The FOXO, which is a beacon of the environment, goes in and it tries to retain glucose metabolism because the body sees glucose as a very desirable fuel. And it does this through the MODY genes. And then it tries to suppress fatty acid metabolism. But at some point of time, the glucose, the FOXO disappears, these MODY genes disappear, and glucose and fatty acids have a free run. They are both promoting their own metabolism. Both of these things are happening at the same time. There's a greater degree of rage-induced damage. There's a greater degree of ROS production. At some point of time, the beta cell decides, look, this is not worth it. This guy is not respecting me. Let me go to sleep. And the beta cell actually de-differentiates. And it waits for many years like a faithful wife, waiting for the husband to become better. But what it does at some point of time is it gives up and dies. It either de-differentiates or dies. And that's why you have diabetes. So this is exactly what happens. Just to sort of summarize here, when normally what happens is when you remove glucose and amino acids, fatty acids are present, and that's the time when cellular protection occurs, a RAGE is removed, you have the SIRT1 is operated and longevity occurs. We have data about longevity up to the non-human primate. We don't have primate data. So one of the things to take home, besides all the other things, do not eat more, respect light, sleep well, is also to sort of eat at the right time. As again, our ancient said, there is an important about kala. Everything has its time. So when you eat in a time-restricted fashion, allowing a longer period when you don't eat, this is Drosophila, this is animal data, again showing lower cholesterol, fasting glucose, body weight, inflammation, dysbiosis, increase energy expenditure, increase motor control, increase sleep and cardiac function. This is human data, again, accumulating a huge amount of human data is coming, small studies. A time-restricted feeding, either 12 is to 12 or 12 is to 14, right? Showing A1C improvements, fasting glucose improvements, weight improvements. A larger study, again, showing the same amount. This is a 14 is to 10, showing eat for 10 hours a day, restrict for 14 hours a day, stay better. Very, very improved glucose in these studies. So what can we do? We are very, very early into this data. Even though this is very ancient data, we are early into it. What should we do? One, respect ancient cycles, right? If you don't need the light, don't have it. Don't sleep with yourself. Try to restrict your eating, especially if you're not in a sulfonylurea, if you're a non-diabetic. After sunset, the closer you eat to sunset, the better. Don't eat food as an entertainment. Food is something to let you live. It's not something to. It's not. We waste food. We waste resources. And then we talk about sustainability. We waste so many resources we have, and then we talk about sustainability. Intermittent fasting, the data is out there, still needs refinement. But you have an ancient tradition of fasting, keep it. Exercise is a way to improve your ketones, providing alternate fuels. In fact, exercising while fasting is something that I'm getting more and more fascinated about. I end a fast day with a bike ride. Works. I can't swim, but I can do the other things. Or at least I'm not. I don't have the guts to go into a pool after having fasted. Ketones, SGLT2 inhibitors are one way, but fasting is a way to improve ketones. And then ketone drinks are available, and ketone drinks seem to sort of be a metabolic switch. Medium chain fatty acids, especially with the C8, the closest we have to medium chain fatty acids in Indian cuisine is coconut oil. Something we have been dissing, but remember, coconut oil seems to be a metabolic switch. In the future, we will have some drugs like mitochondrial modulators. We wait for them. But the sooner we start aligning with nature, the better we become. There's an ancient thing called Langanam Paramaushadam, but this was really said by Bhagavata for Jvare Vatisareva. But we can learn that fasting is, we all think about increasing caloric intake during illness. A lot of data is coming about using lower caloric intake in ICUs and other places. So our ancients had something right. We look up the West for lots of things, including for them to appropriate yoga nidra and pranayama and call it cardiac coherence breathing. Instead of dissing our own culture, we should start learning how to create science out of it and trying to find out the evidence and bring it back into our lives. Thank you so much.
Thank you so much, Dr. Seshadri, for that elegant talk, and particularly focusing on sleep and how the molecular effects take place of disturbed sleep in glucolipotoxicity and beta cell damage. In fact, the Institute of Medicine declared sleep deficiency and sleep disorders as an unmet public health problem. And thank you so much for addressing both the needs for time-restricted eating and sleeping adequate hours. With that, I think this session comes to a close. If there are any questions.
Yeah, we are open to questions because I mean, such a fantastic talk, Dr. Seshadri. I think you have opened eyes and we should all eat early before sunset now. Even at the conferences.
Can I ask questions, Seshadri?
Yes.
May I?
Can I before? Vijay?
Yes, Vijay Negro, yes.
See, there's a saying that you have a heavy breakfast or you have breakfast for yourself. Then you come to lunch, you share with your friends. When it comes to dinner, you give it away to your enemies. So this has any relevance to the talk that you gave of the time and day and night effect that occurs because of melatonin? Is there something in relation to that?
So there are very hardwired, as I said, remember that ultimately we all evolved from unicellular organisms and we learned how to synthesize protein and the greatest source of energy in the world is sun. And it's not just melatonin or any other hormone. I think at a cellular level there are clocks that set the mechanisms. So these clocks are hardwired. They are in us. It is reset by the vagus and others. But what we have learned is that the metabolism resets these clocks. For example, we are now doing a study where we're looking at PER1 gene and others, and their expression based on the glucose and the fatty acids. So we know that it's bidirectional. That melatonin and others are probably markers, but I think hard set is metabolism.
Good. Yeah, Vijay.
Yeah, Krishna, beautiful talk, beautiful. It's an eye opener, and I felt that meri to vaat lagi, because I'm not following any of these things. I have a very late dinner. I sleep very late. Of course, I go for a walk every day. But what I want to ask you is, can this clock be reset according to your requirement?
So there are lots of other things involved. I think one is, there are things like chronotypes. There are people who are meant to party like you. And there are people who are meant to suffer like me. So, so the chronotype is probably important. But can it be reset? Can someone move from just a day to a day night? I think yes. If you maintain the consistency, you can retrain it. There is also, you can probably also cheat on it by having specific times of light exposure and other things. But there's nothing like aligning with nature in many ways. So let's say you are a night worker, then you actually need to sit with someone and work out your time in which, okay, this is how I'm going to eat, this is how I'm going to sleep, this is when I'm going to have a light exposure, and then probably you can retrain your clock to that. But doing things randomly and not giving adequate time in between, not giving and doing it like how the rats that we treated like nurses behaved is going to take a toll at some point of time.
Dr. Seshadri,
you may have some protective mechanism that your mother has given. Remember, the big influence is your mother and her mother, and since and her mother and her mother. So 14 generations our microbiota are maternally inherited. This is from C. elegans data, not human data. But we know that there is epigenetic imprinting occurred. So if your mother had, and her mother had led disciplined lives, Dr. Panikkar will benefit. But what part Dr. Panikkar does, or Mrs. Panikkar does, will change the things for their children.
Dr. Sheshadri, just a question on women who are nursing their children after birth. How does that affect them for, say, the next 6 months or so? Does that sleep disturbance also translate like shift workers?
See, remember that it takes a while for some of these to get established, and I think my view is that 6 months it probably gets reversed. Right? It does get reversed.
Great talk. Great talk.
Yeah. But I think I have reset my rhythm.
Can I ask one question?
Yeah.
Dr. Sheshadri, great talk. Just one question. Is artificial light exposure same as sunlight exposure?
No, absolutely not. I think it is not. But it has been used in things like in travel across time zones, where charts are available for you to use to expose to a strong source of light to reset your clock for a short period of time. And remember, a lot of this is early evolving information that we have. This whole idea of spending time and looking at circadian biology and its link to metabolism, especially the kind of stuff that I'm talking about is not very interesting. So, and including things like hysteresis, most people have not looked at. I think Manoj Chavla. Yeah.
Yes, Krishna. Hi. Can I ask a question?
Sure.
Right. So Krishna, the role of Krishna in Hindu mythology and ever since has been not only to poise questions and challenges, but also to give solutions. So for lesser mortals like Dr. Panikkar and myself, who are going to continue to eat late and sleep late and have the kind of lifestyle, what is the mantra to survive?
So remember, both of you are part of probably a small group of people who are on the extreme right-hand corner of the Gaussian distribution curve, right? And many of us select ourselves because we are on this right-hand corner and become physicians. The kind of rigor that we go through, most others can't, simply because we have selected ourselves to be that. We have chosen because not that we are some elite, but we are capable of extreme masochism. For the others, especially, are people who want to have a good life and have their weekends and their families and grandchildren and children. I think one of the things that has been lost in our vocabulary is the word discipline. We have become woke enough to think discipline is a bad word, but it's something that needs to be cultivated. It's very difficult as an adult to learn not to eat at specific times. We don't have to do it for Panikkar and Manoj. We have already reached a certain part. You and both of us are on our downward climb. I think we need to sort of message this out for the younger ones, that having a disciplined life does not mean it's a bad life. That there are much more greater ways to enjoy life than just having a food and a drink.
Great message.
Krishna.
This is like
Can I comment something?
Yes, ma'am.
Very good, very good discussions. I didn't hear your talk, but I've been reading about these clocks and what they do. And at a cellular level clock, that was almost surprising to me. I think that discipline is required in diabetes management also. It's so important to have discipline. People don't realize that. Not only the time of eating and this, and one of them told me when I said eat early before 8 o'clock or 9 o'clock, they said, you want us to be Jains? I said, you don't become Jain by eating at 6 o'clock or 7 o'clock. You could eat well. But I enjoyed this discussion. Thank you very much.
Let me just conclude. Just one more thing. See, it is very interesting for us to it is very difficult for us to take Eastern constructs and put it back into science. But taking Eastern constructs, giving them the Western yardstick of evidence, and then incorporating it back into our patient's life is probably a challenge for the next 30 to 40 years in medical education. If we don't do that, we will have to live with cardiac coherence breathing and all the other beautiful words that the West constructs for us. And we will feel cheated out that our heritage has been taken over by someone else. I think that is a plea that I have for all the academics here. Thanks.
Thank you. Thank you very much.
Well said, sir.
Thank you so much, Dr. Seshadri. I think you have invoked maximum questions, and we need to put this topic at all the conference fora. And I'm sure I'm going to repeat this topic again next year. Thank you so much, Dr. Mohan, Dr. Shashank, Dr. Krishna, and also the chairpersons, Dr. Panikar and Dr. Mary. So we close this session now, and we go on to one of its kind, the next session. Dr. Ami will take it further.
So after such an insightful session, we go on to the next session on one of its kind, where I invite the chairpersons. We have Dr. Lotika Purohit, Dr. Seema Bagri, and Dr. Manoj Chawla, all three consultant diabetologists from Mumbai. I ask Dr. Seema to take over now. Seema.
Great pleasure to invite Ms. Shilpa Joshi ma'am. Ma'am is the director at Mumbai Diet and Health Center. She's a practicing dietitian, diabetes educator. She's a vice president, Indian Dietetic Association, honorary secretary, All India Association of Advancing Research in Obesity, master trainer in diabetes conversation maps, course director, National Diabetes Educator Program from 2010 to 2019, trained more than 3,000 diabetes educators, presented at various national and international meetings, including American Diabetic Association and International Diabetic Federation, International Confederation of Dietitians. Ma'am is a runner-up recipient of Wim Hammer Cunningham International Essay Award 2017 of the Academy of Nutrition and Dietetic Foundation on malnutrition. Today, ma'am is going to talk on managing glycemic variability with diet in type 1 and gestational diabetic. Over to you, ma'am.
Thank you so much, Dr. Seema. Okay, thank you. At the outset, I would like to thank Dr. Benny and Dr. Vijay Neglur for having invited me here and making me part of this conference. I hope my slides can be seen. Can my slides be seen?
Yes, ma'am.
Okay. Yeah. Thank you so much. And I'm going to be talking about how to manage blood sugars or glycemic variability in type 1 and type 2 diabetes and type 1 diabetes and GDM. So glycemic variability actually means the swing in blood glucose level. Glycemic variability takes into account intraday glycemic excursion that includes episodes of hyper and hypoglycemia. Postprandial hyperglycemic excursions to contribute to glycemic variability. And what is very important to understand glycemic variability is monitoring. And monitoring studies have shown that it is not simple routine methods to measure blood glucose level and can become useful only when feedback from results are incorporated into self-care. Now, usually what happens is this self-care includes medicines which are changed by doctors, but a lot of times diet is not taken into consideration. And that is what I'm going to dwell on, certain dietary issues which may elevate glycemic variability. So these are a lot of things which are there, but I'm going to dwell on some specific ones. One of them is poor matching of carbohydrate with insulin doses. This is very, very true in type 1 diabetes. About 70 to 80% of patients actually do not match carbohydrates to insulin or insulin to carb, whichever way. And dose of insulin is not actually changed, whether it is rapid acting or short acting, to match the food intake. Now, this is a very, most common example that we get. So there are two meals. For example, there is a breakfast option. One can be of poha and one can be of an egg white omelette and a roti. Both of them are breakfast options which are used. Both of them are similar in calories. If you look here, there is 250 calories coming here when you're consuming about 60 gram of poha or raw poha, which is cooked, and it is giving you about 250 calories. And one roti, 2 egg white omelette with 100 ml of milk is also giving you about 260 calories. But if you look at their carb content, it is very, very different. So one is giving you 42 grams of carb, whereas other is giving you just 26 grams of carbs. And you will find that for the same insulin dose, if people eat such variable breakfast on 2 days, one day they are going to get very high blood sugar, and on another day they are going to get their blood sugar within the range, depending upon what was their pre-meal blood sugar. So not matching carbohydrate with insulin, although these meals are similar in calorie, insulin requirement for day 1 and day 2 breakfast will be very different. So what are the solutions? The first solution is insulin to carbohydrate ratio. Rather than following a fixed dose of short-acting insulin, it is important that patient calculates insulin to carbohydrate ratios to account for change in carbohydrates in their diet, because we see that Indian diets are so heterogeneous. There are so many options and they are so full of carbs that you need to have insulin to carb ratios to account for them. And they can be done by using the rule of 450 or rule of 500. Another important thing, especially in management of type 1 diabetes, is weighing foods. It's very important that the patients weigh food to understand carb content in it. Use of insulin sensitivity factor is also important to account for high pre-meal blood glucoses or for correction of blood glucoses between the meals. We do insulin sensitivity factor by using a rule of 1500 or 1800. If there are recurrent hypos, look for wrong or overestimation of carbs or taking overlapping doses. So if patients are taking doses one after the other and they are overlapping, they can cause recurrent hypos. And recurrent hypers can have when patients are underestimating the amount of carbs or they are snacking frequently. And I'm going to show you 1 or 2 examples of what happens when patients snack equally. So carb counting becomes a great tool for a person with type 1 diabetes to liberalize eating patterns and lifestyle. It is an essential component in type 1 diabetes management. Now, irregular snacking is a very common mistake made in meal planning and meal adherence. Planning of snack has to be matched to insulin mode of action, especially when rapid acting insulin is given. If regular insulin is given, then snack can be managed by splitting the dose of splitting the carbs in the main meal. If rapid acting insulin is given, snack, however healthy, now this is something that the patients always talk about, that if we are having snack, we are going to have it very healthy. Maybe we may have fruit or, or an egg. It doesn't matter. However healthy it is, it should not be given as it leads to high postprandial blood sugars. In such case, minimal carb snacking in very small quantity can be offered, like a boiled egg white or a non-starchy vegetable like cucumber and celery, or very few nuts like walnuts and almonds. But the bigger problem is the understanding of the concept of snack. In India, snack is not, having walnut or almond or a cucumber or celery or a boiled egg white is not considered a snack. And that actually becomes a problem, because then the postprandial sugar or pre-next meal sugars are very, very high. So this, you will find that typically if the blood sugar breakfast is taken, insulin is taken, the blood sugar comes down. And in snack, the insulin is not taken. So pre-lunch, sugars are high. Then again, insulin is taken, sugars come down. And then again, person snacks for which there is no insulin. And again, the sugars go high. And you will see that you began down somewhere. And then you ultimately land up with high blood glucoses. And if snack are not planned within the meal, if individual wants to snack here, then these snacks should be accompanied by doses of insulin. This is very, very common in case of younger children who eat breakfast at home before going to school. And in the school, they take a snack box. And for this snack box, typically there is no insulin and their pre-lunch sugars are very high. For lunch, they will take insulin just for lunch and then they will again eat snack. If such snacks are eaten, even if the snacks are healthy, it is important that the insulin is planned for the snack. So in basal bolus therapy, consumption of snack without accompaniment of insulin is really not recommended. And this is something that patients do it almost most of the time. Then meal pattern is, these are examples with rapid acting insulin. For example, somebody is eating a mung dal chilla, which is again a low carb option with milk as a breakfast and taking insulin as per IC ratio, but will have a snack at around 11 o'clock, maybe around an apple or something, and no insulin because they don't want to take an extra prick for it. Then pre-lunch sugar is going to be high. As opposed to that, if the person is having a mung dal chilla with milk and takes the apple in the breakfast itself and then does not snack, pre-lunch sugar will be much better. So no food and fruit together typically is something that we talk about in type 2 diabetes management, not in type 1, especially on rapid acting insulin. If insulin is regular, then maybe this eating an apple or any fruit here would have been advisable. But if it is just a rapid acting insulin, this is not going to work. Now, amount of carbohydrate, quality and quantity actually impacts glycemic variability because of the release of that carbohydrate into the blood system. Now, this is very, very, it is very important when you talk about quantity of carbohydrates. So one cannot replace recipe. And if they want to replace a recipe, then grammages have to be kept constant. I think this is something that you must be seeing in your practice, all of you, very, very frequently. It's a big surge that millets are very, very good for you. And hence what people are doing is they're replacing their chapatis with millets. Now, one chapati typically is 30 to 45 grams in weight, which typically gives about 100 to 150 calories when made without fat. Now, typically this chapati is replaced by a bhakri, which is made from jawar, bajra or ragi, whichever it is. Now, to make a small bhakri, you need at least 60 grams of millet. So you have actually increased the amount of carbohydrate in the meal. This is going to give you 200 calories and 42 grams of carbs. So you have actually increased carbs here. And this is because millets lack gluten and it cannot be rolled, but it is patted. And therefore, you cannot use less atta to make it. And this is a big problem. Why when people shift from chapati to bhakri, blood sugars actually start rising instead of coming in control. So replacing one wheat roti with one jawar roti will always increase blood glucose as quantity of atta is more. This is a recipe replacement. This is not isocaloric replacement of carbohydrate. If somebody is happy eating half a bhakri, probably sugars will come better. So carbohydrate quality, this was quantity, but this is now quality. Keeping grammage constant, it's very, very important to replace less processed food to give a better glycemic control. So for example, semolina should be replaced by dalia. White oats should be replaced by steel cut oats. Maida should be replaced by whole grain atta. Bread, even brown bread, should be replaced by roti. Dosa, which is made from rice batter, can be shifted to dosa, which is made from moong or besan chilla or adai. Poha, which is made from white rice, should be shifted to brown rice poha. So on and so forth. Just white rice should be replaced. Just chapati bhaji should be replaced by chapati bhaji and dal, something like this. Now, the four challenges that we have in type 1 diabetes is lactose intolerance. A lot of them actually cannot handle milk. Even paneer, a lot of them cannot handle to varying degree, curd to varying degree. So the options that are there in the market now are lactose-free milk or almond milk or soy milk, tofu or cashew curd. Lot of them, about 80% of them will be gluten sensitive. So then you will have to replace their wheat, semolina, maida, bakery, hing, again with millets and rice, which is tolerated. Lot of them also come with raffinose intolerance. That is, although, they cannot handle most of the pulses and dals. So therefore, most of them can handle moong dal or matki. And then for protein sources, you have to give them isolates of pea protein or soya protein, or lactose-free whey and casein can be given in case there is raffinose intolerance. Now, this is carbohydrate restriction, effect of carbohydrate restriction on glycemic variability. You will see that when individuals eat things like poha, there is a huge excursion of blood glucose. But when this is replaced by, say, something like sprouts, the blood glucose excursion is very, very minimal. And this is why replacing carbohydrate for a poorer carbohydrate source, not that sprouts don't have carbohydrate, they just have carbohydrates, a different kind of carbohydrate, and also in lesser amount. And therefore, these being long acting will not give a high rise in blood glucose. So again, these are breakfast option. This is giving about 42 grams of carbs and 250 calories. This is giving 26 grams of carb, 260 calories. I alluded to this example even before. So as the carbs change, you will see post-meal sugars will change. So that is something for meals of similar calories. Prefer ones which have a lower amount of carb for a better blood glucose control. Now, as far as GDM is concerned, morning blood glucose control in GDM women is not great. This is because a lot of them also typically eat a biscuit or khakra or raisins or dates on rising because they are nauseous. So they have been told to eat something dry. Like 90% of women who come to us for GDM diets will tell that they were advised to eat a biscuit in the morning because they were nauseous. So replacing these foods with nuts or chana or sattu or boiled egg whites actually gives better glucose control. Avoid giving carb-rich meals as first meals in patients with GDM. In some, even milk causes elevation of blood glucose due to lactose, and they just cannot handle it. Since PP sugars are a huge challenge in women with GDM, split carbs equally in all the meals. Okay, so these are just meal planning principles in GDM. First thing is recall is a must. I think Salome ma'am alluded to it yesterday in her talk. But if you actually go by ICMR recommendations, that's too much of food. So start where the client is eating food, because if you go and increase calories, blood sugars are definitely going to increase. There is no need of adding extra calories in the first trimester. If the patient is not on insulin, distribution of carbohydrate equally is very, very important. Early morning meal should be minimal carb. Avoid fruit, even dried fruit, as the first meal, as there is a lot of increase in blood glucose, and splitting meals is very, very important. So this is how you go. Dietary calories is equal to recall plus 150 to 300 calories only in second or third trimester, out of which carbs will be only 50%. And this is something which is very important to understand. And it is very important that even in vegetarian patients, the carbs are maintained to only 50% of calories. You can even go up to 45 for really good glucose control, but then you'll have to take care of the ketones. If the ketones are positive, then you have to again go back to 50 calories, 50% of that. Fiber, 14 grams per 1000 calorie. This is again very important, and my slides will allude to that later, that eating fiber in every meal is important. It is not only for lunch and dinner. Proteins up to 0.8 to gram per kg body weight. Again, and distribution give in 6 equal meals having equal amount of carbohydrate so as to prevent glucose excursion after any single meal. Okay, so this is again something. Avoid simple carbs like bread, biscuit, ready-to-eat cereal, poha, upma. They increase blood sugars a lot. Salad should be part of each meal, also including breakfast. A lot of people feel breakfast, you don't need a salad, and then post-breakfast sugars are very high. So it's very important, not more than a fruit a day. No meal, even snack, should be eaten without a protein source. So if you're giving a fruit, give nuts with it, give chana, give egg white, sattu in water, yogurt, whatever it is. But it is very important to give a source of protein with even a fruit. And something for all women with GDM, sugar is equal to brown sugar, is equal to jaggery, is equal to honey. They are all carbohydrates and they have same amount of carbohydrates in them. So this, because there were, for the lack of time, I'm going to just go on to just some pictures. Fiber is must in every meal. So whether it is breakfast, whether it's lunch, whether it is a snack or a dinner, try to include fiber-rich sources. So rather than eating these refined carbs as breakfast, whether it's bread or paratha or poha or idli, try to have breakfast which are more complex, because women tend to eat in GDM, tend to eat a bigger breakfast because they are hungry. So there should be egg whites, there should be a salad, there should be a omelette or sprouts, or this is mung chila with lots of vegetables in it. But it is important that these things are included. Ratios are very important. If you look at this, this is a complete thali, but look at the carbohydrate portioning, it's very high. As compared to that, this lady herself changed her diet from here to very small carbohydrate portioning to have improved blood sugars later on. Then snack option, instead of even khakra, which people think is the epitome of healthy snack option, or Mari biscuit, which is again thought to be epitome of healthy snack options. I think snacking with some amount of protein in it is very important. Again, these are pictures taken by my patients who had GDM. So this is the kind of snack they have. And this is a video. I think this is something, how to serve your plate, whether you have diabetes or no diabetes. I think this is something which I talk to my patients all about, and just going to show you this. So it's very important that your plate is full of fiber and protein and very, very limited amount of carbs. That is something which is very, very important while serving yourself a plate. Whether you have diabetes, you don't have, you need to prevent it. And that is when for every 2 portions of fiber and 2 portions of protein, there should be just 1 portion of carbohydrate. And that actually helps you to maintain your blood glucoses. So simple messages go a long way. This is called traffic light system of explaining the clients how to eat healthy. So masala dosa, not a good option. Dosa with sambar, a better option. Lots of sambar with 1 dosa, even a better option. And this is something which, so ghar ka khana is always the best meal plan. And the conclusion is meal planning is an important aspect of management of type 1 and GDM both. Tweaking the homemade meal is important for long-term sustenance of diet. Right carbohydrate distribution helps to reduce glycemic variability and hence maintain a better HbA1c and reduce complications. Thank you so much for a patient hearing.
Thank you, ma'am, for the excellent insight on this topic.
Shilpa, lovely talk as usual. But I must say, today, Sunday afternoon, I'm at my mom's place to eat Sindhi kadhi and chawal. And you are giving me major guilt trip right now.
No, I'll tell you what to do. For 2 bowls of kadhi, half bowl of chawal.
Yeah, I love my chawal also. I don't do that. And I love the fried khicha papad also on the Sunday. So
Let's say chawla.
Super, super.
So Dr. Manoj, can you take up for the next speaker?
Of course, yes. Thanks, Ami. A great pleasure to introduce Dr. Alok Kanungo. Dr. Kanungo is the Chief Consultant Diabetologist, Chairman and Managing Director at the Kids Diabetes and Multi-Speciality Hospital, Bhubaneswar, Odisha. Dr. Kanungo did his PhD in diabetes from the prestigious Karolinska Institute at Stockholm, the one which honors the Nobel laureates. He's had more than 100 publications to his credit. He's the chairman for the Indian Consensus on Insulin Therapy for Type 1 Diabetes. I know Dr. Alok Kanungo very closely, an elder brother, and extremely passionate about his treatment and his beliefs for Type 1 diabetes. So it's wonderful to welcome Dr. Alok Kanungo for the next talk at Wodcon. Dr. Kanungo.
Thank you, Manoj. Thank you very much for your excellent introduction. At the beginning, I want to thank Benny Madam and Vijay Sir for their excellent collaboration and to start such a wonderful program. I want to thank Purvi for all the support she has been giving for the conference all through. And I'll just take 1 second. And I want to thank my chairpersons like Benny Ma'am, Latika Purohit, Seema Bagri, and you, Manoj. So after an excellent talk by Shilpa, it has become really interesting to know that how to go about things. 1 second. I'll just go to. Can you see this? Not yet.
Not yet, sir.
Not yet. 1 second. 1 second. So this is a new topic, not the new.
Sir, sorry to interrupt you, but your slides are not visible yet.
Yes, sir.
Do you want the RX team to share it for you, Dr. Kanungo?
Can do, but they do not have my slides.
Yes. Sir, what kind of problem you are facing?
I have gone to slide share mode, and then I'm not getting this. It usually happens properly, but 1 second. So I share, it goes to application. From application, it should be there. It's not there, so I can.
Are you not able to see your particular presentation, Dr. Kanungo, after doing the slide share screen?
I have not seen it yet.
Do you want to cancel it and then restart? Open your presentation, minimize it, and then restart sharing the screen and selecting it.
Or sir can mail it to RX events and they
Yes, yes, sir.
I can do that.
Dr. Benny, Shefali, Ami, you all want to utilize the time while Dr. Alok is doing that. Shilpa is still here. I'm sure many would have questions for her.
Shilpa, are you here?
Yes,
Shilpa,
yes.
are you here?
Yes, I'm.
Okay, Shilpa, you know, a lot of my pregnant ladies, when you ask them to split meals, they eat more. They eat breakfast, then again after 2 hours, and again in the afternoon, and again. So it becomes hard actually to control the carbohydrates. Even the, nutritionists they don't even listen to the nutritionists actually. So it is very hard to explain the splitting meals. So how do you go about telling your patients that?
So typically what I do is I tell them that, so if they're eating lunch, at a point, depending upon what is their caloric intake, they can eat only half the carbs. So typically if their meal is 1 chapati, dal, rice, sabzi, then they can eat only half. Obviously after 2 hours they get hungry, and then I tell them to eat other half. It is boring, but I tell
Shilpa,
them.
sorry, Dr. Kanungo, we are able to see your slides now. Sorry, yeah. No, Shilpa, I just thought I'll tell him that we can see your slides. Shilpa can finish her answer and then we can start with you.
Okay.
So ma'am, typically what I tell them is the same meal. Once you eat it with dal salad, once you eat it with sabzi and dal, and you eat that same portion of the meal.
Manoj, can you see my slide?
Yes. Thank you.
Yes, sir. Yes, sir.
Yes.
Yes, sir, we can.
Just want to.
Yes, sir. Yes, sir.
Okay.
Maybe you want to download it. It was opening up in the non-PPT format. Just download it and then full screen and you can. Yeah, now full screen and we are good to go.
Right. Sorry for the inconvenience.
Sir, it's not a slideshow, sir.
Dear friends, and as I have given the introduction, I will not take more time.
Dr. Kanungo, you can just do the full screen. It's still not full screen. If you can just do...
Sir, there is a button called present.
Yeah, present. Yeah, excellent.
So dear friends, my topic is a really little thought-provoking topic, because a young type 1 diabetes has to become younger and then become adolescent and adult. And there is a transition. And how do they face it? How do the families cope with that? What is the change in other things? And I will cover them in the headings like diabetes incidence and prevalence in children and adolescent transition, transition in type 1 diabetes, challenges of navigating to adulthood with type 1 diabetes. A young adult with type 1 diabetes is facing challenges in transition to adult care case scenario. What are the recommendations for transition of care? what is the ADA recommendation of 2022, and how the adult care providers, what is their perspective. Dr. Mohan has already spoken about this, but one few small thing, the estimated incidence of type 1 diabetes among children and adolescents is increasing in many countries, particularly in those aged less than 15 years. And you can see this red color is more than 30%, and it is seen in the Saudis. And if you look at less than 5%, this light blue color, we are India, China, and many other countries in South America, they are less than 5% for 1 lakh population. So gradually it increases. Soviet Russia is 10 to 20, Scandinavia, this Sweden and all those things. And gradually this is the situation. And if you look at America and Australia, the incidence is 20 to 30 per 1 lakh population. So this is a very important issue now. And in India, if you look at the incidence, it is 15.9, whereas if you are to look at the prevalence, it is 95.6 in between the 0 to 14 years of age group. So what is a transition? We all know that during this stage, children often start to grow more quickly. These body changes can inspire curiosity and anxiety in some. And the aims are to provide care appropriate for age and development, to help child to develop skills in decision making, assertiveness, and self-care. Child is growing and he always say, I am a young adult. To improve sense of control and independence with regards to child's health, to maximize child's capabilities. And there you can see in childhood, the child is inside the family. And adolescent, he has his own world, but still family is a part of it. And after adulthood, patient has his, the young type 1 has his own world, and family has a connection with him. So what are the issues for him? His issues are employment, independent living, community inclusion, health criteria. His aspirations are raised, his plan of services are together, and develop a shared vision with the society. So this is a new challenge for the young child to become adolescent and then adult. So in transition of type 1 diabetes, the emerging adult with type 1 diabetes are at increased risk for poor health outcomes, because there are so many issues that his health is facing. A transition from pediatric to adult healthcare providers. His doctor is also changing. His clinical nurse is changing, and many things are happening. He's no more going to a pediatric clinic. Due to the complexity of your young adult life, as individuals with type 1 diabetes enter the workforce, leave home or start college while learning to manage the disease on their own. Many children come to me with their parents that after the child has gone to hostel life, after matriculation or after +2, his food is or her food is purely potato based, and they are facing so much of difficulties in diet. So those are the issues. Type 1 diabetes exacerbates the effects of those behaviors, increasing the risk for acute and chronic complications. Routine of living with type 1 diabetes affects the way young women view themselves. This is a bigger challenge for young girls, often making them feel different from their peers, despite the desire to feel normal. That is a big challenge for young girls. And what are other challenges? How to navigate to adulthood with type 1 diabetes? There are two bigger challenges: mental health needs and managing day-to-day life. In mental health, we find the child is feeling different, stigma of diabetes is hunting him or her, and chronic illness burnout. skin thickness reducing, skin allergies, skin infections, not looking that fresh. That freshness is less in many children. Of course, some type 1 children look very good, and the beauty queen of US was a type 1 diabetes few years back. So that's, and many of our cinema heroines are type 1 diabetes, heroes are type 1 diabetes. So beauty is not affected, but in poor setup, some children do get affected. The biggest challenge is glycemic control and hormones. That has to be challenged, as Silpa has very well described how to maintain the control the glycemic status, and how diet has an important role in that. Exercise is important, sports is important. Many children and their parents believe that their child cannot play, but you will be surprised to know and happy to know that many of the Olympiads were type 1 diabetics. So that is no problem in that. After the discovery of infusion pumps and insulin pumps, that has become much easier. Weight control, behaviors and diet. In India, less weight or underweight is a problem, bigger problem in type 1, but higher weight or overweight is also a problem, and how diet can manage that is a big thing. High risk behaviors are important. You cannot always go on telling the child, don't do this, don't do this, don't eat this, don't behave like this. No, you have to tell what to eat, how to behave and all those things. And parenting is very important in that case. In psychosocial stressors or barriers, up to 33% of adolescents aged 18 to 30 years will report depressive symptoms. It is existing, and we find one of the girl who is my patient, 11 years, and after learning more about type 1 diabetes, she's an excellent dancer. She's a very good, beautiful girl, but she told her mama that why at all this diabetes came to me, and a lot of things. I had to take a lot of counseling, and her parents are so good, they cooperated. Depression is associated with poor glycemic control. Adolescents with type 1 diabetes have significantly higher rates of anxiety, diabetes associated distress, and eating disorders than their peers who do not have diabetes. In fact, in young children, depression is a very rare thing, normal children. But in type 1, quite sizable, maybe 30%. It is also important to be vigilant of the high risk of eating disorders and substance misuse. The substance misuse is very important. Recently, some cases were there where children were caught in the ship and they were using substance, and that was just a scenario. But many type 1 patients subject to themselves with friends for substance misuse. And what are the barriers of management of young adults with diabetes, and common clinical challenges facing physicians caring for young adults with type 1 diabetes are many. Fear of hypoglycemia, recurrent decay, obesity, starting a CGM, continuous glucose monitor, elite athlete, if you are an elite athlete, how to do it. Developmental disabilities do exist. Depression is very prominent, and eating disorder and substance abuse. In this cartoon, you can see lack of expertise is a very minimum role, whereas inadequate resources is playing a major role in this. So we still do not have adequate resources to handle this. A young adult with type 1 diabetes is facing challenges in transition to adult care. Soti is a 22-year-old young adult who was diagnosed with type 1 diabetes when she was 10 years old. Then Swati, as an adolescent, she has struggled with body image and feeling awkward at school because of her type 1 diabetes needs, like taking insulin and continuous glucose monitor. She has generally maintained glycemic control within targets, but as she has become more independent, she has not been self-monitoring her blood glucose regularly or following her dietitian's advice. Then what steps would you take to help your patient take the next steps in her health care? So that is very important. And there are few recommendations. Start preparing youth for a coordinated transition in early adolescence by collaborating with the patient and family members at least 1 year before transitioning to adult health care. Emphasize diabetes self-management skills like monitoring of blood glucose, administering insulin, scheduling appointments, maintaining medications and supplies with a gradual transfer of diabetes-related case responsibilities from parent to adolescent. You should give your child more opportunity to handle her problem. Provide the patient and adult care provider with a written summary. Tell them everything starting from medication, post-glucose levels, diabetes-related comorbidities, referrals during pediatric care, and an active problem list so that the other caregiver, an adult caregiver, will know your patient and will tell everything. Provide support and resources that can be benefit the patients, including psychosocial support, vocational support, and educational resources, as well as resources that can help them reconnect to diabetes care if they become lost to the follow-up. And recommend different educational resources to help engage the adolescent patient, such as age-appropriate written materials, text messaging, online resources, social media, peer involvement, and group learning. One point of caution, more you go to the social media and internet, the child has different access to different problem creating visuals that has to be taken care of. Offer culturally sensitive information on the effects of type 1 diabetes on employment, driving, sexual health and contraception, and alcohol and drug use. You should be free with your child, with your young children. As educators, as doctors, as family, you should tell them everything so that they will confide on you and tell you their problems. Cultivate regular collaboration with healthcare providers in adult care setting. Keep parent and guardians involved in care transition, especially during adolescence. Few more slides. ADA 22 recommends pediatric diabetic providers should begin to prepare youth for transition to adult health care in elderly adolescents and at least 1 year before the transition. But in our country, the diabetologists are taking care with the help of pediatrician from the day one, and gradually diabetologists are taking over the child's problem. There is nothing, we don't have much of adult caregivers. Both pediatric and adult diabetes care providers should provide support and resources for transitioning young adults. Assess youth with diabetes for psychosocial and diabetes related distress, generally starting at 7 to 8 years of age. That is an early age, a tender age, when you should look for social or psychosocial stress. Mental health professionals should be considered integral members of the pediatric diabetes multidisciplinary team, like clinical psychologists, not doctors per se. Adult care providers' perspective is very important, but it should be communication, assessing the new patient's needs and knowledge, using a team-based approach, addressing the psychosocial needs of the young adult, and building rapport with a long-term relationship. So to summarize, diabetes-related stigma is linked to worse glycemic outcomes and more psychological distress. Lack of psychological support during the transition stage, coupled with a sense of being different, may contribute to a perception of stigma. Providing opportunities for emerging adults with diabetes to interact with peers who also live with diabetes may be one of the way to enhance a sense of normalcy and decrease the stigma. That is very important. That is why we all have created diabetic support groups among themselves. Support from parents, peers, coaches, and providers improve adolescent comfort level with care transition. Though Sarda has many coaches in her group, and she has possibly all these groups in her practice. Udan. Clinicians should encourage autonomy in self-care and address psychosocial challenges, normal development changes, and high-risk behaviors, all of which can impact the health outcome. Thank you, friends. Thank you so much.
Thank you, Dr. Kanungo, for that excellent talk on a very important topic, which very often all of us fail to recognize. So thank you. Do we have the type of questions now or later, Dr. Benny?
I think, can we move on to the next session because we are running late to the panel discussion? Ami?
There was a change, ma'am, if you can just discuss that change. Dr. Archana Sada, ma'am, will not be coming.
Yes, you can say that. We'll miss Madam Archana Sada because I think there's a crash with her computer. And so we are trying to connect to her, but all her PPTs and all her data is on the computer and she's unable to connect with us and unable to give the talk. So we can move on to the next session.
Yeah. So thank you, speakers. Thank you, chairpersons, for conducting this session. And we move on to the next session now. And I invite Dr. Shilpa Joshi to kindly take over.
So good afternoon, everybody. The next session is going to be on Pandora's box. And just to understand what Pandora's box is, so Pandora's box is actually an artifact in Greek mythology. Okay, so Pandora is supposed to be the first lady on earth, according to Greek mythology. And her husband had given her a container to be kept. And like all of us, when the husband was not around, she opened that container. And that container released all the physical and emotional curses on mankind, which is sickness, death, so on and so forth. So therefore, anything that looks ordinary but may produce unpredictable, harmful results can be called as Pandora's box. And we know that diabetes is one such box that when you have it, when you open it, then you have a whole lot of complications, sickness. And that is why Benny ma'am has so aptly named this session as the Pandora's box, for which I'll invite my friends and the scientific chairpersons of this meeting to chair the session, Dr. Purvi Chawla and Dr. Shefali Karkhanis. Over to you, Purvi and Shefali.
Thank you so much, ma'am, for that warm invite and the lovely introduction to Pandora's box. So coming up next, we have the Pandora's box. Ladies and gentlemen, if you notice, the theme for Wodcon 2022 is unraveling the Pandora's box. And now we have a very thematic session around it. So setting the context for this session will be our very own Dr. Sarita Bajaj ma'am, and with her talk on oral health and the correlation with cardiometabolic status. And following that, there will be an illustrious panel joining her for a panel discussion with Dr. Prema Vartakavi ma'am, who's unable to actually join us, but we will also have Dr. Alka Gandhi, Dr. Mary De Cruz ma'am, Dr. Padma Menon ma'am, Dr. Dhruvi Hasnani, and Dr. Seema Bagri. So introducing, it's a great honor and privilege to introduce Dr. Sarita Bajaj ma'am, who's been the president of RSSDI 2016 and 17. She's also been the founder president South Asian Federation of Endocrine Societies, which is called SAFES. She's also the president of, she's been the president of Endocrine Society of India 2010 and 11, editor-in-chief ESI Manual of Endocrinology, and has been revered with the Professor Sarita Bajaj oration established in 2018 in RSSDI, also achieved several important awards, including the Lifetime Achievement Award for Outstanding Services in the field of diabetes and metabolic disorders. Importantly, she's been a beacon of encouragement and light in the world of women and diabetes. With that, I welcome you, ma'am. We also have Dr. Alka Gandhi joining the panel. She is the founder, director of Ayushi Diabetes Clinic, consulting diabetologist at Nama Hospital, and speaker and national faculty at various conferences. Also conducted various public awareness camps and CME lectures for physicians, and is well published in several local and international journals and conferences. She is the member of managing committee of UDF and a scientific committee member for Women in Diabetes Conference, very own Wodcon, and special interest in Gdm and diabetes for the young. Welcome, Dr. Alka. Dr. Mary DeCruz, ma'am, is a physician diabetologist, president of Diabetes Research and Welfare Association, DRWA, which is a very active association with several CMEs on various aspects. Ex-vice president of APR West Bengal chapter, certified physician for DG Shipping, Government of India, lead auditor for the ISO systems, and community mental health diploma from NIMHANS, Bangalore. She also holds that. With that, I welcome you, ma'am, and I hand over to Dr. Shefali to introduce the remaining panelists.
Thank you so much, Purvi, and I welcome all the panelists who have been already introduced. It's a pleasure to invite Dr. Padma Menon. She's a retired professor and head of endocrinology at Seth GS Medical and KEM Hospital, Mumbai. She's a past president of ESI with over 40 years of teaching experience. She's a consultant endocrinologist at Jupiter Hospital, Thane. She's on chairperson for the ethics committee at Seth GS Medical College and KEM Hospital. She has over 100 papers published and more than 3 book chapters to her credit. I welcome you, ma'am. It's immense pleasure to invite Dr. Dhruvi Hasnani. She is a consultant diabetologist from Rudraksh Institute of Medical College. She is an HOD at Clinical Research in RIMS, Ahmedabad. She's a treasurer of RSSDI Gujarat chapter and is a winner of Torrent Young Scholar Award for Diabetes. Welcome, Dr. Dhruvi. It's my honor to invite Dr. Seema Bagri. She's a good friend of mine. She's an honorary diabetologist at Thane Healthcare Hospital and Indian Red Cross Society. She's the director of Dr. Bagri's Diabetes Care Center and Bagri Diagnostic Center in Thane. She's an investigator and a faculty for numerous conferences, including CID, Kids Project, ZAP Project, and conducts regular diabetes education and awareness programs on various social medias as well as audiovisual media. She has articles to her name and has been the investigator for many studies, including the STAR study and as well as the X-RISE study. She has regular articles published in the field of diabetes and numerous papers which have been published in the field of diabetology and endocrinology. I welcome you, Dr. Seema. And with that, I would like to invite Dr. Sarita Bajaj, ma'am, again to open up this Pandora's box and discuss all the things that we regularly sweep below the mat, especially women who are the ones who sweep all the problems below the mat, especially when it concerns themselves. So, ma'am, please do take over.
Thank you. Thank you so much. And Benny and Vijay, it's an absolute honor and pleasure to be in any meeting which is organized by you. I think you are my favorite couple. You work so much in unison and the result is there for everybody to see. So she's, like tried to include most topics, and the focus on women is what is so attractive to all of us, I'm sure. And thank you, Purvi, for those very, very kind words. Purvi is so charming and she's so warm-hearted and so highly appreciative that I can't tell you. It's such a pleasure to be here. Thank you. Thank you, all of you, and all you wonderful ladies for joining us. Oh, Shilpa. Shilpa, your talk was wonderful, wonderful. I really enjoyed it. Thank you. It's always lovely to see you.
Thank you so
and
much.
Dr. Padma Menon, of course, it's been quite some time since we've been able to get together. So Shilpa, I was going to start off with that Pandora story, but you took the words away from me. Thank you.
Sorry.
No, thank you. I'm glad you did. Because it's important to understand why this has been termed in such a way. And we'll be really trying to cover those things which are often not spoken about. So what I will do is start off with my talk, and then we'll move on to the panel discussion. We'll keep it a conventional panel. And though the topics are different, we will be moving through them to keep, I think, the interest alive for the audience and the delegates who have joined us. Am I okay? Am I allowed to share my screen? I think there's some.
Yes, ma'am, you can share your screen.
Just 1 minute.
ये फोटो ना क्लिक कर लो.
Ma'am, there is.
Yeah. Audible, visible?
Yes, ma'am. Just put it on a slideshow.
Yes, I've done that. Thank you. Thank you. Sorry for the delay. So this is again a topic that is not frequently spoken about, but let's see how, if I can make it interesting enough to have a lasting impression. So I'll be talking under these headings. So this is, see, I've tried to list just about everything. And though my focus will be on periodontal diseases, you can see there's a host of things. And if you carefully talk to your patient, invariably there'll be some problem or the other which they have, especially the alteration in taste. Quite a few times they have recurrent after stomatitis. They may have pedunculated polyps, oral mucosal oral pathology. They may have a fissured tongue. And this again is a very common complaint. Xerostomia, dryness of the mouth, hyposalivation. This is really common, but I think we just need to ask them to open the mouth and see. So the foot and the mouth should go hand in hand. We're very reluctant to have the foot examined, but I hope it's much easier to ask the patient to open the mouth for an examination. So the what are the interrelationships there's between the various manifestations that I have just mentioned? It could be immune dysfunction, it could be side effect of the oral medication, peripheral neuropathy, salivary gland dysfunction, low salivary flow, and candidiasis. So these are the various interrelationship between the different manifestations that we may see in the oral cavity. So now what I thought is, like it says, a picture speaks 1,000 words. So I'll just take you through the manifestations which I had just listed. That's why I didn't go into each one of them, but if you see them in pictorial form, it should leave some lasting impression. So this is the difference between healthy gingiva and a periodontal disease, which I will be describing or making you, showing you the pictures. So the connection here is periodontal disease is often considered to be the 6th complication. It is responsible for poor glycemic control and increasing CV risk. The oral manifestations, if we look at the mechanisms, diabetes, hyperglycemia, adipokines, age, RAGE interaction, upregulated cytokine production, altered PMN function, altered apoptosis, dysregulated inflammatory responses, increase in the pro-inflammatory cytokines, and the connection between smoking, which I'll be highlighting later, leading to periodontitis, and there is a subgingival biofilm which is also responsible. So there is believed to be a two-hit model for this pathogenesis. So we have the periodontal microbiota on one side, and the other side, the RAGE activation, leading to exaggerated and sustained inflammation, impaired repair, and enhanced periodontal tissue breakdown. So the chronic diabetic complications because of the underlying insulin resistance, we have hyperglycemia, and the microvascular target cell is shown here, and increase in the ROS. There is hypertension and leading to microvascular and macrovascular complications. On one side, the microvascular complications, the retinonephro-neurodiabetic foot, and the macrovascular complications we are aware of. The oral complications, which I said is the 6th complication. I'll be talking about periodontitis, caries, dry mouth, oral mucosal lesions, a little bit of oral cancer, taste disturbance, and the other oral complications as well. So poor glycemic control is the underlying factor which leads to caries, pulp necrosis, periapical abscess, and periodontal disease. There's a host of microbiota which have been implicated. Now, going through the pictures that should leave a lasting impression. So here is a clinical view of the periodontitis. And if we take a radiograph, you can see that the green dots that are shown here will tell you where the bone level should originally have been. But you can see there is bone loss underneath. This difference is there. And though it is not easy to discern on the surface, but it is very clear from the radiograph. So this is localized moderate gum disease in a patient with type 2 diabetes. This is generalized moderate to severe periodontitis. You can see the extensive swelling of the gums and the redness. Very severe periodontitis. You can see the secretions which are collected here. And this is a type 1 diabetic, 22-year-old man, very poorly controlled, and very severe anaerobic periodontal infection. You can see that there's so much loosening of the teeth and so much dental separation as well. Again, very severe periodontitis in a type 2 diabetic. Just apical periodontitis is one other manifestation. You can see a fistula. This is a fistula. And you can see the corresponding radiograph. This is the same thing which is marked over here. Because of an implant, there is inflammation at the site of the implant. And again, you can see the bone loss between the green and the red dots. Dental caries showing deep carious lesion, which is marked here. Hyposalivation. The fissured tongue is depictive of hyposalivation. A gum boil pointing out acute infection in this poorly controlled diabetic. Again, another gum boil here. Enlarged gingiva, all this would be very easy. All the patient needs to do is open the mouth. There are a lot of gingival polyps here. Again, severe periodontitis. Bone loss, you can see extensive bone loss, which is absolutely visible on the surface. And again, radiographs to depict the same. Candidiasis is one other manifestation. Again, candidiasis, it looks like milk curd, but you cannot remove it. If you try to remove it, then there is bleeding. Denture stomatitis, again, this is candida related. Again, median rhomboid glossitis because of candida. And angular cheilitis, again, because of candida related lesion. Recurrent aphthostomatitis per se is very common. I'm sure all of you might have had an aphthous ulcer at some point in time. But recurrent aphthostomatitis is seen in diabetics. Oral lichen planus is another manifestation. And the involvement of the temporomandibular joint. So this is one point of pain that the patient
always reports in case the temporomandibular joint is affected. Leukoplakia, oral cancer, again another manifestation, strong association. And when I said mouth and foot, if there is extensive periodontitis in the mouth, do look at the foot. So this is a patient who had periodontitis with a 2 centimeter foot ulcer as well. So the mechanisms are the altered host response, alterations in connective tissue wound healing, microangiopathy, alterations in the gingival crevicular fluid, altered subgingival microflora, and there is some hereditary predisposition as well. The presence of periodontitis, there is a 2 times greater incidence in type 2 diabetes, a 5 times greater increase in the progression of A1C. And from the NANS data, there was the clinical measures of periodontal infection are associated with the greater insulin resistance, risk of elevated HOMA-IR, and they're associated with insulin resistance among participants if the WBC count is more than 6.5 and CRP more than 1. Coming to the cardiovascular association. In the ERIC study, the odds of intima media thickness 1 millimeter were higher for severe periodontitis as compared to moderate to no periodontitis. So these results were the first to provide indication that periodontitis may play a role in the pathogenesis of atheroma formation as well as cardiovascular events. This was a study of 50 carotid atheromas, and 72% of the surgical specimens indicated bacterial content, and 44% of the atheromas contained at least one of the periodontal microorganisms, which I had mentioned earlier. What about mortality? Death rates from ischemic heart disease and nephropathy were higher with severe periodontal disease than in those with no or mild or moderate periodontal disease. It has also been implicated as a risk factor for stroke and carotid atherosclerosis. It's been shown to be associated with endothelial dysfunction in patients with coronary artery disease, and metabolic syndrome has also been suggested as a potential risk factor for periodontal disease. It is believed to be a two-way relationship. Microalbuminuria and end-stage renal disease are increased 2 to 3 times, 3 times higher risk of cardiorenal mortality, and an A1C reduction of even 0.4% following effective periodontal therapy. So yes, so the treatment helps. That's extremely important to note. Again, a very interesting study to show the relationship between the severity and control of diabetes. This was just to show the bidirectional relationship. 50 type 1 diabetic patients with good, fair, and poor control, and the severity of the periodontal disease was increased with poor glycemic control. So these are the 3 groups. And here comparing between groups A and B, if we look at the various parameters, whether it's probing pocket depth, clinical attachment level, or the plaque index, there was a significant difference between group A and B, and between B and C as well. What about the effect of periodontal therapy on glycemic control? A small number of patients. The first group received treatment with full mouth scaling and root planning, followed by systemic doxycycline. Group B received no treatment, and all the periodontal parameters, that is TNF alpha and A1C, was significantly decreased 3 months after non-surgical periodontal therapy. So there are a lot of longitudinal studies showing association between periodontitis and the diabetic complications. So I'm not going into the details here, that there is ample literature. Now coming to our data. So we looked into 50 cases of diabetes. They were selected. They had oral complications, and we studied them for the association between oral manifestations and micro and macrovascular complications as well. So this is just to show you the distribution. So they had periodontal disease, candidiasis, tooth loss, oral mucosal ulcer, taste impairment, halitosis, xerostomia, and salivary gland hypofunction, dental caries, and burning mouth sensation. So this was in collaboration with the dental department in our college. If we look at the blood glucose status, the FBS, as well as the PPBS, there was a significant difference between cases and controls. As far as the complications were concerned, neuropathy, retinopathy, and nephropathy, including CVD and dyslipidemia, was significantly more in cases as compared to controls. So the p-value for neuropathy, retinopathy, nephropathy, cardiovascular disease, dyslipidemia, and sepsis has been mentioned here. It was significant for neuroretino and dyslipidemia, and several oral complications are seen. Periodontitis is the commonest association as an oral marker in diabetes, and microvascular complications, suggesting that there is a significant association between the two. So subsequently, Dr. Sridhar invited us to write a chapter on diabetes and periodontal disease, making the connection. I'd mentioned earlier that I'll be talking a little bit about smoking. So this was a type 1 diabetic population, non-smoking diabetics. A positive correlation was found, and smoking is a major risk factor. Treatment of periodontal disease, significant improvement in the periodontal clinical parameters would result with a correlation of reduction in the A1C levels. So the management for the different pathologies I have tried to highlight here. So depending on the type of pathology, the appropriate management would have to be implemented. So there's some newer options for treatment as well, like low-level laser therapy. Glycemic control, this was again very interesting recent data, August 21. This is Japanese data. They looked at the glycemic control and they showed it to be strongly associated with the number of natural teeth in a real world setting. So there are continuous relationships of A1C and the fasting with the number of natural teeth, including individuals with impaired fasting glucose. And what they said is their data emphasizes the importance of glycemic control and appropriate oral care for the protection against tooth loss. Individuals with even impaired fasting glucose are at risk of tooth loss in middle age. So this is the data that they have tried to show, the number of natural teeth classified according to glycemic control.
Ma'am, I'm so sorry to interrupt.
I'm just finishing off. So just trying to emphasize glycemic control, stopping smoking, appropriate oral care. And the last slide, we know the ABCs, but the D now needs to be added. Dental care every 6 months, evaluate, encourage daily brushing and flossing, and refer to a dentist if required. Thank you. Thank you very much.
Wow, fantastic.
Your teeth reflect your cardiometabolic status, and this is what healthy gums should look like. Thank you. Thank you very much.
Absolutely wonderful coverage of all the periodontal problems that we probably neglect and ignore, and we don't even look for in our diabetic patients. Ma'am, I request you to please conduct the panel and take it forward.
Right. Thank you once again, and welcome to Dr. Alka Gandhi, Dr. Mary De Cruz, Dr. Padma Menon, Dr. Dhruvi Hasnani, and Dr. Seema Bagri. So what we'll do is we'll go through the questions and let's see how we take it forward. The topics that we are covering are prevention of diabetes, circadian rhythm and weight loss. I think Dr. Krishna Seshadri had alluded a little bit to this in his talk. Subclinical thyroid disease, diabetes distress, which is a relatively new terminology, and then managing diabetes whilst travel and driving. Dr. Alka Gandhi.
Yes.
Coming to the prevention.
Yes.
Would you prefer to use the word prevent or delay? And would you feel there's any difference when we talk about pre-diabetes or diabetes in that regard?
Thank you, ma'am. At the outset, thank you, Team Wodcon, and thank you, Benny, ma'am. Thank you, Dr. Bajaj, for taking a wonderful talk earlier. Now, when we are talking about prevention, especially for NCDs like diabetes, there is a genetic predisposition as well as epigenetic factors or the precipitating factors that are important. And as we have had a very good discussion earlier in the morning, so we have to understand that the developmental origin of health and disease theory, or the Barker's hypothesis that we are going into. So if we want to prevent the disease or diabetes in particular, it has to start very early in preconceptional days or 1000 days periconceptional period. But having said that, it is a long way to go. But if we are considering pre-diabetes and diabetes, the insulin resistance is the main pathophysiology which is present. And most of the pre-diabetics, I would say 50% tend to develop diabetes in 5 to 10 years and maybe earlier in Indians. And therefore, if we want to prevent or delay the pre-diabetics going to diabetics, we have to address this pathophysiology, that is insulin resistance, as well as beta cell dysfunction. And it can be done by the lifestyle changes like encouraging the diet plans and the structured exercise programs in the patients, or I would say people who are most likely to develop pre-diabetes or diabetes. Ma'am, you are on mute.
Thank you. I think so. You would prefer to go with the prevention concept?
Yes, ma'am. Earlier, if we can handle it, but once the patient is having pre-diabetes, then maybe we can delay diabetes for a decade or so, if not prevent completely.
Okay. And I asked about the difference between impaired fasting or impaired glucose tolerance, that is pre-diabetes, vis-a-vis frank type 2 diabetes.
So, ma'am, in pre-diabetes, as I said, the risk of developing or going to diabetes would be high. For 50% may go if we are not tackling at that speed. And that is why it is a period or window of opportunity which we can act and prevent it to progress to diabetes.
So I think that was a very, very important message. Now, Dr. Mary, how does the circadian rhythm affect our health?
Circadian rhythm, or rather the biological processes that occur during a 24-hour period, are the circadian rhythms. And so a lot of our processes like our sleep, our eating habits, our sleep-wake cycles are all affected by the circadian rhythm. And this, of course, starts in the suprachiasmatic nucleus, in the hypothalamus, and then the peripheral clocks that are present in each of the cells. So it does affect our health in terms of good health, rather, weight loss, if we follow any discipline for circadian rhythms. So this would be basically following what Dr. Sheshadri alluded to, following the normal sunrise and sunset patterns where we are expected to be active in that period and then rest when the sun goes down to rest. So that is when the body gets the power to recover and regenerate and we are ready for another day. But we have disturbed our entire circadian rhythm by sleeping late, by eating late, by being emotionally full of baggage at the end of the day with so much of frustration, so much of anger, so many issues which we bring home from work to the house, and so many other related issues. So yes, circadian rhythm does lead to disturbance in our physical health.
Thank you. Thank you. Is it applicable all across, or is it applicable to certain, more to certain occupations?
Yes,
you're
Dr.
right, that all of us are living a different lifestyle.
Yes, night shift workers who have been studied extensively have shown greater incidence of cardiometabolic problems, of higher incidence of diabetes, and also high triglyceride levels, probably because of the patterns of eating in the waking hours at night rather than being asleep. And then there are adolescents who are doing the same thing now, though they are not working. But then again, they are awake more at night, sleeping way into the night at 2 o'clock or 3 o'clock, disturbing their entire sleep cycle. Then nursing mothers for a period of the first 6 to 8 months when they are feeding the infant, they are also exposed to the same shift.
Is there any data from the Jain community? Because they are the ones we know, like, they eat early, they sleep early.
Yes.
And they follow the circadian rhythm. We'll come back to you, Dr. Mary.
Yes.
Dr. Padma Menon, I think it's important to define subclinical hyper and hypothyroidism before we can move on with this particular aspect of subclinical thyroid.
Thank you, Benny and others, for inviting me and enjoying the conference. The subclinical hypo and hyperthyroidism definitions doesn't change in diabetes, it remains the same. So whenever you have a TSH which is above normal but below 10, and you have a T4 which is normal, we call it a subclinical hypothyroidism. Now one must remember the word which is used in all our textbook and guideline, and that is consistent elevation and consistent figure. That means you do today and you get a 4, and tomorrow you get a 8. It may not be correct. Or you do today, you get a TSH of 8 and tomorrow 4. That's not what is called consistent. So you need to have a consistent reports once or twice to call it subclinical. Number 2, in subclinical thyroid disease, we must, hyperthyroidism, we must understand that very, very often in practice, we have thyrotoxicosis developing diabetes, stress-induced precipitation of diabetes, or metabolism-induced precipitation. Vice versa is extremely rare. I'm thinking in my practice how many I have seen that patient has diabetes, and then over a period of time develop thyrotoxicosis. Most of them have some prior thyroid illness or Graves' disease, which is being accentuated on a special stress thing. So subclinical hyperthyroidism or even overt hyperthyroidism is very rare. I would just like to mention that the commonest thyroid disease which is seen in diabetes is subclinical hypothyroidism. Indian data tells you almost about 29% of people can have routinely done test on 100 patients, found that 29% had subclinical. However, this data doesn't tell me how many go on to become clinical or how many stay there or how many become normal. So it is also most common disease among the elderly. So generally that is what you will see much commonly in diabetes than anything else. Whereas subclinical hyperthyroidism is extremely rare, less than 1%, which you will see.
Thank you. Overall, hypothyroidism is by far more common as compared to hyperthyroidism. Yes. So this would apply for a diabetic as well. What about women? Since we're talking about women here, Dr. Padma.
Yeah. So it's like a reflex, Thyroid disease in general are much more common in women, almost 10 times more common than in men. So it is the women who are likely to develop this thing. Only thing is that hyperthyroidism in this diabetes group doesn't seem to have a difference in prevalence whichever data I looked at. So they are almost same, anybody can get into. And the causes of hyperthyroidism also remain, though it is extremely rare.
Thank you. Thank you so much. So this diabetes distress, Dr. Dhruvi Hasnani. So what is it?
Okay, ma'am.
And again, in the context of women, is it more common, less common, as far as diabetics are concerned?
Thank you, ma'am. Good afternoon to all the respected panelists. Thank you to Dr. Benny, ma'am, for having me on the panel. I have found out the most appropriate definition of diabetes distress according to the ADA and the RSSDI. All of them are saying that, it is defined as the emotional response that we as people with diabetes would, have in terms of an extreme apprehension or discomfort or a feeling of dejection that might be perceived when the person thinks of dealing with diabetes as a disease per se. And we have our very own Indian paper guidelines by Dr. Vishwanathan sir, and he came out in 2019, and the paper is saying that there are nearly 55% of women with diabetes who are reporting or who are being diagnosed with diabetes distress. So the paper said that women are at a higher risk of having diabetes distress because somehow they are not able to process the disease per se, and they are not the ones who are screened as much as possible in comparison to the men. And when the term emotional distress is used for diabetes related disease, there is a lot of overlapping between, major depressive disorder as well as with diabetes distress. And it could include burden of self-care, some interpersonal issues, some emotional worries regarding the ability to coping up with the condition, and relationship along with the family as well as with the healthcare professional.
What would about the percentages being more common in women?
Yeah, we have the Indian data, which is saying 55. There are various other papers. There is a meta-analysis from 2017 from 55 different studies, which talked about type 2 diabetic women having overall prevalence of 36% and type 1 diabetic women having a prevalence of 54.4%. This is a paper in 2016 by Fisher et al. But still there is a lack of systemic analysis for the prevalence of diabetic distress in type 1 diabetes. And it is still said that a type 1 diabetic population is more, at a higher risk than in comparison to type 2. But again, females in both, whether it is type 1 or type 2, are at a higher number. If we look at these statistics here, it's 54.4 and 55 and 36 per se for type 2 diabetes.
And major depressive disorder, MDD?
Again, lack of data differentiating to the two. There is a lot of overlap. Again, a paper from 2017 that they both can occur together, but you have to differentiate using all the standard content specific measurements. Like there is a diabetes distress scale. Now it has two parts. Again, there is first a diabetes distress scale with 2 questions. If it is positive, you move on to a 17-question diabetes distress scale, which is quite popular with the name of DDS-17. And again, not a huge ton of data where we can, talk about women specific or gender specific, but maybe we can work more upon that.
And I think it's important to note that it is bi-directional.
Yes.
I think that is another very important point as far as diabetes distress goes.
Yes.
Thank you very much. Dr. Seema, what about diabetic drivers? What are the incapacitating factors? And do you think a medical certificate of fitness should be called for?
Dr. Seema, please unmute.
There, yeah, now we can.
Yeah, thank you, ma'am. At the outset, would like to thank Benny, ma'am, and the entire Wodcon team to make me a part of this panel discussion. Now, the incapacitating factors and the medical certificate, which we are going to discuss now. First of all, as we know that driving is a complex process which places a considerable demand on the cognitive and the physical functions. And many complications of diabetes can potentially impair the driving performance, including those affecting with vision, cognition, and peripheral neural function, among which hypoglycemia is the most common side effect of patient who is on insulin and who is on secretagogue sulfonylurea, which impairs the most cognitive domain necessary for safe driving performance. So we will see how the different driving behavior which may predispose to hypoglycemia while driving is examined. we'll see the different factors which affect in a diabetic driver. Let us have a different, complications of diabetes, such as hypoglycemia, peripheral neuropathy, visual impairment, sleep apnea, and cerebrovascular disease, which can lead to this cognitive impairment and which will affect the driving performance. Now, coming to hypoglycemia, now many licensing authorities, have learned that a driver who has experienced an episode of hypoglycemia will, it will affect his ability to drive and maybe refer to for a medical evaluation. And in many cases, he may lose the job for a period of time until it is cleared by the licensing authority. And also studies have demonstrated that cognitive functions are very critical to driving, which are impaired during hypoglycemia. And different changes in visual information process which occur during hypoglycemia could affect the visual perception under the conditions of limited perceptual time and low visual contrast. The peripheral neuropathy, due to the reduced sensations and the impaired proprioception effect on the lower limb of people with diabetes, they may find it difficult, to gauge pressure on the accelerator, brake, and clutch pedals. So also, when these patients are on neuropathic pain agents like gabapentin or amitriptyline, it may have a sedative effect. Now, visual impairment can also affect driving performance. As we know that vision is an essential part of safe driving performance, and impairment therefore has a potential effect on this driving performance. So diabetes, as we know, increases the risk of developing several eye disorders and can impair the eyesight. A new concept like sleep apnea can also affect driving performance. Like, sleep apnea is associated with obesity and type 2 diabetes. And with increasing prevalence of obesity, there is an increased risk of sleep apnea also. Like sleep apnea can lead to, because of the poor quality of sleep, it can lead to daytime somnolence and performance in, in the daytime, reduced performance during the daytime due to this sleep problem. So we see that different complications like hypoglycemia, visual impairment, neuropathy, and apnea can affect a diabetic driver's performance.
Thank you. Thank you very much. So what are the recommendations regarding the frequency of screening? So if suppose you have a license, ideally how frequently should the screening be done to ensure that you are medically fit to drive?
Yeah. See, as we know that driving is very important, it's not only for the business, but for the recreational role, for the transport in most of the countries, and it allows people to travel to and from work, pursue their employment, undertake multiple social activities. So it is very important, and in many cases, it's a fundamental part of the daily life where there are limited sources of transport. So it is very important, that patient, the majority of the driving license authorities, what they have done is they have, made a distinction between people who have diabetes and with those who are on insulin, who are needing insulin to treat diabetes, and those who do not. Basically related to the risk of hypoglycemia, which is associated with the insulin therapy. And also the other glucose lowering agents like sulfonylurea, glinides, which can also cause hypoglycemia. So they have made a distinction category so that they can, individualize the drivers with the licensing capacity.
So the Canadian Diabetes Association recommends once in 2 years,
yes,
and ADA recommends once in up to 5 years even, so 2 to 5 years. So there is a difference between the two.
Yeah,
as far
the
as
different.
the recommendations are concerned. Definitely, it has to be renewed.
Yeah, different. For example, European regulations have also, made a difference in the drivers who are, treated with insulin, and even in the USA, according to the ADA guidelines, also people with diabetes should be treated individually, taking into account their medical history and the potential risks associated with driving.
Dr. Alka, could you just give us some tips for prevention and lifestyle versus drugs, as far as the prevention is concerned?
So I would say no pain without, no gain without pain. So yes, lifestyle would be the first choice. We have scientific data to support that. So the DPP, that is Diabetes Prevention Program, where there were 3 arms, intensive lifestyle versus drugs like metformin and placebo. And we have seen that in the group where the intensive lifestyle was followed, there is significant reduction, or 58% people had a reduction in incidence rate of developing diabetes compared to 31% in metformin. Again, if we study, follow further the DPP outcome study, which has shown that this lifestyle change was able to delay the diabetes further by almost 6.8 years. So that is a significant achievement in the lifestyle group. And sometimes the patients, in spite of following intensive lifestyle, may not be able to achieve the goal. We can put them on additional drugs like metformin. But we also have to understand that the primary aim of prevention of diabetes is to prevent the micro as well as microvascular complications and reduce the mortality and morbidity. And the lifestyle prevention, lifestyle changes have shown that improvement in the cardiovascular risk markers also. So I would say definitely lifestyle changes would be the first one. And the tips would be, so when they say lifestyle change, it is not easy. Diet, we have very good sessions earlier in the morning to reduce the calorie, reduce the carb intake, reduce the fat, increase the protein in diet, increase fibers, and then exercise. If we say the structured exercise program, at least 150 minutes in a week, and aerobic along with the strength or the resistant exercises as needed. And so we have to educate the people, create the awareness about the healthy lifestyle, empower them to make good choices, and encourage to follow them.
And the plate concept?
Pardon, ma'am?
The plate concept.
Yeah, so we have to have half, yes, to reduce the portion size, and first fill the half plate with the fibers, salads and vegetables, and then another half would be with protein, and the less, so 1/4 protein and 1/4 would be carbs.
And I think the fats are also very important as to the type of fat that one consumes. So and what we are doing right now, too much sitting. So less of inactivity, to decrease the inactivity. So if you're working on the computer, which is very common these days, so if you get up intermittently, because so-called smoking, sitting is the new smoking, that is what is being propagated as well. So I think
avoidance of smoking and alcohol also is important.
Absolutely. Right. So coming back to you, Dr. Mary, how do you suggest we manage our lifestyle to avoid, to keep our circadian clock in rhythm?
So to keep the circadian clock in rhythm, lifestyle changes, like you already mentioned, of being disciplined, of getting up at the same time, preferably even on weekends within a half an hour delay here or there. And the same goes for the night. When on weekends we tend to eat more, we need to restrict that. And a very simple way is to do a time restricted eating, which means eat during a less than 12-hour period. Recommendations vary from 6 to 12 hours, in which we could get immense health benefits in terms of weight reduction, of improving glucose values, of improving our lipid profile, reducing blood pressures. All these by just a simple intervention of eating an early dinner by 7 or 8 p.m. And even then we are awake after that. So ideally have a 3-hour gap between going to sleep and the dinner time. And then of course, we delay the breakfast slightly, but have a very good breakfast is the recommendation. So preferably items that you eat should be eaten earlier on in the day to take advantage of the insulin secretion by circadian rhythms. So we look at our insulin secretion more in the morning, vis-a-vis evening when it reduces as the melatonin starts rising. And so all these rhythms in our body are governed by hormonal levels which affect each of our bodily functions. So just a mnemonic, because time is over, it would be dream. We need to be disciplined in whatever we do. We need to keep restricted eating times, which would be from 6 to anywhere between 10 to less than 12 hours. Do exercise regularly, that's E, and then avoid all emotional baggages that we carry. If we cannot lose weight, we blame ourselves. If we lose weight, we have some other issues, and it goes on and on. And then, of course, maintaining that weight loss. As one of our earlier speakers yesterday said, maintaining the loss is really difficult. So maintaining is probably helped by motivation. And motivation could be something for young girls who are going to get married, they want to lose weight. For those who are willing to conceive, they would lose weight to have a baby and avoid gestational diabetes. For conjugal life and so many different things. So we need to keep being motivated to a healthier lifestyle more than losing weight.
Thank you. Thank you. I think that was wonderful. Dr. Menon, would you like to elaborate a little bit about the treatment part as well? Especially in the context of diabetes, if there is anything that needs to be highlighted. You're mute.
Ma'am, please unmute.
Yeah. Yes. I'm mute, sorry. See, most important thing to know is where can you talk about some sort of a risk factor? For example, if the patient had a history of Graves' disease, has a goiter or antibody positive or some symptoms, these will be people who have to be followed and who are likely to develop thyroid disease. And those who do not have no, for example, patient history of Graves' disease, and today the TSH is 7, but T4 is normal. I am expecting this patient to become hypothyroid because that is a natural end course of Graves' disease. So you may, what do? Observe and repeat after 6 weeks to 3 months. Any disease would be there, it would progress. If there is no disease, it's a lab variation or something else that has happened, or a seasonal variation or a sickness-induced variation, it would disappear. So if it persistent and it goes up, for example, if TSH of 7 goes to 9 or 10, and the TPO is positive, yes, your antenna is up and you need to treat. How does it affect? In subclinical hypothyroidism doesn't affect diabetes to that extent. However, in a Graves' disease, yes, it affects, it worsens the thyroid diabetes control. And when you treat, you expect that the drugs to be coming down. Similarly, if it's a gross hypothyroidism, yes, then it would, a patient could go into hypoglycemia. That may be the first time you detect your thyroid disease. They come with hypoglycemia. And that time, after you treat, you expect the drugs to be increased or the control to be a little more difficult. So these are two things which you need to observe in these patients. Otherwise, treatment-wise, it is the same way what you treat hypo and hyperthyroidism. Otherwise, when to treat is the most important thing. And that's what I talked about in subclinical hypothyroidism.
Yeah, and there's a very important role of when we talk of testing, I think the antibodies, the thyroid peroxidase TPO antibodies.
Yes. Yes.
It can be there both in hypo and hyper, but definitely
they can,
more in hypo.
No,
the thyroid receptor antibody for Graves' disease. So they also would help us guide the treatment. Right. Thank you.
But the most important thing is that if you have a thyroid related TPO antibody positive and patient had a thyroid disease and it is normal thyroid function, then we don't know where to go. TPO can be positive from very, very long time. So should not base only on TPO, you should put the overall picture of the patient.
Agreed. So there's a very, very important point to be noted. Dr. Dhruvi, I think we just briefly, I think one line answer to the most validated instrument. See, like we talk of hypothyroidism, on one hand, we're saying do this test, that test. So which is the most validated instrument available?
It is the diabetic
establish a diagnosis, and then we take it from there.
The most validated tool currently is the diabetes distress scale. And like I already said previously, it comes in 2 parts. We have 2 questions. If they're positive, you go on to the 17 questionnaire scale.
Yeah, I think that's the most apt answer there, because we need to establish, yes. So there is some way of confirming it as well. And Dr. Seema, Just a couple of more do's, perhaps less don'ts for both for travel. I think travel. I think that's more important. Travel.
Yeah. Just a few points before you go visit a doctor. Discuss with him your the activities, the number of days you're going to stay, and if you are on insulin, discuss with doctor the insulin doses. Carry the prescription with you. If you're going to a different place, then take an advice for the vaccine. If you are discuss with your travel insurance. Keep it with you in case you miss a flight or a medical care, and keep the diabetic food packing with you. Keep enough of your healthy foods and the carbs and tablets in case you go for a low sugar. And especially most important, when you're going to the airport security, and if you're on CGM or if you're on a pump, then discuss with them in prior, so that you don't have to waste time, or you don't have to you can just quickly enhance the process. While you're traveling, make sure that you are keeping insulin in the proper pouch, so that your insulin is not wasted. And once you are there at the destination, you can keep because there will be a change in the time, or the time zone may be different. If you're going to a different country, then you may have to frequently monitor the blood sugars. So keep all these things handy whenever you are traveling.
So is there any difference between the flying and going by train?
In the train, if you're going by train, then also you have to keep the insulins and everything in the in the coolant pouch, so that your insulin doesn't get destroyed or it doesn't get wasted.
Yeah, I think this is extremely important. There would be hardly any difference, but then comfortable footwear is one important
important thing, so that you don't get exposed to direct sunlight, or you don't get any sunburns.
Yeah, thank you very much to all the panelists. I think we've tried to cover most of the points, and at least I've enjoyed interacting with all of you. Thank you, Benny, and thank you again, Vijay. Thank you to Wodcon for inviting us, and for Shilpa, of course, for the introduction in Pandora's box. So I think we're all in yellow, but the men have not complied. So I saw Anuj Maheshwari was wearing a yellow t-shirt. So I think there should be a special prize for the men who are wearing yellow.
We had Professor Dr. Jayan Panda and Dr. Anuj Maheshwari in yellow yesterday.
Yeah, that's what I'm saying. I saw some lovely photographs of men in yellow as well. So thank you very much.
You should give a prize for somebody who always wears blue.
But blue is so men anyway. So
next year we'll make the color blue.
Okay.
For your sake.
Thank you for the suggestion. Thank you very much.
Thank you.
So over to the organizers.
Thank you so much, Sarita ma'am, and all the panelists. I think this was a very lively discussion. Lot of inputs and lot of carry-on messages, and it must have been terrible. I mean, to give all disconnected topics and yet be on the same platform. So thank you very much. And thank you, Dr. Purvi and also Dr. Shefali. So for interest of time, can we just close the session and go on to the next? Thank you again.
Thank you so much.
Thank you, Benny ma'am. The next session is going to be the old wine in new bottle. And for that session, I would like to invite Dr. Rupali Boye, Dr. Sanhita Valavalkar, and Dr. Ishita Sachdev. All of them are diabetologists practicing in Mumbai. And over to you, Dr. Rupali, to take over the proceedings.
Good afternoon, everyone. It's my immense pleasure to invite Dr. Panikar, sir. Dr. Panikar is honorary consultant at Department of Endocrinology, Diabetes and Metabolism, Inactivity Hospital, Mumbai. And he's ex-professor of medicine at KG Somaiya Medical College, Mumbai. and is Vice President at Research Society for Study of Diabetes in India. He has more than 20 research publications in journals and written chapters in textbooks and medicine updates. And he has pioneering work on triple drug therapy and low dose of pioglitazone 7.5 mg in clinical practice. I invite Dr. Panikar sir to deliver his lecture.
Thank you very much, Rupali, for a kind introduction. At the outset, let me just share my wait, I think. Can you see my slides?
Yes,
Yeah.
sir.
Yes, sir. So they are also all in blue.
Can you see the slides changing?
So we can see all the slides.
There is slide sorter.
You can click on the first slide.
Something has happened here.
So you'll have to scroll. Yeah, on the first slide, sir. Perfect.
Okay.
And slide show.
Click on it.
Does it show full,
Yes, sir.
full screen?
Yes.
No, sir.
No, not yet.
No.
No, I think I have
Presentation
to go and again with stop slide share. Either say slide show. I think something has to be done here.
Yeah, down there.
Custom slideshow.
No, sir, from beginning.
From beginning.
So the
Left hand side.
First one, sir.
Yes.
Yes. Perfect.
Okay, now can you see my slide?
Yes.
But not in the.
No, it's still on the
Sir, at the time of sharing, you have to press on power presentation mode, slideshow mode.
Achha. 1 minute. Let me share again.
At that time, you.
No, slide share from the beginning. क्या करने का?
सर जब आप शेयर करेंगे ना तो मल्टीपल विंडोज होगी, वहां मल्टीपल विंडो में एक होगा पावर पॉइंट प्रेजेंटेशन स्लाइड शो मोड, वो आपको क्लिक करना है.
ऐसे वापस स्टॉप शेयर करो और क्या हो रहा है आजकल?
सर हाँ, अब ग्रीन बटन पे आप प्रेस करेंगे तो मल्टीपल विंडोज आएंगी, उसमें से आपको हाँ सर डन.
आ गया?
Yes.
Yes sir. Yes.
Full screen दिखता है?
Yes.
Yes, sir. Perfect.
Okay. At the outset, let me thank Benny and Vijay for having invited me to give this talk. But I'm wondering why Vijay has put such a talk. He says PIO has vascular benefits, but should we use PIO in women? Means he doesn't want to give vascular benefits to women. This is gender bias. And if so, when? Let's see. You know, PIO has had a very checkered career, lots of ups and downs, and 2+ decades of pioglitazone from 2000 onwards, and it still stands tall. See, all drugs have pros and cons, and you have to understand the benefit, identify the risk, and decide and optimize which patient should get which drug and why. Trials and tribulations of pioglitazone, this was almost hanged for these side effects, or so-called side effects: weight gain, congestive heart failure, bone fracture, bladder cancer. Yes, pioglitazone does cause weight gain, but basically what it causes is increase in subcutaneous fat and a decrease in the pathological visceral fat. So causes weight gain, but lowers visceral and hepatic fat. And by lowering hepatic fat, it also becomes the treatment for fatty liver. Now, whatever weight gain you get can be really offset with diet, exercise, and everything. And there are n number of patients. In fact, today morning, I had a patient online consultation. He has reduced 8 kilos weight, and he says, I want to stop pioglitazone because it causes weight gain. It was 8 kilos weight loss, no problem. Congestive heart failure. See, the proactive study showed excellent results as far as myocardial infarction, acute coronary syndrome, and stroke. But there was an increased incidence of heart failure. But there was no increase in mortality in these patients. In fact, fewer patients of pioglitazone who had congestive heart failure. If you look at the final outcome, the deaths were much less than in the other patients. Now we talk of bone fracture. Yes, pioglitazone is associated with reduction in bone formation and markers as well as reduction in bone mineral density. But this should be seen basically in post-menopausal women. So here the question comes, would you use this in post-menopausal women? With caution. If the patient has osteoporosis on a PMD, you will not use it. But otherwise you can use it, but this does not apply to men. In men, it is relatively safe. Then came the big story, bladder cancer. In fact, bladder cancer in 2011, France suspended, Vietnam suspended, and India banned it in 2013. And in fact, it was me and Rajiv Koil and late Dr. Siddharth Shah. We had a press conference and we really fought it out. And within a month's time, the ban was withdrawn. As far as bladder cancer is concerned, these are major studies which are showing that there is no risk of bladder cancer with pioglitazone. And this is a beautiful comment done by Robert Ryder and Ralph DiFranzo in 2019. Pioglitazone is inexpensive because it has gone off patent in the US, so it becomes inexpensive. Very effective at reducing HbA1c. No evidence of bladder cancer risk and plenty of evidence of cardiovascular benefit. This, in short, tells you what pioglitazone is. So whether it is a woman or a man, they should get all these benefits of this drug. What do the guidelines say? Look at the ADA ESD guideline. It says, if SGLT2, GLP-1 don't control, you have TZD and sulfonylureas. But it says avoid if there is a history of heart failure. So if there is an ejection fraction less than 45, you generally tend to avoid pioglitazone. When you want to minimize hypoglycemia, again pioglitazone, it does not cause hypoglycemia. When cost is a major issue, pioglitazone. This is the European Society. After monotherapy failure, again, TZD is there. Here again, TZD is there. It's there. So it's there in all the guidelines. But now the big question is, what are we really looking at when you're treating your type 2 diabetes? See, if an adult at 30 years, non-diabetic, he has a lifespan up to 75. And this is average life expectancy in India. But if he becomes a diabetic at 30, he stands to lose 14.5 years of his life. And when you are going to treat that patient, what you are looking at is not blood glucose control. You are looking at how you can prevent that patient, whether it is a male or a female, from preserving that loss of 14.5 years of his life. And what do these patients die of? 80% of type 2 diabetics will die of a macrovascular disease. And that's a coronary artery disease or a stroke. End-stage renal disease. And now we have a new epidemic on the block, the fatty liver, which progresses to cirrhosis and hepatocellular carcinoma. This is what we need to prevent to get your patient to live happily beyond 75. So what are the favorable things with pioglitazone? It preserves beta cells, it reduces insulin resistance, and because it does these two things, you have a durable glucose control, improves the lipids, it has anti-inflammatory properties, reduces cardiovascular event, and obviously improves non-alcoholic fatty liver disease. Now, progression of type 2 diabetes depends on the beta cell. This is the UKPDS famous slide, which says that at the time of diagnosis, 50% of beta cells are already gone. And the beta cell apoptosis continues. What is the driving force? Lipotoxicity, hyperglycemia or glucotoxicity, and insulin resistance. And insulin resistance drives both these. These are 10 studies using sulfonylurea. Initially, see, there is a nice decline in HbA1c within the first year. But as time goes, you find that they lose the HbA1c control. What it is telling us? It's telling us that the beta cells are dying. So there is less insulin. And these are 8 studies using a glitazone. Initial good response and well-maintained durable control. because if beta cells are preserved, the progression of the disease is reduced. And what is the action of glitazones on the beta cell? They have a direct effect. It reduces insulin resistance, reduces plasma free fatty acid. But most important is what is in this yellow: mobilization of toxic lipid metabolites out of the beta cell. And that is how it prevents the rapid apoptosis of the beta cells. So we have seen that it is the only drug that has been shown to preserve beta cells. Now, reduce insulin resistance. These are two large prospective studies. Helsinki study, Verona study, which showed that insulin resistance is a very strong independent predictor of cardiovascular disease, myocardial infarction, and stroke. And what are the implications of insulin resistance? Glucotoxicity, lipotoxicity, but ultimately look at the clinical consequences. It can cause diabetes, it can cause hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, PVD, stroke, PCOS, and NASH. And these are the things that you can prevent by treating insulin resistance. So is there evidence that treating insulin resistance can help? All the diabetes prevention programs were looking at reducing insulin resistance. Non-pharmacological, diet, exercise, weight reduction. Pharmacological were metformin and pioglitazone. All these showed fantastic results. These are the studies. And I will talk a bit about the IRIS study, which used pioglitazone. What is the IRIS study? IRIS study was done in patients, non-diabetic patients who had a recent TIA or ischemic stroke and who had insulin resistance as calculated by HOMA more than 3. And they gave them pioglitazone 15 to 45 milligrams for 5 years, and they were looking at fatal, non-fatal MI and stroke. Mind you, these were non-diabetic patients. So here is a study which was just treating insulin resistance, nothing else. Recurrent stroke reduced by 24%, myocardial infarction reduced by 24%, and new onset of diabetes reduced by 52%. And this is purely by treating insulin resistance. So for the first time, a therapy directed at insulin resistance has been shown to prevent cardiovascular and cerebrovascular events in these patients. But look at this now. There was a subgroup in this same IRIS study, almost 2,885 individuals who were pre-diabetic. They were not diabetic, they were pre-diabetic. And when they studied this subgroup, what did they find? Whooping, stroke and myocardial infarction reduced by 40%, stroke again by 33%, acute coronary syndrome 52%, and new onset of diabetes over a period of 4.8 years reduced by 80%. We were talking about pre-diabetes in the panel discussion. This kind of results you will not get anywhere. No drug, no semaglutide, no SGLT2 gives you this kind of results. Effects of pioglitazone on CV risk factors and biomarkers. These are 4 randomized controlled studies: PROACTIVE, Chicago, Periscope, IRIS. Several meta-analyses and 3 large observational studies have shown that pioglitazone has anti-atherogenic and cardioprotective benefits. Look at the PROACTIVE study. PROACTIVE study was a study done where they gave pioglitazone to patients who already have had a myocardial infarction. And here they showed a 47% reduction in stroke. Because of this finding, based on this finding, the IRIS study was done in patients who had a stroke. Your secondary myocardial infarction was less by 28%, acute coronary syndrome by 37%. Now, pioglitazone reduces CV risk and mortality in patients with type 2 diabetes and chronic kidney disease or end-stage disease. See, those who have CKD have also a high risk of cardiovascular disease and mortality. So this is the study where they had, this is again from the PROACTIVE only, where they gave patients on pioglitazone. They found that even cardiovascular mortality in patients who already had CKD was much less in patients who were on pioglitazone. Then you had the Chicago study, which basically looked at the intima media thickness, carotid intima media thickness, and they compared glimepiride with pioglitazone. With glimepiride, the carotid intima media thickness steadily increased, whereas with pioglitazone it decreased. Periscope study, this was done by Steve Nissen. Steve Nissen was the person who killed rosiglitazone. And what they did was they looked at the intravascular atheroma volume. And they gave pioglitazone and glimepiride and followed them up for 18 months. And what did they find? That those patients who are on glimepiride, the atheroma volume increased and those on pioglitazone reduced. So you have these two studies, Chicago and Periscope, have shown that pioglitazone treated patient had a significantly lower rate of progression of coronary atherosclerosis with reduction of carotid intima media thickness, which is a surrogate marker to show that it has got anti-atherogenic properties. Now, this is a meta-analysis of pioglitazone in patients with PCOS. What is PCOS? It is again an insulin-resistant state. So this meta-analysis indicated that pioglitazone ameliorated the menstrual cycle and ovulation better than metformin. But metformin ameliorated the BMI and the FG scores. FG score is basically for hirsutism, better than pioglitazone in treating patients with PCOS. So pioglitazone might be a good choice for patients with PCOS who are intolerant to metformin for the treatment. These are all the drugs used and what has been the cardiac outcome. And here again, if you see, the all pioglitazone versus metformin has the best outcome. This is a beautiful study done by Korhonen, published in Diabetes Care in 2018, where they looked at cardiovascular and non-cardiovascular death in a cohort of 31,000 patients. These are pio-exposed and non-pio-exposed. Average patient years 2.6, 2.7, very well compared. Patient years 2.3 to 2.1. In the patients who had pioglitazone, that 639 cardiovascular death, 972 non-cardiovascular death. But look at the non-pio-exposed. It is practically 4 times, much more. So patients who were on pio had a much less mortality. Again, if you look at number of cardiovascular specific deaths and causes, look at this. This is a pio-exposed. Myocardial infarction, 467. In non-pio-exposed, it is 1,380. Stroke, 92, 340, 47, heart failure. We consider that pioglitazone can cause heart failure, but look at this. This is the data. That patients who are on pioglitazone have a lesser chance of. Analysis suggests that pioglitazone is associated with a decrease in both cardiovascular and non-cardiovascular mortality. So these are the basic benefits of cardiovascular, of pioglitazone. Stroke by 47%, carotid intima media thickness, Chicago study we saw, 28% reduction in reinfarction proactive, acute coronary syndrome reduced, stop progression of coronary atherosclerosis, reduction of MI, stroke, proactive, quartet. And this is very important. Reduction of inflammation and necrosis in NASH and 50% risk reduction in hepatocellular cancers. So when you talk of pioglitazone, you have seen the adverse effects, which are very manageable. But look at the benefits. It reduces insulin resistance, which is at the core, and Indians are insulin resistant. It's a potent lowering of HbA1c. It is comparable to metformin and GLP-1. Improves CV risk factors, increases HDL, reduces triglyceride, reduces the inflammatory markers, reduces microalbuminuria. Decreases the cardiovascular risk as shown in proactive study and IRIS study. Reduces risk in CKD and hemodialysis, improves liver damage in NASH, and strongest effect in diabetes prevention. Act now. Almost 80% of patients were prevented from becoming diabetic, and protection of several common cancers like liver cancer. So these are the benefits. Why shouldn't the woman have it? They should definitely have it. And if you ask me, every type 2 diabetic right from day one should have a pioglitazone and metformin on board unless there is a contraindication to their use. So what is the conclusion? Pioglitazone is a very valuable treatment option in patients with type 2 diabetes, especially Indian patients. And they are recommended by all the guidelines. The benefits far outweigh the risk in those patients responding well to pioglitazone. Careful selection of patients. Again, I said, careful selection of the patient and monitoring the response will help in optimizing treatment of the patient. And this is irrespective of the gender of the patient. So every type 2 diabetic Indian should get a metformin and pioglitazone unless there is a contraindication. Thank you very much for your kind attention.
Thank you so much, Dr. Panikkar. I just had to add that this topic was given to you because PIO does have benefits. You have explained it so beautifully. But in women, we have to be a little cautious during their reproductive age, during the menopause, because you see it increases fractures during menopause. And even in the reproductive age, you know, these patients who are on PIO become pregnant and you have had it. That's the only word of caution that we had to add to the women.
Benny, PIO doesn't make them pregnant. Somebody else does.
Yes, I didn't mean that. But I think we need to avoid, because 90% of the time pregnancy is not planned. So in the preconception age itself, we have to omit these drugs.
What I would like to say is, in the reproductive age, if proper contraceptive precautions are not taken, whether there is PIO or no PIO, she can get pregnant. So there is nothing to blame PIO for it. But yes, PIO in patients like PCOS can cause ovulation and help in pregnancy. That's a different thing. But an average lady taking pioglitazone, that pioglitazone is going to make her pregnant is not the answer. She can become pregnant otherwise.
I didn't say that. Anyway, so we next.
Wonderful talk.
Thank you, Vijay.
What was the dose of pioglitazone used in the IRIS trial?
Come again?
Those are the pioglitazone in the IRIS trial.
15 to 45 milligrams.
Okay.
Can I have? Can I ask a question?
Sure.
To Panikkar?
Yeah.
Dr. Panikkar, if we control diabetes well, with hemoglobin A1C of less than 6.5 and a fasting always around 110, is PIO needed?
Yes.
No drugs, only on diet and exercise.
Madam, you are not treating insulin resistance. This patient, every Indian is an insulin resistant.
Yes, but the insulin resistance varies from person to person. This fellow may have less. That's why he improved.
I agree. But 80% of type 2 diabetic, once you have diagnosed, 80% of them are insulin resistant. And if you see the cardiovascular complication starts 15 years before the onset of diabetes.
You know, I take it with a pinch of salt.
No,
I take it with a pinch of. Okay.
Yeah, money. See, basically, hyperglycemia is not what causes the macrovascular complications. Hyperglycemia only accounts for the microvascular complications. The macrovascular complications are driven by hypertension, dyslipidemia, and the pro-atherogenic milieu that is there, secondary to insulin resistance. All the inflammatory cytokines are high. That is not being reflected in your HbA1c or your blood glucose. Yeah. So once you make a diagnosis, they should be treated unless you have evidence to show that there is no insulin resistance.
No, there is a different way of looking at it. For example, I achieved this good control in that patient by regular exercise, which is about an hour of walking or gym, and rest of the things. So it will take care of everything. Why would you not accept that? Madam, a person who has gone from a diabetes state to pre-diabetes or even a normal, partly reverse, why would he develop? I agree there are so many things, but you know, when you look at complications, for example.
See, this morning I have had online consultation with my patient, Nitin Dedia. He is my patient since 2008. And today he's only on a metformin and pioglitazone and absolutely well controlled. 6.4 HbA1c. And he wanted to know whether he can stop pioglitazone. I said, "Tu milega to marunga main."
Your views are, I agree with you. You may very, yes.
He's absolutely well controlled with just
but no, I will say, I will say his genes are better. He was not prone to develop any complication. People who have treated diabetes for 20 years will know so that in a family, if the father died of a cardiac attack, the son is likely to die of cardiac attack. If somebody has a preponderance to developing a renal complication, so there are not one factor. There are multiple factors here at work, and there are genetic, hormonal.
No, I agree.
There are so many of them. Because whenever you say there is a 70% reduction in cardiovascular disease, you're also saying that 30% don't get benefit.
Correct,
We
madam.
hardly ever look at it.
Yeah. Madam, the Irish study which was done in non-diabetic patients. It was done in non-diabetic patients who had insulin resistance. And that was the benefit that was shown. And in the pre-diabetic, the benefits are phenomenal. None of these drugs, no SGLT2, no semaglutide, no liraglutide can even match that. And those were pre-diabetics. And the majority of them were non-diabetics. They just checked the HOMA. If the HOMA was more than 3, they were given pioglitazone.
Well, I will be converted to your views when I look into these and look at the conflict of interest. Every study has some conflict of interest.
Irish study was.
I think so.
Irish study was a fallout after the proactive study, which showed 47% reduction in stroke. So because they found that in the proactive study, this study was done in non-diabetic patients to only check if treating insulin resistance can do the work. And that is what they have shown.
Okay.
I think we'll conclude here. Thank you very much for the discussion.
Thank you.
We'll carry forward the
some other
the conference. Yes.
Thank you.
Thank you, Vijay.
Thank you. Thank you.
I request.
Can we request the next chairperson to introduce Benny ma'am, please?
Dr. Sanata.
Sanita.
I think there's no need to introduce me, but of course, Sahita, yeah, you could just say something.
I would love to. I would love to. So here, there's heart, soul, and body behind this Wodcon. Our very own Dr. Benny, as she herself has very correctly pointed out, there is no need. But this is from different perspective. This is just that she is very humble. So she says there is no need to introduce. For us, she is omnipresent. She is everywhere. And she is the epitome of what women in diabetes should be. So she is the director of Dr. Negelu's Diabetes and Thyroid Specialty Center. She is a consultant diabetologist with Jupiter Hospital, Thane. She is also teaching faculty for fellowship in diabetes at DY Patil University and PHFI. She is the fellow of the American College of Endocrinology, FACE and Diabetes India, and also for fellowship in diabetes. Fellow of the American College of Physicians and Indian College of Physicians. Apart from that, there are many more laurels that she has with her. Editor of Awakening. She has written several chapters on diabetes in reputed textbooks of medicine and diabetes. A wonderful orator. And we always love to listen to her because her talks are full of knowledge, superb language, great command over her language and content and knowledge, of course. So the stage is all yours, Dr. Benny ma'am.
Thank you, Sarita. I think you have raised me to the skies now. I have to keep up with your compliments. So let me just share my screen. Yeah, so just to inform you that this is a pharma-driven talk, and therefore, I think my last slide has come first. Yeah. Therefore, there might be a little bias, but this is the hunt for the best basal insulin. So we know that since the discovery of insulins, more and more newer insulins have evolved over the last 100 years. not only the rapid insulin and ultra rapid, but also basal insulin and the ultra long insulins. And if you think why this newer insulin are sought after, it is because there's no insulin as of now which really matches the secretion of from the beta cells. Because when the beta cell secretes insulin, it at 50% of it is already destroyed in the liver, and only 50% is required by the body. And here you're injecting an exogenous insulin that should match the physiology of insulin and glucose hemostasis. So today I will cover the unmet needs with insulin in diabetes management and how to break the barriers of insulin inertia. We'll see how the basal insulins evolved, and we will compare two second generation long-acting basal insulins. So we know that why hunt for newer insulins? Because this is Indian data. So by Ramachandran and all, the International Diabetes Management Practice Study, the Indian subset, which was presented at RSSDI 2017, and it's shown that 1 in 5 patients with type 2 diabetes achieve the HbA1c less than 7 with insulin therapy. And only 2 in 5 patients with type 2 diabetes reduce the insulin dose after a minor episode of hypoglycemia. And 77% who experience hypoglycemia after 6 months of the insulin initiation discontinue within a year. So suboptimal insulin experience actually stir patients away from good glycemic control. And there are so many barriers that we face in our Indian patient. And this was a study in 185 patients. And I'm not going to elaborate, all of you know all these barriers, but let me say that fear of hypoglycemia, although it is 15.2% here, in my practice, I feel that is the greatest barrier, because if one episode of hypoglycemia, the patient is so frightened that titration of insulin becomes difficult. Even if you ask them to reduce by 4 units, they will reduce by 2 units. And it was Elliot Jocelyn, he was the father of diabetology. When the discovery of insulin was made in 1921, the first thing he said is insulin is here for survival of patients with type 1 diabetes. But there is a dark side of insulin, and that is hypoglycemia. And day-to-day blood glucose insulin stability is another cause. We know that a lot of variability is there. Sometimes the patient shows, say, a fasting of 120, and suddenly in the evening they go into hypoglycemia or hyperglycemia. So intraday variability and interday variability is also common in insulin requiring patients, both in type 2 diabetes and of course in type 1 diabetes. Other barriers are lack of titration. Patients are not educated, or even if you educate them, they feel they can titrate for a few days and then they are lost to follow up. They stop doing SMBG. They also have a problem with the cost of medication and also the cost of strips, and weight gain, lack of support is an issue. So if you need a improved quality of life, you have to weigh the balance between complications, tight glycemic control, and also see that hypoglycemia is less. We know that we have to control our patients tightly to decrease complications, increase the quality of life, and decrease the healthcare costs. And on the other hand, you don't want any hypoglycemia, because the fear of hypoglycemia itself can decrease the quality of life, can also reduce productivity and increase the hospitalizations and healthcare costs. Also, those who are on insulin, adherence is a big problem. And adherence to insulin, and they don't even take their OHAs, and so they are totally out of control, increasing the number of complications. So treatment of with insulin should aim at a good balance between glycemic control and hypoglycemia if we need to improve the quality of life. Now, all these guidelines recommend that if you need to initiate insulin for the first time in a patient, we must initiate, it would be convenient to initiate with a basal insulin, except for this RSSDI and in our Indian guidelines. So we have two options here. basal insulin and a mixed insulin, which is very widely used in our country. Let's see how these insulin evolved. So first was the NPH insulin, and you can see on the right-hand side, the yellow curve, it is going up so steeply and then also coming down so steeply. So glucose actually rises earlier than what happens after a meal, and it comes down earlier, and patients go into hypoglycemia somewhere around 4 to 6 p.m. And that was known for many years. Another aspect is that there's a variable absorption of NPH. So there's a lot of variability in 24 hours and also inter-day variability with NPH insulin. You also need a second dose of insulin if you need to cover 24 hours to make it a near basal insulin. Then came glargine 100 and insulin detamine, and you can see that compared to NPH, glargine 100 had a less steeper curve. It is not absolutely flat. There's a little hump here, but it does cover 24 hours. And compared to glargine, detamine has a greater hump. So variability is much more in insulin detamine, and it may be required twice a day. And therefore, they made newer insulin, the ultra long acting basal insulin, and we have two of those, insulin glargine 300 and insulin degludec. If you see the curves on the right hand side, compared to insulin glargine, degludec has a flat curve, and so does glargine 300. So you see insulin degludec is a zinc phenol formulation. It exists as dihymers, and once it is injected, it forms multiple hexamer chains, which then are released very slowly when this zinc is exposed and then converted into dimers and then monomers. But important to remember is that these monomers bind to albumin, and because they bind to albumin, they release insulin very slowly, one. And number two, it depends on the level of albumin. If there's a hypoalbuminemia, you see there's a chaos in the basal insulin management. Whereas glargine is a compact depot formation, and you can see very well explained in these figures. It's a compact depot with a lesser surface area compared to glargine 100, which has a larger surface area. And so lesser the surface area, more the compactness, more gradual and slow release of the depot of insulin from its surface compared to insulin glargine, where more of the insulin is released. So compared to glargine 100, glargine 300 has a greater, is more long acting and more slower release of insulin, giving a good peakless control of the blood sugars. So do we have data to compare the two? You see the BEGIN trials. In the BEGIN trials, IDEC was compared to glargine 100. And you can see all the point estimates here on the right-hand side, suggesting that there was a better A1C reduction with glargine 100 compared to IDEC 100. And then you have the addition trials now, where they compared glargine 300 with glargine 100. And here the point estimates are distributed, but if you see the overall HbA1c reduction, it's in the neutral line, which shows that both these glargine insulins have a similar HbA1c reduction with glargine and 100 and 300. But when glargine 300 was compared with IDEC 100, both the long-acting insulins, the ultra-long-acting as they are known as, second generation, you will see that IDEC 100 has a higher hump, showing in this CLAMP study in patients of type 1 diabetes, where they looked at the glucose insulin dispersion, they found that glargine IDEC 100 has more variability than glargine 300. So glargine scores over this. It has a 20% lesser within day variability with glargine 100 compared to IDEC 100. And then now if we start again comparing the second generation basal insulin, starting from the PKPD in type 1 patients you will see that there's less fluctuating steady state PD profiles, that is lower within day variability with glargine 300, and it is more evenly distributed pharmacokinetic profiles. And even when compared to IDEC 200, there was lower within day and day-to-day variability in glucose lowering effect. So when they looked at the trial level meta-analysis, again, we just saw the begin and the addition trials here. There is less improvement in A1C with IDEC compared to glargine 100, but it has a benefit with nocturnal hypoglycemic effect. And when glargine 300 was compared to glargine 100, there's a similar HbA1c reduction and hypoglycemic benefit both at night and any time of the day. In the real world analysis, when they did a head-to-head comparison in the DELIVER trial, which had more than 3,000 patients, and the Lightning trial, where there was more than 1 lakh patient, and they switched to glargine 300, and there was a switch where glargine 300 versus IDEC 100, there was comparable improvement in glycemic control and reduction in hypoglycemia risk with glargine 300. Rates of severe hypoglycemia were similar without compromising on the HbA1c reduction. So was there an head-to-head RCT? Yes, now we have 2 RCTs head-to-head comparing glargine 300 with IDEC 100 in the BRIGHT study and glargine 300 with IDEC 200 in the CONCLUDE study. So we'll talk of the BRIGHT study here. So BRIGHT study is a multi-center open label non-inferiority study done in type 2 diabetes patients, all adults above the age of 18, and they divided these participants into 2 cohorts. One cohort they gave glargine 300, the second cohort they gave IDEC 100, and all of them had an HbA1c more than 7.5 and less than 10.5. There was no prior insulin use. They were between the BMI 25 to 40, and they followed up these patients for 24 weeks. And let's see on comparing in this RCT, in the first 12 weeks, you see a good HbA1c reduction for both the insulins. So there is non-inferiority of glargine 300 versus IDEC 100 in the HbA1c reduction. And then from 12 weeks to 24 weeks, you see both these lines are almost superimposed. So it shows that they have a similar HbA1c reduction. And here in the bar diagrams, you can see that in 24 weeks, the HbA1c came from 8.7, 8.6 to 7 in both these groups. But when they looked at the hypoglycemia and anytime hypoglycemia in the titration phase itself, that is 0 to 12 weeks, you will see that hypoglycemia was much less, better with glargine 300, and the event rates were also less with glargine 300. And when they looked at the nocturnal hypoglycemia, remember that we always worry about nocturnal hypoglycemia with the basal insulin. In this study, in the titration phase, that is 0 to 12 weeks, the hypoglycemia, nocturnal hypoglycemia was much less in patients taking glargine 300. So what does it mean? It means that patients have fear of hypoglycemia. And that fear of hypoglycemia is much more in the first hypoglycemia. So when we need to initiate patients with a basal insulin, it is best to start with an insulin which does not have glycemia or which has less hypoglycemia. And the BRIGHT study has taught us that in the first phase or the titration phase, the hypoglycemia, both anytime hypoglycemia, as you can see here, incidence of anytime confirmed hypoglycemia, event rate of 24 hours confirmed hypoglycemia, anytime confirmed hypoglycemia is anywhere between 23% and 43%. It is much less than IDEC 100. And that gives us more confidence to start or initiate a basal insulin because we are safe. I mean, the patients are safe that they will not have a nocturnal or anytime hypoglycemia. And when they looked at the sub-analysis here, you see the renal bright study. They looked at patients with GFR more than 90, with a GFR between 60 and 90 and GFR between 60. And you will see that the mean change of the HbA1c was similar to both these insulin when the GFR was more than 90. It was a little less. The HbA1c change was much lesser in glargine 300 compared to IDEC when the eGFR goes lower and lower. So it is 60 to 90, it was lower. And you see as the GFR goes much lower, less than 60, the effect of glargine 300 remains. There is a greater change in the HbA1c, but what happens to IDEC 100? You see the HbA1c goes up. And why is this happening? Renal patients are compromised patients. They do have albuminuria, they have hypoalbuminuria anemia in there. And therefore, glargine, IDEC 100, which is mainly bound to albumin, gets disassociated, and more of IDEC is present in the blood, disturbing the glycemia in these patients. And when they looked at the elderly patients, as you can see here, there was a greater HbA1c reduction with glargine 300 versus IDEC 100 in those aged above the age of 70. And the hypoglycemia risk was similar with both insulins in these older patients. So it works well also for elderly patients. So in summary, when you compare glargine 300 versus IDEC 100 in type 2 diabetes patients, we find that glargine 300 has a greater HbA1 reduction in renally impaired patients. It has a greater HbA1c reduction in the elderly patients, more achieved glycemic targets without hypoglycemia. And so patients are less anxious about hypoglycemia, and there is increased treatment satisfaction. Besides that, if you look at the variability, the intraday variability, you'll see that in glargine 300, there's a 23% lesser variability compared to IDEC 100. And there's a 22% greater peak with IDEC 100. So there is more insulin compared to glargine 300. And this is a randomized crossover study with 30 type 2 diabetes patients who were put on once daily glargine 300 or IDEC 100. And a CGMS was done for 5 days on each insulin treatment. And the objective was to compare the efficacy and safety of these two insulin on the glycemic control using a continuous glucose monitoring. And they saw the percentage of time within the target glucose range of 70 to 180. We know that we have to keep all our patients in the time in range should be around more than 70, which corresponds to an HbA1c of less than 7. And in this, they found comparable time in range for glargine 300 versus IDEC 100, with a time below range markedly lower for glargine 300 across all categories of hypoglycemia, as the figure on the right shows. Anytime hypoglycemia lesser in glargine compared to IDEC, nocturnal hypoglycemia lesser in glargine compared to IDEC, and severe hypoglycemia much lesser in glargine compared to IDEC. And so you see the p-values are very significant here. So this is an advantage to use this glargine 300 in these stratified patients. Another study, which is a randomized crossover study with 24 type 2 diabetes patients on one daily insulin glargine and IDEC 100. And they wanted to compare the efficacy of safety of both these insulin on glycemic control using a flash glucose monitoring. Again, looking at the time in range as the endpoint. And you can see here the arrow very nicely shows that the percentage of time in nocturnal hypoglycemia with glargine 300 was significantly lower than the IDEC treatment. And glargine 300 is here in these empty bars compared to the solid bars, as you can see. So hypoglycemia and nocturnal hypoglycemia was less. So let's see significantly better safety profile with glargine 300 versus, so we know that low albumin levels have strong positive correlation with diabetes or high A1C. So that is what happens to the renal patient. And increased hypoglycemia rates with IDEC, which is 99% albumin bound compared to glargine 300, which is not albumin bound, is attributed to hypoalbuminemia and increased free fatty acid levels in type 2 diabetes, especially at 9. Because mean percentage of time with hypoglycemia was markedly lower in patients of glargine 300 compared to IDEC 100. And the p-values here are very significant for the mean percentage of time with hypoglycemia, time with severe hypoglycemia, and percentage of time with nocturnal hypoglycemia. So in summary, we know that suboptimal insulin experience steer the patients away from achieving glycemic goals. Basal insulin is endorsed by all global guidelines to be the most convenient insulin to start insulin therapy. And there are second generation basal insulins like glargine 300, which have a better and safer profile compared to other insulin. And we have data for that. The BRIGHT study has shown significantly lower risk of hypoglycemia with glargine 300 compared to IDEC 100 during the titration phase when we have to initiate patients with an insulin. And glargine 300 has demonstrated effective glycemic control and acceptable safety in diverse patient groups across the real-world studies and randomized controlled trials. Thank you. Thank you very much. So let me stop share. Yeah.
Thank you very much, ma'am. This is indeed a wonderful lecture.
Hello.
Yes,
Yeah, thank you so much, ma'am, for a wonderful talk. And can I invite Dr. Ishita to introduce the next speaker? Is she here?
Hi, sorry, technical glitch. Sorry,
Are you okay?
Yeah. Yes, ma'am. So I would like to introduce Dr. Dakshita, ma'am. She's a diploma diabetes. She's a preventive diabetologist and director at Concord Diabetes Center in Mumbai. She's also the founder of Om Diabetes Club, which is a group of 15,000 diabetes patients, founder of the UDF, founder of Diabetes Revise and Update meets for general physicians, gynecologists, and pediatrics. And she has done a lot of work at national and international events. And over to you, ma'am.
Thank you, Ishita. At the outset, let me thank Benny ma'am and Neglu sir for giving me this opportunity to be part of Wodcon, and congratulations team Wodcon for this already super success of the Congress. Let me start sharing the screen, sir. Ma'am will have to give me a minute. Is my screen visible?
Yeah.
Yes, ma'am.
Okay. 1 second. Okay, so today the topic given to me is current and potential therapeutic use of metformin, the good old drug. The session is about old but gold drugs. So whenever we are labeling any drug as old drug, the journey is very important. The fact that we are still using any old drug, that means over the period of last so many years, there has been, this journey has been very, very long. When insulin was discovered in 1921, first time metformin was first synthesized in 1922. 1950, when first SU was invented, first use of metformin started in clinics for type 2 diabetes in 1957. 1998, when glitazones were invented, by that time already, I mean, in 1995, it was quite late. The US FDA gave approval for metformin use. And 1998, with Wikipedia's, it reconfirmed our belief in metformin as a CV positive drug, that it is very, very safe, and it has proved its cardiovascular superiority in outcome studies. In 2005, when GLP-1 mimetics were invented and DPP-4 inhibitors in 2007, it was diagnosed one more feather in metformin's cap, that a lower incidence of tumors was associated in type 2 diabetic patients. Cancer patients were retrospectively analyzed, and diabetic patients who were on metformin, there was lesser incidence of metformin. And in 2013, when SGLT2 inhibitors were invented, already the use of metformin in cancer, obesity, PCOS, GDM, CVD, anti-aging trials, so many feathers in metformin cap. So in next 10 to 15 minutes, I'm just going to revise this drug. Everybody knows about this drug, but just a quick revision when we are updating about new drugs. Just a quick revision, that it increases glucose uptake and utilization by peripheral tissues such as skeletal muscle and adipose tissue. Simultaneously, it decreases hepatic glucose production through suppression of gluconeogenesis. These are the typical, two effects we talk about when we talk about metformin. And this is the main pathophysiology of this type 2 diabetes, that reduction of insulin resistance and improving insulin sensitivity. That is what we try to do throughout the life journey of a type 2 diabetic patients by giving good lifestyle modification, diet and exercise. And this is something which is, physiological, and that is being executed by metformin. Now, this is a little complicated slide, that metformin is transported into hepatocyte and molecular mechanism. This is a proposed molecular mechanism. In all stages of diabetes continuum, right from pre-diabetes, type 2 diabetes, complications, and extra glycemic effect, that is beyond type 2 diabetes, metformin is extending its care. Metformin has been used very much widely. It is ADA 2021 has already recommended metformin as a therapy for pre-diabetic patient for prevention of diabetes, and probably going towards normoglycemia when patients are about BMI is about 35, age is about 60, and definitely women who has previous history of gestational diabetes. Now, this is the drug which has strongest evidence-based and long-term safety as a pharmacological agent for diabetes prevention. Let's see how. These are two landmark studies. DCLIP, there was risk reduction by very much significant number, 32%, and in IDPP, risk reduction was by 28%. Now, all the guidelines are on the same page. Canadian Diabetes Association, International Diabetes Federation, International Diabetes, IDF. These are the drugs which are saying that from 250 to 850 milligram, whenever we are prescribing metformin for pre-diabetic patients, we have to be bold. We should not get stuck at 250 and 500. Though patient is lean, patient may be having a lot of visceral obesity, severe insulin resistance. So the dose of metformin can be up to 850 milligram in pre-diabetic patients as well. Now, when metformin is compared with other drugs as a monotherapy, the reduction is almost 1 to 1.5%, which is taken as a standard for many landmark trials. So not used in combination other drugs when compared with metformin, the results are almost at par. ADA guidelines, AACE guidelines, it recommends that after lifestyle modification, metformin should be the first drug to be introduced as a monotherapy, first line of treatment. Now, the monotherapy and metformin-based combination therapy for type 2 diabetes. Evidence supports metformin as a first-line therapy and its beneficial effect on A1C, weight, and CV mortality. So this is what I just mentioned, that when we compare with TZA, DPP-4, SU, DPP-4 used alone for 52 weeks, it gives similar results of reduction of HbA1c. Now, as and when we go on intensifying dose from 500 milligram to 2000 milligram, the reduction in fasting plasma glucose, HbA1c, and postprandial plasma glucose is very much significant. So, just a few slides back, I mentioned that the dose has to be very bold. Probably Indians require not less than 1000 to 1.5. The dose has to be between 1.5 to 2.5. Now CKD, it was 10 to 15 years back, it was like whenever creat will be more than 1.1, 1.2 or EGFR slight reduction, metformin has to be stopped. Once metformin is stopped, sugar will be haywire and there will be a vicious cycle of hyperglycemia and worsening of nephropathy. Now metformin can be given from mild to moderate CKD. This is the data from Wikipedia in 1998. It is seen that when metformin treated patients were compared directly to those of sulfonylurea or insulin, they experienced fewer diabetes-related endpoints and less all-cause mortality and stroke. So this is absolutely proven since last almost, you can say, 15 to 20 years. So these are other trials, a home trial and spread DIMCAT trial. That was one was with placebo and one was with glipizide. That metformin, has reconfirmed our belief in this molecule with respect to CVD outcomes. Very important study. This is an article from Diabetes Research Journal 2020. Metformin treatment is associated with a decreased risk of non-proliferative diabetic retinopathy in patients with type 2 diabetes mellitus. This is a population-based cohort study, and the results were amazing. 24% reduction in risk of retinopathy in type 2 diabetic patients who were treated with metformin, and potential trend was found for a reduced sight-threatening diabetic retinopathy risk in patients who had previously been diagnosed with NPDR. So forget about patients who never had retinopathy, patients already who had NPDR, progression toward STDR was reduced when patients were on metformin. Now this is something which is like metformin gets gold medal when we talk about PCOS and GDM. It has a mild anti-androgenic effect, reduces risk of miscarriage. I mean, this is just a revision for all of us, but I'm going to definitely enumerate this, that this can be used as a second-line ovulation induction agent, decrease OHSS with IVF, reduction in weight, safety, efficacy is almost comparable to insulin, reduce risk of miscarriage, and decrease neonatal hypoglycemia. Now, this is the one trial which we all know, MIG trial. Almost 750 women from Australia and New Zealand were, study trials started in October 2002. And metformin alone or with supplement with insulin is not associated with increased perinatal complication as compared with insulin. And definitely women preferred metformin to insulin treatment. The reason is very much obvious. Now this MIGHTY study, the results were out in 2020. It's a very large multi-center study, 25 centers from Canada and Australia, metformin versus placebo trial, and metformin has several maternal, glycemic and neonatal adversity benefits were observed. When we are treating PCOS patient, this molecule is very crucial for PCOS patient, not from just a menses point of view, weight gain point of view, or infertility point of view. But when patient has PCOS with menstrual irregularities, hirsutism, it acts at that point. Anovulatory cycles with PCOS, metformin has some role. PCOS who wish to conceive undergoes IVF, this molecule has a very, very important role. During pregnancy, whether patient pregnancy is normoglycemic or pregnancy has GDM or already existing type 2 diabetes, definitely it reduces miscarriage rate and it reduces risk of GDM if patient is normoglycemic. And when this PCOS patient becomes type 2 diabetic patient, metformin improves dysglycemia and other metabolic dysfunction in future. Association of this is same thing which we just studied, that these are the studies which aim to compare pregnancy outcome in women with pre-existing type 2 diabetes receiving metformin or standard insulin therapy, and the results were at par. Metformin treatment for women with type 2 diabetes in pregnancy is not associated with increased risk of adverse pregnancy outcome when compared with insulin therapy. Dose of metformin showed efficacy in reducing insulin resistance and decreasing androgen level. So these are few studies. The dose should be around 1500 to 2500 milligram. I'm repeatedly mentioning this, that the dose is very, very important. And then it has positive effect on fasting glucose, fasting insulin, and HOMA index as well. When metformin is combined with insulin, it definitely improves insulin resistance. So logically, it is going to reduce the external exogenous insulin dose, and eventually, if patient is not over insulinized, the weight gain will be stopped. NAFLD is something which is a big problem. 50% of the patients already have type 2 diabetic patients. They already have NAFLD, and this is the probable mechanism that metformin acts positively in NAFLD. It reduces glucotoxicity, it improves insulin resistance, it decreases gluconeogenesis, increases glucose uptake at the peripheral level, and it increases fatty acid oxidation. So these are few things which are going to go in favor of treatment of NAFLD. It has a beneficial role in patients with NAFLD, improving all liver biochemistry parameter. We are monitoring all women patients' FIB score. And in FIB score, patients who are on good dose of metformin, FIB score definitely settles down with good weight loss and reduction of insulin resistance. And metformin appears to be safe in mild liver disease as well. Now, when we are talking as metformin beneficial role in cancer, that through GI absorption, it goes to portal circulation, then systemic circulation, and it is an indirect effect. There is an indirect anti-neoplastic effect. Probably it is, it reduces insulin resistance. Insulin is an anabolic hormone. We know that, insulin resistance is the one of the main cause for neoplastic problems. So this anti-neoplastic action of metformin definitely, it is proposed mechanism by which metformin may influence cancer biology, and there are so many studies going on. We are beaming with evidence. 2015 metformin, new era to cancer therapy, metformin and cancer, existing drug for cancer prevention and therapy cases in 2018. 19 metformin and its implication in cancer therapy. So there are so many studies to prove its anti-cancerous role. I'm not going to go in the detail of this because I suppose COVID is already over. So repurposing is just that patients who are on metformin, they had less ventilatory, they required less ventilatory support. The recovery from ICU admissions were fast, and the mortality rates were low. Interleukin levels, knowing its anti-inflammatory property, interleukin-6 levels were less. So these were few findings which we all have observed in last few years. So convincing properties of metformin that it sets apart from rest is greater potency, 100%. Since it is beta cell independent, it has enhanced durability of effectiveness. It has clear benefit on the incidence of long-term microvascular and macrovascular complications. And the cost, very important. GLP-1, 7 lakhs per annum, SGLT2 inhibitors, 3.5 lakhs per annum, and metformin given in the correct dose with good lifestyle modification and good patient education, annual cost is less than 4,000. It is critical to favor the most cost-effective option in treatment of type 2 diabetes. So in summary and conclusion, it is effective, safe, weight neutral. Probably it causes to some extent weight loss because of its GI effect and reducing hyperinsulinemia. Low risk of subsequent treatment intensification is required if given in a good dose. Associated with improved mortality in elderly patients with type 2 diabetes, provides unique cardiac and renal protection. It has clinical outcome studies for CKD, CHF, CLD, cost effective, For non-diabetic patients, non-diabetic uses PCOS, GDM, NAFLD, COVID-19. These are the extra glycemic effects, and perhaps in your future we may see other indications to use metformin in non-diabetic patients as well, because insulin resistance is a core pathology to many metabolic problems. So this is something which we just mentioned, and very important, it has freedom from hypoglycemia, so there is less glycemic variability, time tested, cost effective. So one answer is metformin, and 60 years of metformin use, and it is just blooming and branching. It's not just insulin resistant, type 2 diabetes, pre-diabetes, but anti-inflammatory effect, some role in tuberculosis, aging, slowing of aging, microbiota, cancer, and whatnot. Thank you so much.
Thank you, Dr. Dakshita, for that wonderful talk.
Yeah. Thank you, Dr. Dakshita, for the wonderful talk. And for the want of time, we will go to the next session, which is the session called Fresh Look. For this session, I would invite Dr. Firdaus Sheikh, Dr. Dakshita Padde, and Dr. Dhruvi Hasnani to chair the sessions.
Good evening, everyone. Thank you so much, Shilpa ma'am, for the warm introduction. It's great to be a part of the 6th Women and Diabetes Conference. And more importantly, it's very humbling to be a part of such esteemed faculty. It's an honor for me to introduce our next speaker, Dr. Lily Rodrigues ma'am. Dr. Lily Rodrigues is a consultant diabetologist and general physician. She graduated from one of the most prestigious medical colleges in our country, St. John's Medical College, Bangalore. She is currently the director at the Soraksha Diabetes Center, Hyderabad. She is the chair-elect of RSSDI Telangana chapter. She is the chairperson of Indian Society of Hypertension Telangana chapter. She's been a DNB teacher since 1998 and also a principal investigator in several global and national clinical trials. A very warm welcome to you, ma'am. We look forward to your talk ahead.
Thank you very much, Dr. Firdaus Sheikh. Nice to meet you on virtually though.
Same here,
can I share my screen? RX, help me, it's not coming.
Ma'am, press on the green button, share screen.
Yes, I did that. Okay, share. Yeah. At the outset, I would like to
thank the full screen.
Full screen?
Yeah.
Ma'am, at the top, there is a button called slideshow.
Slideshow.
Yes, ma'am. At the top. After that animation tab.
Yes, I'm not able to see it though.
Ma'am, right on top. Yeah, after this animation, there is slideshow.
That's 7th tab.
I'm in line with file
home in that line.
Where?
Slide.
Yeah, right above that. Where you're at the same line.
Yeah. Keep going right. Keep going right. Keep going right.
Slideshow. Yes.
Now press from beginning.
Slideshow from beginning.
Yeah.
Yes. Thank you.
Great.
Great. Thank you. So at the outset, without wasting time, I thank from the bottom of my heart, Dr. Benny and Vijay Negilur and all the wonderful ladies who are part of this team. And it's an extraordinary conference that I've been watching from yesterday. And I feel humbled to be part of this conference as a speaker amongst all the wonderful national and international speakers around. the topic that is given to me is challenges in transitioning from midlife to menopause with diabetes.
Ma'am.
Yeah, the transition from midlife, it's a very big step in the journey of a woman who is passing through the midlife into menopause. So I'd like to start this, the slides with the saying from Marcel Proust: the real voyage of discovery does not exist in seeking new landscapes, but in having new eyes. My presentation outline would be definitions, menopause in general, a case presentation, symptoms of menopause transition, challenges of transition to menopause with diabetes, bone health in perimenopause, cardiovascular health in perimenopause, and role of a physician at the end. So coming to the definitions, these are not unknown to the audience here, but I'd just like to recapitulate. Premenopause is reproductive period prior to the menopause. Perimenopause is 5 years before and 1 year after the menopause. Postmenopause, as we know, 1 year after the cessation of periods. And surgical menopause is after surgical removal of ovaries or uterus or both. And predominantly ovaries has to be removed. And then premature menopause is menopause when it occurs before the age of 40. Now, what is menopause transition? Menopause transition is otherwise called as perimenopause, which includes both the period leading up to menopause and the menopause itself. Most women start perimenopause in their 40s, but some do as late as their 60s, but 45 to 55 is the average age. In most cases, menstruation ceases gradually. Because of the erratic production of hormones, women may skip periods, bleed at odd times, or have extra heavy periods, otherwise known as abnormal uterine bleeding. A small number of women may stop menstruating abruptly, almost overnight, as it were. So now I have been going through the literature for menopause, midlife transition to menopause. There are many articles available, but the one which I found very useful for us was the SWAN study, the study of women's health across the nation, which was done in the US. Unfortunately, there are not many studies done in our country like India. And particularly, there are no studies done on menopause transition in women with diabetes. These studies, the main results are as follows. The menopause transition, otherwise known as MT, is a major health milestone for a woman with influences that extend far beyond the reproduction. In addition to the symptoms that accompany menopause, concomitant biological, psychological, behavioral, and social changes that shape women's midlife to the future health. So we have the reproductive axis where there is a decline in estradiol and increase in the FSH during the menopausal transition. Then menstrual cycle patterns may vary, as I just said. About 35% or above women may have anovulatory cycles, which can be diagnosed with the ultrasonography of pelvis, where antral follicular count can be done. And the antral follicular count, if it is less than 1,000, it is diagnostic of menopause transition happening. Then there are vasomotor symptoms. About 80% of women have vasomotor symptoms, and these may last as much as 8 years after the menopause. Then there are sleep disturbances. They keep increasing across the menopausal transition and menopause, and poor sleep will also have an adverse effect on the cardiovascular health in future. Coming to the mental health, depressive and anxiety symptoms are very predominant in the women who go under midlife to menopause, more during peri and post menopausal period. And other factors like stressful events, financial strain, low social support, and sleep problems, and low physical activity also will contribute to the depression. As far as the testosterone is concerned, that is the only hormone which will enhance the depression. Now, cognitive symptoms also are deranged. Menopausal transition, the cognitive changes may affect learning ability during the menopausal transition, but improves after the menopause, immediately after the menopause has occurred. Age-related cognitive decline starts much after the menopause. So then coming to the genitourinary and sexual health, the sexual decline happens almost 20 months after the last menstrual period. Cardiovascular metabolic health, there is a fat redistribution. The central obesity and gluteal obesity can fast occur during the menopausal transition. Then there is a change in the lipids. There's increase in lipid LDL and apolipoprotein B and triglycerides as well. And there is a loss of protection from high HDL, which occurs during menopausal transition. Sex hormones, that is estradiol and FSH, when vasomotor symptoms aggravate the CV risk in menopausal transition. These were all the findings of SWAN study. The metabolic syndrome risk and vascular remodeling at midlife are driven by the menopause transition again. Bone health, the bone mineral loss begins a few years before the last menstrual period, and that is during the menopausal transition and 2 years after the menopause, up to 2 years after the menopause. So there is also a change in the physical functioning, but it may not happen during the menopausal transition. The main changes that are seen are predominantly due to the hot flushes and sleep disturbances that are vasomotor symptoms that are part of the menopausal transition, and a woman might feel that her physical function has declined, but there is no science behind it. So, but as the age advances during the menopause and after, it can happen. Now, I would like to allude to the new AHA scientific statement that was the cardiovascular statement that was given in December 2020 on cardiovascular risk position statement. Changes in hormones, body composition, lipids, and vascular health during the menopause transition can increase a woman's chance of developing cardiovascular disease after the menopause. And then this emphasizes the importance of monitoring women's health during midlife and targeting this stage as a critical window for applying early intervention strategies that aim to maintain a healthy heart and reduce the risk of heart disease in future. Now I'd like to present a case, which is a typical case in our part of the world. A 46 years old with type 2 diabetes, 11 years on. She had a gestational diabetes at the age of 29 and 31, and 4 years later developed type 2 diabetes. She has been complaining of feeling dizzy and suddenly feeling hot and sweaty for the past few weeks. Her sleep has been disturbed and she wakes up feeling tired and sleepy. She has also been feeling weepy and depressed off and on. So what are the challenges that we see in this case? Vasomotor symptoms mimicking hypoglycemia, sleep disturbance affecting energy levels and ability to execute, depression worsening glucose control, sleep disturbances increasing weight, depression, mood swings causing lack of interest in self-monitoring. So now coming to the signs of menopausal transition, hot flash, which are common to both diabetic as well as non-diabetic women. hot flashes, breast tenderness, worse premenstrual syndrome, lower sex drive, fatigue, changes in menstrual periods, vaginal dryness, discomfort during sex, urine leakage when coughing or sneezing, and urinary infections, which are very frequent, and mood symptoms, as we already said. Now, this is what I just alluded to. There also can be a skeletal-muscular deficiencies and emotional slowdown. All this has been mentioned, but the purpose of this slide is to think about the physician's role and approach to a aging and menopause approaching woman for preventive health, be it asymptomatic or symptomatic. We need to think of the preventive health for the future. Now, the main interest of this talk is diabetes and menopause, which is a twin challenge. What do we have? We have changes in blood sugar level because the hormones estrogen and progesterone affect the response to insulin. More the dysglycemia, higher the risk of diabetes complications. Now coming to the weight gain during the transition and after is very common. This may require an adjustment in diabetes medication. Infections, as I already said, urinary tract and vaginal infections are very common, and they're more common in people with diabetes. After menopause, when a drop in the estrogen makes it easier for the bacteria and yeast to thrive in the urinary tract and vagina, the risk is even higher. The sleep problems, like because of hot flashes and night sweats, may lead to sleep disturbances at night. In turn, the sleep deprivation can make it tougher for the woman to manage the blood sugar level. And as we already said, there are sexual problems. Diabetes can damage the nerves of the cells that line the vagina. This can interfere with arousal and orgasm. Vaginal dryness, a common symptom of menopause, may worsen the issue by causing pain during the sex. So what is the influence of menopause on the diabetes risk? The changes in the body composition, adverse changes in insulin sensitivity and glucose metabolism can occur. The hormone therapies that are given during the post-menopausal period, there's a neutral or beneficial effects on the adverse change in the body composition. Whether menopausal status independently influences diabetes risk remains controversial. Some evidence suggests that postmenopausal hormone therapy decreases the risk of developing diabetes mellitus. Postmenopausal hormone therapy has neutral or beneficial effects on glycemic control among women already diagnosed as having diabetes mellitus. There are very few studies which are done on type 2 diabetes and menopause. This is a multinational study with a background type 2 diabetes cases, causes metabolic changes that may lead to early menopause and worsen the climactic symptoms, that is menopausal symptoms. The objectives of this study was to determine the risk factors for diabetes and assess the impact of diabetes on the age of menopause and on climactic symptoms. 6,079 women were studied between age of 40 and 59 years. 11 Latin American countries were studied, requested to answer the menopause rating scale and Goldberg anxiety depression scale. So what was the conclusion? The menopause does not increase the risk of type 2 diabetes mellitus, but diabetes is associated with early menopause in women under the age of 45 years of age. Another study, Chinese study published in the Nutrition and Metabolism in February 22, 10-year prospective study. As you can see, 3,02,522 women between the age of 30 and 79 years across China were studied. And the period during which it was studied was 10.8 years. follow-up period, and incident diabetes cases, 11,459 incident diabetes cases were recorded without prior diabetes at the baseline. So findings were mean age of menopause was 48.2 years. Peri and postmenopausal women were higher at risk for diabetes. Now a little bit more on cardiovascular health in perimenopause, because most of our patients, what the risk that we can avoid is the cardiovascular risk for a for a woman who undergoes transitioning into menopause and thereafter cardiovascular health. So there is no strong relationship between the perimenopause and development of hypertension. Endothelial dysfunction, however, or decreased flow-mediated dilatation and high levels of aortic calcification may begin during the menopausal transition. Adverse changes in the lipid profile, as I already said, has been noticed. And then development of the metabolic syndrome, abdominal obesity, dyslipidemia, impaired glucose tolerance, and hypertension are the part of metabolic syndrome, and these may begin even before the menopause happens. It's a big challenge to our mental health and diabetes. Depression is the commonest mental health disorder that has been observed during the menopausal transition of a woman with diabetes. She may also have memory and concentration difficulty. Mood swings are very much pronounced, and women may feel happy 1 minute and prone to tears the next. Fluctuating hormones and their disruption of a woman's life are usually thought responsible for these mood swings. Insomnia and sleep disturbances can make mood swings feel worse. So what are the solutions to staying mentally fit through the menopause? Engage in mentally challenging activities like exercise, treat menopause symptoms, sometimes even with hormones, seek support, and think positively. Very difficult to tell, but this is what we need to tell our women patients. So coming to the physician's role in individualizing the treatment, first of all, as always the case is for all the patients, assessment of symptoms need to be done, physical examination, investigations, and then comes to the management. Healthy with no problems is one cohort of patients that we see. Healthy with significant risk factors, healthy with latent disease, and medically compromised women. So we need to, this is known to everybody, height, weight, BMI, blood pressure, waist circumference, waist hip ratio, neck adenopathy, thyroid, breast examination, abdominal examination, and pelvic examination. These are some of the benefits of physical activity. Physical activity, the type of exercises. Yesterday, Dr. Sabu had given a beautiful talk on exercise for women. And this was part of his talk. Just to recapitulate, it can be aerobic, weight bearing, and resistance, and they have to be combined in the week, during the week. So frequency of exercises, 30 minutes, 3 to 5 times a week, 40 to 60 minutes, 3 to 5 times a week, if has to reduce weight. If a lady has to reduce the weight, then it has to be done maybe every day. Intensity, nowadays we need to be cautious about telling the patient about the high intensity exercises should not be done. It should be mild to moderate intensity. 55% to 90% of maximal heart rate should be able to carry out the conversation during the exercise. So what are the tests that can be done? This also is known to everybody here, but I just want to narrate them here. Complete blood picture to rule out anemia, blood sugars and HbA1c, lipid profile, apolipoprotein B, serum calcium, serum electrolytes, ultrasound of pelvis, estradiol, FSH if need be. If a patient has severe vasomotor symptoms, this should be assessed to maybe treat the woman with estrogen if need be. Bone mineral density should be done if a woman complains of bone health. And then mammography at least once in 2 years has to be done to rule out any evidence of breast cancer. So I'd like to end my talk with this saying: the greatest mistake in the treatment of disease is that there are physicians for the body and physicians for the soul, although the two cannot be separated. Thank you very much for the patient listening.
Thank you so much, Dr. Lily. Now we move on to the next talk, and may I invite Dr. Dakshata to take over?
So can I have a CV of Dr. Keval Ramani? So for the next talk, Dr. Kanchan Keval Ramani, she is DNB Medicine and she's a consultant endocrinologist. She's attached to Jupiter and Bethany Hospital, Thane. And she's been awarded for DSL for her best paper presentation at ESICON 2007, gold medalist in DNB Medicine and Diploma Diabetology. And she's invited at many national conferences as an astute speaker. Areas of interest are diabetes, thyroid, adrenals, metabolic bone diseases, and the topic is very, very interesting. Over to you, Dr. Keval Ramani. Thank you so much.
At the onset, I would like to thank Dr. Benny for inviting me for this platform. And so I'll just share my slides in a minute. So are my slides visible?
Yes. Yes.
Okay. Fine. So for my topic is impact of anti-diabetic treatment on the bone. Do we need omissions? So I'll start with a brief case presentation. So this is a typical case which comes in our diabetes clinic where we see in and out. It's a 66-year-old lady, postmenopausal, with a history of diabetes for the last 9 years. She's been a hypertensive for 5 years. She does have a history of left forearm fracture 6 months ago. Her examination is unremarkable except for a lean BMI, where her BMI is around 19. She is poorly controlled with an HbA1c of 10.2. Her medications wise, she's on tablet metformin 500 milligrams twice a day, along with almost 8 milligrams of glimepiride and 30 milligrams of pioglitazone. She's taking telmisartan with hydrochloroside for her blood pressure, and she's on a Bicasol. So she's basically come to know for an advice whether insulin needs to be started, because most of the patients are very scared of insulin. So before they start insulin, they take multiple doctor shopping visits just to be, sure whether it's really required. So this is what my outline of talk would be like, where I'll be discussing about diabetes and bone health relationship, the mechanisms which contribute to fracture in these patients, and what are the factors which affect the fracture risk, followed by a detailed evaluation of individual drugs on the bone health. Now, like cardiovascular and renal complications in diabetes, there is an increase in the risk of fragility fractures being associated with both type 1 and type 2 diabetes. However, fracture should not be a surprise in patients with diabetes, because as we all know, patients with diabetes have a number of micro and macrovascular complications. They have problems in the vision, which may make them more prone to falls. They have long-standing diabetics have severe neuropathy where balance and coordination could be an issue. There could be dizziness making them more prone to fall because of the effect of both blood pressure lowering medications as well as autonomic neuropathy. Hyperglycemia per se also affects the bone. So there are a lot of studies which are associated with increase in the fracture risk in both type 1 and type 2 diabetes. And we have a lot of prospective, cross-sectional and meta-analysis which have repeatedly shown that there is an increased incidence of hip fractures as well as vertebral fractures in both type 1 and type 2 diabetes. So now what are the factors which really affect the fracture risk? Now, when we are talking about the fracture risk and the factors, the most important comes to our mind is the bone quality. When we say bone quality, what we are talking about is the structural quality of the bone, which involves the bone mineral quality, the bone mineral property, as the bone material property, as well as the bone biomechanical quality. The other important factor which we consider is the bone mineral density, and of course, frequent falls, which can happen in patients with type 2 diabetes because of various complications. So if we look at the definition of osteoporosis, it basically is defined as a condition characterized by low bone mass with microarchitectural deterioration, making the bone fragile and prone to fractures. So when we talk about bone mineral density, there are various studies in patients with type 1 diabetes which have shown that the BMD is on the lower side. Now, there have been research over the decades which has proven that insulin and IGF-1 have an anabolic effect on the bone. So basically, patients with type 1 diabetes who are insulinopenic, they usually have a decrease in the peak bone mass. There are various studies which have quoted the same. However, this is one study which was done at Nair Hospital with Dr. Amay Joshi, and Dr. Prema ma'am was also, of course, was there, where they looked at 86 consecutive type 1 diabetic patients and matched them with 140 age and sex matched with BMI controls. They did a DEXA scan along with other parameters like the celiac disease, the vitamin D levels, the cortisol, and the sex steroids. And they found that patients with type 1 diabetes definitely had a significantly lower BMD as compared to the controls. The factors which were associated with a low BMD in these patients were concomitant celiac disease, insulin deficiency, poor glycemic control. They had low levels of IGF-1 and BP3 levels. Vitamin D deficiency, which is very common, was again an associated factor. Also associated hypogonadism, renal failure, and early age of onset. So what are the mechanisms which lead to this poor bone mass and osteoporosis in type 1 diabetes? As we spoke, insulin deficiency is the main contributor which causes decrease in the osteoblast function as well as osteoclast activity. Also, chronic hyperglycemia leads to increase in the advanced glycation end product formation, which has an osteoclastic effect and decreases the osteoblast function. Per se, also, hyperglycemia has a direct effect on the osteoblast function. Also, apart from insulin, there is a myelin deficiency in type 1 patients, which contributes to the osteoblast dysfunction, along with other factors like malabsorption, calcium, vitamin D deficiency, and hypercalciuria. Unlike type 1, in type 2 also the risk factors are high for fracture risk, and the patients with type 2 have a paradoxical increase in the BMD as compared to the controls, to the tune of almost 5 to 10% higher BMD. This could be basically because of the insulin, hyperinsulinemia, which is commonly seen in patients with type 2, where they have an anabolic effect on the bone. So there are various studies which have shown increase in the BMD in patients with type 2 diabetes. This is one such study where they've looked at 29,407 women above 50 years of age from Manitoba, which had around 8.1% diabetics in them. And after adjustment for the age, BMI, and other risk factors, it was seen that patients with diabetes had a higher BMD value at the level of the spine, the hip, and the femoral neck, as compared to those without diabetes, thus clearly showing that BMD levels are high. One point I would like to mention: when BMD by DEXA is used to assess osteoporosis in women with diabetes, it usually does not correctly diagnose it, and it's a misnomer because these patients have a higher BMD. So the T-scores, as we all know, of less than -2.5 is used to define osteoporosis. But in patients with diabetes, the recommendation is that anything above, anything -2 and below should be considered osteoporotic and not -2.5. Also, if you look at this figure where they looked at the trabecular bone score. Now, trabecular bone score is basically an index of structural quality. It basically evaluates the pixel gray variations in a DEXA image, and it tells you about the microstructural alterations which happen at the cortical as well as the trabecular bone. A value of more than 1.32 is labeled as normal. So if you see in patients with diabetes, they have alterations at the microstructural level, thereby making them the bones more fragile. Now, when we talk about the structural quality, there are other modalities like the high resolution peripheral QCT and the MRI, which reveal the microstructural abnormalities. Basically, these modalities have shown in studies that diabetic bones have increase in the cortical porosity, thereby impairing the bone material properties of the bone. Also, there are other tests such as the tibial microindentation technique which Dr. Anjali spoke about yesterday, and even these are deranged, thereby showing that the bone mechanical quality is low in patients with diabetes. Now, coming to again the mechanisms in type 2 diabetes, chronic hyperglycemia basically causes an increase in the advanced glycation end products. These then bind to the receptors and lead to increase in the oxidative stress and create an inflammatory increase cytokines and increase in the inflammation. This in turn leads to an increase in the osteoclastic activity and decrease osteoblastic activity, thereby promoting increase in the bone resorption and decrease formation. Advanced glycation end products not only work at the cellular level, but also they alter the proteins like the collagen and the elastin in the matrix, and thereby they make these bones more brittle by losing their elasticity and making them less tough, and thus they are more prone to fractures because of increased fragility. Another important thing which is seen in type 2 diabetics is there is increase in the sclerostin. Now, what is sclerostin? It is an inhibitor of osteoblastogenesis, which is secreted by the osteocytes. So basically, the WNT pathway is a very important pathway for osteoblastogenesis. What WNT does is it promotes the mesenchymal stromal cells towards the osteoblastic lineage, and it also upregulates the osteoprotogerin and thereby inhibits osteoclastogenesis. So because of an increase in the sclerostin, this pathway is inhibited, thereby leading to increase in the bone resorption and decreased formation. So this is just a diagram which is talking about the common pathways in both type 1 and type 2 diabetes. Only the red pathway in type 2 diabetes, as we said, because of obesity and hyperinsulinemia, they have an increase in the BMD. Now, a good glycemic control can definitely improve the bone status, but there are a lot of papers which have come up which are speaking about the effects of these anti-diabetic therapies at the level of the bone, where they cause problems at the bone cell replication as well as the bone remodeling process. So in fact, in retrospective analysis, where they've looked at studies evaluating the risk factors for osteoporosis, they have looked at patients with concomitant medications for diabetes as a strong risk factor for osteoporosis. So when we are evaluating for the risk factors in a patient with osteoporosis, diabetes and the associated drugs should be taken into account. So we'll just speak about the drugs in detail. Now coming to metformin, which is the most commonly used drug not only in diabetes, but as we heard from Dr. Dakshita, in a variety of conditions. Now this drug has positive effects on the bone, and these are predominantly mediated by the AMPK pathway. It has also been demonstrated that metformin slows the effects of the advanced glycation end products, it thereby reducing the oxidative stress, and it increases the cell regenerative capacity. So if you look at this diagram, metformin basically has a direct effect where it inhibits the osteocyte apoptosis. It has a direct effect on the bones where it inhibits osteoclastogenesis. This is both by decreasing the Rankel and upgrading the osteoprotogerin. It also stimulates osteoblastogenesis by reducing by causing stroma cells towards the osteoblastogenic series and inhibiting adipogenesis. Thus, overall, it has increase in the bone formation and decrease in the resorption. When we talk about sulfonylureas, glyburide treatment has negligible effects on markers of the bone formation, the bone resorption, and the BMD in humans. And therefore, in most of these trials, sulfonylurea did not have an increase problems with the bones. But if falls are a prerequisite to fracture occurrence, it was not clear if and how the sulfonylureas increased the fracture risk, but the only possibility could be secondary to hypoglycemia or long-standing neuropathy in these diabetic patients. So far, their effect on the bone is neutral, but the increase in the fracture risk with these medications is probably because of associated hypoglycemia, but otherwise they are bone safe. Coming to glitazones, these are the most prominent form of pharmacotherapy which are linked to bone derangement and increased fracture risk. Though preclinical studies indicate that glitazones have a pro-adipogenic effect, they also have inhibition of the osteoblast differentiation via IGF-1 expression, and they stimulate the osteoclast dedifferentiation. So this is a beautiful diagram which explains it all. Now basically glitazones like pioglitazone, they are PPR gamma agonist. So it is basically the PPR agonist mechanism which works on the bones. It causes an increase in the osteocyte apoptosis and also an increase in the sclerostin, which we saw is a bone formation inhibitor. By inhibiting the WNT pathway, increased sclerostin inhibits the osteoblast genesis. Most importantly, patients who are on glitazones, they have an increase in the adipogenesis of the marrow, and this is because the glitazones stimulate the mesenchymal cells towards an adipocyte lineage and inhibit osteoblastogenesis, thereby having an increase in the bone marrow adipogenesis, and which has been shown in patients with type 2 diabetes with increased vertebral fractures. It also causes an increase in the osteoclastogenesis. Thus, together, these findings indicate that the glitazones decrease the bone formation and increase the resorption, thereby resulting in a reduction in the bone mass. Coming to incretins, there are three important incretin peptides like the glucagon-like 1 peptide GLP-1, the GLP-2, and the GIP. Now, these form two important ways of treating diabetes by using the DPP-4 inhibitors and by using GLP-1 agonist. Food intake elicits a reduction in the bone resorption through the incretin secretion. So patients, there have been studies where administration of GLP-1 agonist has resulted in decrease in the nocturnal bone resorption. Also, GIP has been demonstrated to attenuate the age-related bone loss of bone mineral density via a pre-osteoblast function. And overall, these drugs have shown to have neutral effects. In terms of fracture prevalence, they demonstrated no increase in the risk of fractures. So these are bone-safe drugs, and we can safely use them in patients with type 2 diabetes. DPP-4 inhibitors, again, have shown to demonstrate the osteoclast levels and activity, which in turn improves the bone morphology. Therefore, DPP-4 inhibition tips the scale in favor of bone anabolism through their mitigating effect on bone resorption. Also, they have been shown to attenuate the diabetes-related deficits in the bone microarchitecture, the cortical bone volume, and the strength. Thus, these drugs are bone safe, and we can use them safely in patients with diabetes. Coming to SGLT2 inhibitors and bone health. Now, there is ample of tier 1 evidence showing that these drugs reduce the cardiovascular and improve the renal outcomes. And this drug is now widely used in the treatment of diabetes. And it is not only used by diabetologists and endocrinologists, but also our cardiology and nephrology colleagues have been using it very widely. However, their promising effects have been undermined by their possible detrimental effects of the bone. The various mechanisms where these drugs have been shown to impact the risk of fractures is mostly bone independent. Basically, these SGLT2 inhibitors cause an increase in the resorption of phosphorus. This in turn increases the parathyroid hormone secretion, thereby increasing the bone resorption, and also it increases the urinary calcium excretion. So these are the three ways in which it improves the osteoclastogenic activity and bone resorption. In addition, these drugs cause significant weight loss, which in turn can reduce the BMD. Thirdly, because of the fat loss with these drugs, there is reduced in the aromatase activity, which is an important source of estradiol, and lack of estradiol thereby promotes osteoclastogenesis and thereby increasing the bone loss. Now, there are various studies which have also counteracted this effect, saying that the fracture risk which was observed in the older patients with impaired renal function and cardiovascular disease with these agents was basically independent of its direct effects on the bone, and they were more likely to be associated with the falls due to changes in the hydration status secondary to osmotic diuresis. So basically, they say that it is the extraskeletal rather than the direct effect of canna on the bone, which was assumed based on the fact that there are no SGLT2 receptors found either in the bone or bone marrow. Again, the canvas and bone fracture study did show us that they really didn't know what was the reason for increase in bone fractures, because they saw that the fractures were basically in the upper extremities in this study, while the bone mineral density changes were seen mostly at the hip bone. And also these fractures were seen within the first few weeks of started canna. So the timing and the location of the fractures, that is the upper extremity, along with the knowledge that canna is associated with volume depleted events, suggest that some of these fractures could have been resulted from falls because of osmotic diuresis and not because of the direct effect of canna on the bone. Again, followed by the canna, study, there were a number of studies which were done to prove that canagliflozin was bone safe. This was basically seen again in a review article where they looked at the bone effects of canagliflozin in patients with type 2 diabetes. And across the clinical studies, they found that cana was not associated with any meaningful changes in the urinary calcium, the vitamin D, or the parathyroid. Also, they found that the increase in the phosphate and magnesium was very minimal, which would not have caused any adverse effects. And the decrease in the total BMD was only at the hip level, even with doses of both 100 and 300, even after 2 years, but there was no other skeletal sites which showed any impairment of BMD. Again, when they looked at changes in the BMD with cana as compared to other weight loss interventions like behavioral modification, caloric restrictions, bariatric surgery, they found that the changes in the BMD were minimal as compared to other modalities of intervention, with bariatric surgery having the maximum one. So thereafter, there were a number of studies on the safety profile of cana, but I will not go through them because of shortage of time. I would, but as far as the SGLT2 inhibitor safety is concerned, in 2 different randomized double-blind placebo-controlled trials, dapagliflozin had shown neutral effects on the bone turnover and bone density. A post-hoc analysis from EMPA-REG also showed a neutral effect on the fracture risk. Data are less reassuring for canagliflozin, which has been associated with a higher bone loss, increasing the resorption and higher incidence of fractures compared to non-canagliflozin treatment. Therefore, the FDA in 2015 had put a red box warning on this drug to be used cautiously in patients with osteoporosis. As far as insulin is concerned, as we saw, patients with type 1 diabetes have a reduction in the peak bone mass, suggesting that insulin has potential anabolic effects. It has a direct effect on the bone metabolism, and changes in the bone markers are seen within hours of administration. So those studies have shown that patients treated with insulin have an increased risk of fracture, but this could basically be explained by the higher risk of hypoglycemic events, and most of the patients who are on insulin have a longer duration of diabetes and increased diabetes-related complications. So insulin per se is unlikely to be having any effects of the bone. The effects are secondary to hypoglycemia and other complications. So this is just in a nutshell talking about the safety of biguanides, DPP4 inhibitors, and incretins on the bone, and insulin, glitazones, and sodium glucose inhibitors should be used with caution. So when I come back to my case, if you look at this patient, she has all the risk factors for osteoporosis. She's 66 years. She has a long-standing diabetes, poorly uncontrolled, with a past history of fracture. So in this patient, she definitely has osteoporosis. So we definitely need to omit the drugs like pioglitazone in her, and even glimepiride high doses, because she's already on 8 milligrams. She needs a tighter control where DPP4s can be used and insulin should be used for a better glycemic control. However, we should not aim at a very high target. 7.5 should be good enough for her. Calcium and vitamin D should be supplemented, and she should be started on bisphosphonates. This is just an outline of the management where they talk about the drugs to be preferred in patients are metformin, DPP4 and GLP-1 receptor agonists, and glitazones and SGLT2s have to be avoided. In addition, blood pressure, vision, and neuropathy should be taken care of. Fall prevention is very important in these patients because of neuropathy and weak bones. Bisphosphonates is the drug of choice, and monitoring should continue. So to summarize, both type 1 and type 2 diabetes are risk factors for osteoporosis and fractures. Osteoporosis should be viewed as another complication of diabetes. The aerial BMD is lower in type 1 and normal or higher in type 2 diabetes. Bone quality is definitely compromised in type 2 diabetic patients, and advanced glycation end products are implicated in the brittleness. And when agents which interfere with the bone health should be chosen with caution and after evaluating the patient. And from a bone perspective, metformin, DPP4 inhibitors, and GLP-1 agonist-based therapies are safer than glitazones, sulfonylureas, or SGLT2 inhibitors. Thank you.
Thank you so much, Dr. Kanchan Kevalramani. I would request Dr. Dhruvi Hasnani to take forward the session.
Thank you so much, ma'am. It was a wonderful, wonderful session and two very great talks by Dr. Lily ma'am and Dr. Kanchan ma'am. We move forward to the last talk of our session, Fresh Look by Dr. Kirti Samudra ma'am. She's a practicing physician and a diabetologist and has more than 30 years of practicing experience, more than 25,000 of registered patients, and she regularly conducts education program for patients as well as for general practitioners. She's a faculty for the PHFI and the NDEF, and she has been a speaker for a lot of regional and national conferences. Thank you so much, Kirti ma'am, for accepting our invitation for our 6th Wodcon.
Thank you. Thank you for this introduction. And I thank Benny madam and Vijay sir for giving me this opportunity, and team Wodcon also. And I hope next year we will meet at the conference physically. So I'll just share my screen. Is it visible?
Yes, ma'am, it's visible. You'll just, on slideshow mode. Yes,
yeah, okay.
Yes, yes.
Okay, so this is a kind of extension what Dr. Lily spoke. I keep forgetting things. Is it the brain or hormones? And I think most of us who are now senior ladies here have gone through this, or we are still going through this. And it's beware situation for all you younger generation that you should do something for this now onwards only. So we are all familiar with the cultural stereotypes about women, moods, and hormones. They look something like this, because women has to go through puberty, pregnancy, and menopause, and everything can be blamed on hormones. So it is important for us to recognize the realities that women face struggles that arise from dramatic changes in the hormone levels and all the chemistry of these hormones. All jokes aside, the mental state of women has a domino effect that impacts not only women, but their families as well. Surprisingly, science still overlooks the differences between men and women. Studies are conducted on men and not on women mostly, and psychiatrists often overlook the biological impact on mental disorders. So what are the effects of hormones actually on or menopause and memory? According to the Dementia India Report 2010 by the Alzheimer's and Related Disorders of India, ARDSI, there were around 3.7 million Indians with dementia in 2010, and which was projected to rise to 7.6 million by 2030, and 2/3 will be women. So it's a huge burden, and all the women are going to face this. Women are at the epicenter of this because the economic threat is especially dire for women, given they are an increasingly powerful element of our global economy, and everybody will accept this. And the vast majority of unpaid caregivers are women. Thus, maintaining intact memories starting early in midlife with the transition to menopause is critical not only for women themselves, but also for their families, societies, and economic health of the nation. In addition to chronological aging, women undergo reproductive aging, during which they experience a depletion of over time of ovarian hormones and estradiol, the primary form of estrogen that works in the brain. Many studies have demonstrated that estradiol directly relates to changes in memory performance and recognition of our brain circuitry that regulates memory function. This is essential because viewing brain aging as beginning in early midlife and understanding the impact of menopause on the brain will allow for development of strategies to prevent memory loss for women. So on average, women perform better than men on measures of verbal memory, beginning as early as post-puberty. This is also a very good advantage that women have because of their good hormones. But however, women's advantage for verbal memory performance is reduced with menopause. Many women report increased forgetfulness and brain fog during the menopausal transition, and all women eventually undergo menopause. Though we have seen, Dr. Lily has shown us a wide range when women can develop menopause, especially from late 40s to early 60s. So what are the effects of female hormones on brain? First, estrogen and the brain. Estrogen is a major player in mood, memory, and cognitive skills. Estrogen relates to serotonin and is found to be protective against depression in women. Today's topic, basically memory. Estrogen promotes nerve cells that contain acetylcholine, which is related to memory function. Studies have shown a heightened ability to perform on verbal and visuospatial tasks during times of high estrogen. And estrogen receptors have been found in the prefrontal cortex, hippocampus, thalamus, and the brainstem. There are also progesterone receptors in the prefrontal cortex, hippocampus, thalamus, and brainstem. But progesterone reduces the number of available estrogen receptors, so it can increase depression. And progesterone is a part of cyclical changes in women's life that contribute to depression. DHEA has been shown to have a regulating effect on the brain and on mood, and DHEA increases levels of serotonin, the brain contributing to its antidepressant effect. There is a connection between estrogen and serotonin. Serotonin is made from tryptophan, a basic protein building block. Serotonin is a neurotransmitter. Its functions include expression of mood, anxiety, memory, movement, stress, and regulation of menstrual cycle. When serotonin is low, symptoms include sleep disturbances, agitation, worry, lethargy, and hopelessness. Estrogen increases the density of serotonin receptors and transporter sites in the forebrain. What happens in menopause? Dr. Lily has already shown this. So this is the definition. She has already shown this, so I'm not going through this. And symptoms also she has given us. Only thing, the last one we see, that is memory problems. For many women going through menopause, memory lapses can be the most concerning symptoms, and they can lead women to believe their minds are receding into a fog of mental illness. One study found that women going through menopause are 95% more likely to experience memory lapses than women who have not yet reached menopause. And memory lapses are sometimes called brain freezes. When trying to remember names, dates, addresses, or other similar information, this can happen even when information has just been heard. And this happens, and we have experienced this many times. Talking about memory, there are different types of memory like short-term, recent, long-term, declarative memory, procedural memory. So short-term memory is the ability to remember information for brief moments, such as a telephone number for the time it takes to dial it. Recent memory is the ability to recall day-to-day events involved in learning new information. Sensory memory, the ability to recognize smells, sounds, sights. Long-term memory, also known as remote memory, concerns itself with the more distant past. Declarative memory is the ability to remember the meaning of words, facts, and the generalized knowledge of the world. And procedural memory, the ability to remember motor skills, knowing how to do things such as how to walk, ride a bike, and eat. The reproductive senescence, menopausal transition, the ovary failure is associated with release of extracellular vesicles containing inflammasomes, which may be responsible for low-grade systemic inflammation. So everything of this can be actually explained on the basis of inflammation, and the low-grade inflammation may compromise the blood-brain barrier, making the brain more susceptible to inflammation and neurodegenerative disease. 1 in 5 women develop AD in the 7th decade of life. Late onset Alzheimer's is the most common form of dementia, and 2/3 of late onset Alzheimer's disease patients are women. The higher longevity is one of the explanations for the late onset AD in women. However, increasing evidence suggests that longevity alone is not the only explanation, and there may be other underlying mechanisms. Some studies were carried out to find out the mechanisms, like brain imaging studies, multimodality, perimenopause and emergence of an Alzheimer's bioenergetic phenotype in the brain and periphery. And this multimodality brain image study and in the postmenopausal women versus age and educated match men were studied. And these studies indicate that as women go through menopause, multiple imaging findings indicate of endophenotype emerge, including reduced brain glucose metabolism in frontal cortex, increased amyloid beta accumulation, and gray matter and white matter loss. The patterns of brain hypometabolism correlated with measured reduction in the platelet mitochondrial cytochrome oxidase activity, which suggests that emergence of AD-like bioenergetic deficits in peri and postmenopausal women. Further studies indicate that systemic inflammation and estrogen decline associated with perimenopause can contribute to accumulation of this amyloid beta. Direct effect of E2 on neuronal amyloid beta have been demonstrated, showing that E2 decreases the generation and secretion of A beta in primary neuronal culture, and the administration of estrogen in estrogen-deprived mice reverse the elevated levels of this brain amyloid beta. Another study on cognitive changes during the menopausal transition, though this was carried out in women with HIV, though we are not concerned with HIV, but this was basically for cognitive changes during menopausal transition. And this was a longitudinal study carried out in the women with HIV. About 443 women from the Women's Integrity HIV study completed tests of verbal learning and memory, attention, working memory, processing speed, verbal fluency, motor skills, and executive function, first at an index premenopausal visit and thereafter once every 2 years up to 6 visits. And adjusting for age and relevant covariates, the overall sample of women with HIV showed longitudinal declines in the continuous measures of learning, memory, and attention working memory domains from the premenopause to the early perimenopause and from the premenopause to the postmenopause. So effects on those same domains were also evident in categorical scores of cognitive impairment. The increase in predicted probability of impairment by menopausal stage percentage affected ranged from 4 to 13%. Concluding, menopause stage was a key determination of cognition in a sample of low-income women with color, including women with HIV. Many of these changes reached a clinically significant level of cognitive impairment. So, what are the questions now to resolve? The main important question is, could anything be done? And yes, we can do many things. What would be the options and how safe are they? Because when we talk about hormone replacement therapy, always there is a question. So we should look forward to maintaining the quality of life. And there are options, like some natural options, like live a healthy lifestyle, enhance and accept what nature has given you. Alternatively, use supplements, vitamins, naturopathic and homeopathic remedies, or go for medical treatment, like treat specific symptoms or problems with medications as they arise, or go for hormone replacement therapy. So replace the original substance that is missing, like we treat our hypothyroid patient by replacing the thyroid hormone. So when here is again the hormone deficiency, so why not replace it? Dr. Lily has shown before anything to be decided for especially hormone replacement therapy, we have to evaluate the patient prior to the treatment. So detailed personal and family history, physical examination, including height, weight, BP, breast examination, evaluation of symptoms, need for the medication, evaluation of individual risk versus benefit from the treatment, routine screening, and lipid profile and CV risk assessment must be done. TBS and assessment of endometrial thickness, routine mammography, assessment of BMD, DEXA, and endometrial biopsy in postmenopausal bleeding. So medical treatments begin after a problem develops. Traditionally, this is what most of us choose. We seem to assume that disease is inevitable. Eventually, we all will get it, and we have to accept it. And this refers to specific drug therapies to treat conditions or disease states as they arise or even before that. HRT, it improves vasomotor stability, reducing hot flashes, helps maintain elasticity of skin and tissues, improves sleep patterns, decreases fatigue, increases sense of well-being, better recall, memory, problem solving. But we have many other health issues when we talk about HRT, like cardiovascular risk, insomnia, osteoporosis, ovarian cancer, colon cancer, diabetes, endometrial cancer, breast cancer, dementia, clotting, deep vein thrombosis, stroke, macular degeneration, arthritis. So we have to weigh the risk and benefit ratio. In ladies who have recently attained menopause, and if there are no symptoms, it's great not to have symptoms. Still, you face the decline in health associated with the loss of estrogen. This is a group of patients that's harder to convince. Patient doesn't have symptoms, so she doesn't feel bad. They don't feel the slow loss of calcium in the bones until it's too late. Consider HRT to prevent some of the long-term effects of chronic estrogen deficiency. Again, weighing the benefits. There are many studies carried out in women giving HRT or with some other methods like mind-body medicine. So lifestyle changes and personal habits, exercise, it was all well, importance was documented, and everybody has stressed upon this. Physical workout, yoga and meditation, breathing exercises, simple diet, plenty of vegetables, fruits, decrease fat and sugar, plenty of fluids to maintain hydration, control or abstain from smoking, alcohol intake, more tea and coffee. So mind-body medicine is very important, and we should try and inculcate the habits, good habits in ourselves. Overall, these findings indicate that menopause stage is an important determinant of cognitive performance. It is likely that cognitive deficits are not solely caused by declines in the estrogen production, but are also likely to stem from reduction in the sleep quality, increased depression levels, and the onset of hot flashes. Mind-body interventions may hold promise for treating cognitive declines associated with the menopausal transition. These therapies may be used alone or in combination with hormone therapy, depending on the preferences of the patient and her medical provider. So don't forget, just stay inspired. It's just a phase, but many women fear the word menopause, so I prefer to call it puberty part 2. Thank you.
Thank you. Thank you very much, Dr. Kirti. And I love the last part, puberty part 2. I think it's more reassuring than menopause. Thank you so much. And due to the paucity of time, we are going to the next session and the last session of the conference. So the last session has to be the dessert, because without dessert, picture abhi baki hai, meal is still left. So I would like to invite my co-chair, Ms. Cheryl Salis. Cheryl, are you there?
Yeah, I'm here.
Yeah, Cheryl, you can begin with the introduction.
All right. So good evening, everybody. I think we've had sumptuous starters and really hearty meals, and now over to the delicious desserts. And we have some great eminent panelists with us, as well as, so can I have the CV slides, please, of Dr. Kavita Gupta? Dr. Kavita Gupta is a very, very dear friend. She's the director and head of Department of Dietetics, Sunil's Diabetes Care and Research Center. She's the honorary secretary, Indian Dietetic Association, Nagpur chapter. She's a joint secretary, Association of Diabetes Educators, and she's also won several awards, and she's doing phenomenal work in the area of diabetes education, and she's been doing it for so many years now. So welcome, Dr. Kavita Gupta. Can we have the next series slide? Now we have Miss Ruby Sound, and again, a very, very dear friend. She's the founder of Eat Wise Nutrition and Wellness Clinic. She's a dietitian at Sangeeta Maternity Hospital. She's a secretary of the IDA Mumbai chapter, a managing committee member of the PCOS Society of India, and again doing phenomenal work in the area of nutrition and in with the nutrition community as a part of IDA. So welcome, Ruby. Welcome, Nazneen, again a very, very dear friend doing phenomenal work in the area of nutrition. She's the founder director, Freedom Wellness Management. She's the ex-president of IDA Mumbai chapter, and we've had a great IdeaCon under her leadership. She's the NEC committee member of Indian Dietetic Association. She's a nutritional advisor, and she's doing phenomenal work over there at the Indian Navy INS Hamla. And that makes us all very, very proud. She's a chief dietitian, Yoga Institute, Santa Cruz, and again, part of various associations and doing wonderful work in the area of nutrition. So welcome, Nazneen. And now over to you, Shilpa.
Thank you so much, Cheryl. We welcome Niti. She is a consultant nutritionist who practices in South Mumbai. She was attached to Kambala Hill Hospital for the last 17 years, and she's secretary and master trainer, Association of Diabetes Educators. Welcome, Niti. Next slide, please. We welcome Dr. Meenakshi Bajaj, again registered dietitian with 29 years of experience in clinical and therapeutic nutrition, certified bariatric critical care nutritionist, certified diabetes educator, and nutrigenomic consultant. She is SPEN LLL certified renal onco, obesity, diabetes, metabolic syndrome, enteral, parenteral, pulmonary, pancreatic, liver disease, and sports nutrition specialist. So she has a long CV here, and I'm going to end it here, but you can go through the whole thing. Next slide, please. And we also invite Ms. Priyagi Lahiri. She is RD, MSc, CDE. She has 12 years of experience and has been trained and worked at leading hospitals and healthcare companies. She is presently attached as a consultant dietitian with Care Continuum Private Limited and NG Medicare and Calcutta Hope Infertility Clinic. Welcome, Priyagi. Kavita and Ruby, you can begin the session.
Thank you so much, Shilpa and Cheryl. And at the outset, let me again thank you, Dr. Benny Neglur ma'am and Dr. Neglur sir, for the wonderful opportunity, and welcome you one and with that, I would like to welcome one and all to the last but the sweetest part of this academic feast of Wodcon, and that's the dessert. And I would be just sharing my slides. Yes, and hope that's...
The slides are visible and you are audible.
Yes. Okay. Just a minute. So, okay. So yes. So in fact, this was a very important topic, like given to us. A topic which is not well spoken about or not learned much about. In fact, I was highly impressed and surprised to know that we are unknowingly consuming a small shot of glass of oil when we consume a packet full of chips. And so, and you know, when I was watching Shark Tank last week, and so whenever we talk about packaged foods, I think our health it goes out of room. And the talk today is going to, you know, it's our quest to lead to the healthier alternatives to quench our hunger, you know, for searching for the healthier options. So this was a case of a young girl. In fact, me and Ruby are going to, you know, have a nice conversation about this, about a very important topic, that is, are we reading food labels? And this happened, you know, this topic actually clicked to us. You know, last week there was a young girl of PCOS who just came to me, and then she asked that she was right in front of the super bazaar, and she had so many things right in front of her which were labeled as organic, 100% natural. And then she just called me, okay, what is all this about? How am I supposed to read all this and understand all this? So there it came, you know, the idea of, yes, that we need to create more awareness about reading food labels. And I think most of us, whenever a packet comes to in, you know, whenever we get a packet of food in our hand, we usually just bother to read the date of manufacture or the best before or used by date. You know, we hardly use, or we hardly read the list of the ingredients which is there, or we don't even bother to read the nutritional information which is mentioned on that. So with that, I would just like to focus on a small nutrition information here on this slide. So first, what we need to understand is the serving size. Every packet, wherever there is a food label, there is a packet, the serving size. So we need to understand how much amount of what is the serving size of that particular food, and which mentions the amount of calories in that per serving. So if you are going to take extra serving, so naturally you're going to increase on the amount of the calories. And here we can also compare the amount of the calories per 100 grams. In fact, per 100 grams is a useful standard, you know, to compare the products, and you can also understand whether it is a healthier option or not. And let me tell you that every product will have a different serving size. Now, what we need to focus here is the amount of the carbs, that is the sugar. You know, whether we should aim that, you know, the sugar should be less than 15 grams in 100 grams, you know. So if the food is of 100 grams, the sugar should be less than 15 grams. So if it is less than 15 grams, it is a healthier option. Similarly, for the fat, we should aim for 3 grams per 100 grams or less. When we are looking at the fiber content, we should see that the fiber content is at least 7.5 grams per 100 grams, or at least 3 grams per serving size. So we can either look at the serving size, or we can look at the 100 grams, you know, of the product. Similarly, if we are looking at the sodium, especially for the patients who are hypertensive, or even the patients who are with kidney diseases, we should aim that the sodium content should be around 120 milligrams per 100 grams, or even less than that. So these are the micro and the macronutrients which I think we need to ask our patients to always read whenever they are going to read, whenever they're going to pick up some food or product from the shelf. So Ruby, could you just focus or make us understand about the percent daily value this is what we have been actually seeing in most of our the food labels. Over to Ruby. Okay, so I think she has some network connectivity. She would join whenever she's there. So here I would just like to focus that here we have two labels, which again emphasizes that it shows, now the nutrition labels have been, the serving size has been mentioned, the calories have been written in bold, so that, whoever picks up the packet understands how much calories per serving it contains. So the percent daily value is basically it tells us that how much nutrient is there in a serving of a food, which contributes to around a 200,000 calorie intake. Well, I mean to say, if a serving size of a food or a beverage which contributes to around 2,000 kilocalories, you can understand that the total fat content is around 10%, or the saturated fat is around 5%, and the carbohydrate content is 13%. So that is also an easy way to understand what is the macro or the micronutrient content of that particular food is. And we also have the dual columns, which would let you know how much amount of calories does it contain, or we also have the grams. The gram is also there, which also would help us to understand how much amount of grams the total fat content of that particular product is there. So here we can see that the total fat is around 10 grams, the cholesterol is 30 milligrams, and then the sodium content is really very high. And even the carbs we can see is 70%. Here in the carbohydrate sections, we should also emphasize on seeing the dietary fiber content and the included added sugars. So here, if we see the added sugar in this is around 4 grams in that particular product. So, so whenever we are talking about the daily value, the percentage daily value, the rule of 5:20 is always easy to understand. We need to aim for 5% of the daily value or less in fats and sodium, and aim for 20% of daily value or higher when we are looking on fiber or vitamins or minerals. So Ruby, are you there? Okay, so
sorry to interrupt. Ruby ma'am, try to remove your earphone or something. Yeah. Maybe there is a problem in her microphone.
Okay. So I think Ruby, whenever you get a good network,
am I audible, Dr. Kavita?
Yes, sure. Yes, please go ahead.
Okay. I'm sorry I couldn't join earlier, but I thank Dr. Kavita for discussing some critical points before I could discuss. Well, as you rightly said, there is a huge difference in the serving size and the number of servings that you've already explained. What is very, very important is for a lay person to understand the different names which are used to identify fat or sugar or salt. Because if you read a label, it says low sugar, no sugar, but may only see certain keywords. But it's important to read some hidden terms. If we talk about saturated fats, many a times it may not be mentioned very clearly. It could be the butter, it could be coconut oil, it could be a hydrogenated oil. So it's very important to read these terminologies. When it comes to sugar, it may not be sugar always. It could be, fructose, lactose, mannose. It could be xylitol and other sugars. Especially when consumers get very confused whether palm sugar or coconut sugar is that a better option than sugar, because we know sugars could be complex as well as simple. So only reading the word sugar may not be enough. It's important to identify what is the type of sugar present in it. Similar with salt, especially those who have renal issues may need not avoid foods containing salt. They also need to look at other ingredients like MSG, that's monosodium glutamate, or even rock salt, because there's huge confusion in the type of salt that they can consume. So not only the amount, like she said earlier, the daily value or the per serving value, it is also the type of salt or sugar or the saturated fat present in it. So identifying these is very, very important while reading any nutrition label. Next slide, Dr. Kavita. This slide actually talks about different carbs as I mentioned. So when you look at a new label, it may say that the X number of carbs are present. For example, this is a packet which says that there is about 68 grams of sugar present per 100 gram, but per serving, which is about 40 grams, there is about 27 grams of carbohydrate. What is very critical for anybody with diabetes is to understand how much of sugar is present. This product label, which is shown here, has 0 amount of sugar, but high amount of dietary fiber, which is also very specifically mentioned that how much of soluble and insoluble fiber is present in this. So it's critical to identify that source also. And similarly, when it comes to protein, how will you identify what is the amount of protein and the protein type or the source is by reading the nutrition label. For example, this product, which has about 7 grams of protein, is a protein-based food product because that's the first ingredient mentioned on the nutrition label. And it very clearly says that's a whey protein isolate and a casein. So it's a blended protein, which is this product. So nutrition label is not only about the amount, but also the source of the particular nutrient. Similarly with that, for a specific type of fat, you can read the nutrition label to understand whether it is rich in mu-fats, whether it is rich in pu-fats, or it is high in trans fat or saturated fats. And we know which ones to avoid and which ones to include. But this information is very important to identify which is a healthier option than the other one. And it's also very important that you pick up 2 food products, read their 100 grams content, and then compare before you choose a particular product. That makes very easy for choosing the healthier versus a non-healthier food product. It need not be always a processed food like a packet of chips. It could also be a regular packet or tetra pack of milk that you need to choose which one is a low fat, which one is a moderate fat, which is a high fat. Next slide, please.
Yes, so wonderful. I think that should be of a great use for people with diabetes.
Yes, correct. Similarly, when we see there are too many ingredients written in it, the simplest way is to understand which are the first 3 products which are mentioned on this ingredient. The maximum part is the ingredient which is first mentioned is the one which is maximum in that given product. For example, in the label which is on the left hand side, it contains mainly refined wheat flour and sugar and palm oil. Because what happens is sometimes the consumer or the patient reads that okay, it has cocoa solids, milk solids, so is it a good product? But they must understand that the first 3 products are most important to identify whether this product is suitable or not. Similarly, on the right hand side, though it is 54% of flour, the first ingredient is wheat flour. So that could be a better choice over the one on the left hand side. So reading in a sequence also helps in choosing the right product. Next slide, Dr. Kavita.
Yes. So, yes. Yes, Ruby, go ahead.
Like other things which are very important to identify, there are certain, things which one has to avoid, especially allergens. And so far we know about 8 allergens. Those who have allergies or food intolerances would avoid foods containing either peanuts, tree nuts, soybeans, shellfish, fish, eggs. But very recently there has been an act which is passed, and from 2023 January 1st, even sesame is going to be included as one of the major allergens. It's very important for people to also read if there's any allergen given in the food product.
So
Next
yes,
slide.
yes.
Kavita, you could talk about claims to our given audience.
Yes, yes, because nutrition claims are actually very important for what they usually claim on the food labels, and they usually get misled. This I have usually seen with our people with diabetes. The moment they see light or like, so they really get carried away. So here also we need to make them understand that please read food labels before picking up a food. So it's not always important that no cholesterol or a low cholesterol can be cholesterol free. There even baked baked or fried. So all these may sound healthy, but at the end of the day, when you read the food label, you will you may understand that the amount of the fat which is there is really high. Similarly, it goes for the organic foods also. It's not necessarily, the organic foods have they are less in calories or proteins. They also have the similar amount of macronutrients. So reading on not getting carried away with these claims are very, very important. So I think finally we both would like to summarize that we need to make the best use with the label reading, because like when we are choosing the foods, it would help us to choose foods with our nutrient dense, which is a food which we want to take more. So we would like to emphasize that we need to read well, think smart, and consume healthy. So that is what I'm not going again. We need to recognize the serving size, think calories, read nutrients, understand the footnote. And finally, we need to choose the healthier foods and the beverages that can help and reduce the risk of non-communicable diseases. So thank you. Thank you very much. Wodcon 2022. Thank you very much.
I hope this presentation has helped a lot of us and our patients to choose the best and the healthier food options. And that is very true for not only food products that we have consumed daily, but also certain foods that we take sometimes or for some particular reason. And that is very, very true and very critical to understand when it comes to supplements. Now, food supplements is a space which has a lot of confusion, and a wrong choice can be lead to a very bad health consequences. And that is especially when those people who go to the gym have to pick up over-the-counter supplements. They look at a supplement box and they see it's good for weight loss, bodybuilding, protein supplement, but only a nutrition label reading will help them guide, pick up the best one. So in fact, I think I would take this discussion further and ask one of the eminent panelists, Ms. Nazin Hussain, that when we talk of protein supplement, the first question is, before label reading, is should anyone start taking supplements when they start giving? Is that the right thing to do, Nazin?
Okay, thank you, Ruby, for that question, and thank you, Dr. Neglu, Dr. Benny, for having us here. I think it's a fabulous treat, and dessert is the perfect ending. So, to go with your question, Ruby, at the onset, a simple answer is no. When one begins a gym workout, you don't really require a protein supplement if your diet is enough. If you're eating your 0.8 grams of proteins per day, you do not require any supplement. However, but us as Indians have been sarcopenic Indians, our protein is much lesser, and so the first thing we do is step up protein at every meal and make sure that there are enough portions of protein, at least 20 grams per meal. Also concentrate on spreading it through the day. So research shows that definitely don't concentrate it in one meal, spread it over breakfast, lunch, dinner. Even more better if we put it as in between meals. Even a simple bowl of yogurt or dahi can almost reduce the cravings and reduce calorie consumption up to 100 to 200 calories lesser. But however, if all this due to a busy lifestyle somebody is not able to accomplish, one could look at protein supplements. Today, the market of protein supplements is a really, really huge one, and we have both plant-based and animal-based protein supplements. So we have the whey, casein, and the egg albumin, all very high in the PDCAAS value and all known to be very superior. They come in different forms like the concentrate, hydrolysate, and isolates. Now, depending on at what level of workout you are, one can include these supplements with the help of a qualified dietitian. In the space of plant protein, a tremendous research, very, very exciting research. So we have soya, we have pea proteins, which comes with fiber. We have hemp protein, which is low in protein but also high in omega-3 fatty acids. So a lot of bucket of choice over there. However, matching and careful planning of protein over there is a very important one. Now, when, like you and Kavita rightly said, that creating awareness on label is very important, because even when the Indian Olympic Council looked at all these supplements, almost 80% of them came in the banned form because a lot of adulterated substances were used. So look for certification, adulteration. So these are very important points. Now, especially, is there a window of opportunity? Like we heard this time, there's a particular point of having protein. So earlier studies said that you can have protein from 15 minutes to 60 minutes of a workout. However, today, more and more research shows that you can have proteins even 2 hours after the workout, and that can be a good form. So what are the immediate direct protein benefits? Is it helps in muscle gain, it helps in appetite control, greater satiety, lesser cravings, better immunity, better bone health. We see direct raise in metabolism, and we see a whole lot of reduction of the hunger hormone, ghrelin, increase in of appetite hormones like glucagon peptide, YY peptide, and cholecystokine. So very, very exciting work there. And also special work is done on leucine today, and leucine is a branch chain amino acid which has shown some tremendous results, especially in reducing the fatigue, recovery, and muscle gain, and also reducing liver damage. So that's my 2 bits about protein supplements. And it's interesting because we're doing this session as desserts, and proteins are inversely proportional to desserts. So whilst that is a challenge, I think it's also an opportunity for us that we look and innovate desserts which are more protein based. And how much is too much? So even for the highest level of athletes, never go beyond 2.4 grams per kg body weight. Yeah. So thank you so much for that, Ruby.
Yes, that's a very important carry home message, Nazneen. So now moving ahead to another case of PCOS, and now there are many cases, the young girls who are actually facing the PCOS problem, and we all know that it is a state of insulin resistance. So, and with a number of issues like the acne, hirsutism, and irregular menses. So, Neeti, how would you plan a diet for a lean PCOS? A woman whose BMI is normal 22 and she regularly goes for gymming, and what are the type of the interventions you would like to do, dietary modifications you would like to do to reduce her inflammation? And what is the type how would you actually go about it?
Right. Thank you, Kavita, for that question. I would like to thank Dr. Benny and Dr. Neglu for having us here for this delectable session on desserts. PCOS is generally kind of, is associated with obesity. Most of the times we see obese PCOS patients, but now we do see a smaller percentage, but we do see a lot of lean PCOS also. When we say lean or obese, we are using the BMI as the criteria. Very often we will find that from the BMI point of view, they might be lean, but if we check their visceral fat, if we do their body measurements, then you will find that the visceral fat may still be high, which is kind of quite common. So they may be lean, but we will have to work towards reducing the visceral fat, which we know is basically absolutely related to insulin resistance, hyperinsulinemia, which is a cardinal feature of PCOS. So this would involve changing the macronutrient composition of the diet, having a look at that. If the diet is high in carbohydrates, which as Nazneen mentioned, we Indians are basically a carb-rich country. We just eat a lot of carbs. So that tweaking will have to be done. We'll have to perhaps cut down, reduce her carbohydrate intake, replace it with some good quality protein, which again, we are not meeting our basic requirements of 0.8 grams per kg body weight. So that would be the first step when talking about carbs and protein. Cut down on refined carbs, simple sugars, get in the complex carbs, which itself will reduce the insulin resistance. Thirdly, talking about fats, we need to look at saturated fats and trans fats. These are pro-inflammatory. So since PCOS is a state of chronic low-grade inflammation, we need to replace these fats with good PUFAs, like including nuts, seeds, and omega-3 rich sources, food sources. Vitamin D seems to be very, very important for PCOS from many different points of view, as a modulator of insulin resistance, as an anti-inflammatory. So make sure that the vitamin D levels are optimum for the patient. Physical activity, too important again, for works through various different mechanisms. So physical activity will have to be brought in. Look at endocrine disruptors. So this is something that we, especially in lean PCOD, because if a lot of them are healthy, they are eating all right, and one wonders where this is coming from. So we need to ask them if they're storing their food in plastic containers, they are heating up the cling films in microwaves while heating the food. The endocrine disruptors need to be out of the diet. So it basically would involve a macronutrient composition change, looking at micronutrients and these other few components such as physical activity and endocrine disruptors.
Yes, very important points you have brought out, Neeti. So over to Ruby. So I think again
Ruby, no sound.
Okay, so so moving ahead, from PCOS, now moving ahead to patients who have hyperuricemia, and we have actually seen a lot of patients who are obese, who have renal diseases, who have high alcohol intake. They may have problems of hyperuricemia. So can Meenakshi, could you lay some good thoughts of yours for dietary intervention in hyperuricemia?
At the outset,
and basically, in fact, in hyperuricemia, we have always seen, we always seen that you stop all the protein containing foods. So what would you like to focus on?
At the outset, I'm truly grateful to Negalur ma'am and Dr. Negalur sir and his entire team, Dr. Chawla, all of us, for giving me the opportunity to be participating in the desert. It's lovely to be part of the desert. But definitely, it's an important thought to be kept on hyperuricemia. But before I move on to hyperuricemia, I would want to congratulate both Dr. Kavita and Ruby Sound for an excellent presentation on nutrition labeling. And in continuation to that, before I move on to answering your question, I would want to say that also look for high corn fructose syrup in your nutrition labels, because that also is a major culprit when it comes to hyperuricemia. The reason being that there is decreased excretion of uric acid and increased production of purines. Also, there is a degradation of purine nucleotides when it comes to high corn fructose syrup. Now, that's the take home which I wanted to add on to your nutrition labeling. The second thing is, when we talk of hyperuricemia, we've always had the concept that tissue proteins or endosperm rich foods are the ones which are going to be a good source of purine, and if your uric acid is not excreted, you're going to be troubled with gout. But we need to remember both are not synonymous. The reason why I'm saying this is sometimes your uric acid levels may be absolutely fine, but you may be having gout. You may be having gouty arthritis. So whatever said and done, we need to correct 3 underlying conditions, which we can correct to some extent. First and foremost is 1/3 of it only comes from diet. 2/3 of the purine is an endogenous production, similar to like when we talk of cholesterol. We know that the purines are metabolized in the liver and then they are excreted in the form of uric acid via the kidneys. And when they are excreted via the kidneys, they are in the soluble form. Now, what really happens is we need to worry about what is idiopathic. We can't do much about it. But there are certain things which we need to worry about. That is the intake. As you very rightly said, that the whole world has been talking about protein restriction, and Neeti ma'am very clearly said that our requirement is about 0.8 grams. Now, with 0.8 grams, what are the foods which we need to restrict? And as I mentioned to you, it's the organ meats, which are purine rich. Apart from that, the glandular meats and certain other plant sources like the legumes and the whole grains and the beans, as well as the spinach and the asparagus. But the interesting thing to note here is that the vegetarian sources of protein, with enough evidence to tell us that they do not actually increase the uric acid production. So we don't really need to worry about that. And second thing is, you beautifully, elucidated the fact that a lot of obese patients are found to have hyperuricemia. The reason being
Hyperuricemia is a marker of insulin resistance. It's a marker of endothelial dysfunction. And we know that all patients suffering with the 5 metabolic variables in metabolic syndrome also suffer with decreased excretion of uric acid. So we indirectly help the patient lose weight, cut down on saturated fat, go on complex carbs, bring down on low GI, step up on low GI and low GL foods. In other words, the bottom line is weight loss. If you induce weight loss, you will see that the uric acid is improving. But another important thing, when it comes to foods like beer is also a source of purine. And obviously, you need to cut down on alcohol consumption as much as possible because that also decreases the uric acid production. So that's about my take on this.
Yes.
Kavita, can
Very
answer?
useful
Kavita?
information. Yes, sir.
Kavita, see, when you talk of production of the metabolism of protein, there are 2 kinds of protein metabolism. One which is routine protein, which goes into urea cycle, and the other which comes from purine and pyrimidine, which comes from the RNA and DNA, and that is converted to uric acid. And the reason being that the uric acid level below 6.8 is protective. It protects against Parkinson's disease, it protects against cardiovascular disease, it protects against aging. So that's the reason why the good proteins, purine and pyrimidine, is converted to uric acid. Now, when you give large amount of fructose, what happens is the fructose is primarily metabolized only in the liver. And no other organ can metabolize the fructose. And when fructose is broken down to 1,6-glucose phosphate, that uses ATP. And that breakdown of ATP is one which contributes to uric acid. And that's why we say we allow fruit juices, don't allow fruit juices, or don't allow fructose, as the speaker mentioned about corn syrup, which is a very high concentration of fructose. In the alcohol, what happens is that the excretion of the uric acid in the kidney is blocked. And that's why the uric acid rises up suddenly. And that's why you must avoid alcohol, especially beer, because it prevents the excretion of uric acid by the kidney. The uricase enzyme is present in lower animals, which can excrete the excess amount of uric acid. Unfortunately, the human beings don't have this. That's why the gout disease doesn't exist in lower animals. It's only in the human body or human beings where you have the disease of gout. That's why nature is very wise to take away the proteins by 2 different mechanisms. And all the vegetable protein that we have gets the urea cycle. So therefore does not contribute to uric acid. As you rightly mentioned, the animal protein, which has a high source of purine and pyrimidine, that is the one which gives you high uric acid. Thank you.
Very
Thanks
useful.
for the wonderful explanation.
Thank you, Mata. Meenakshi, I think you've thrown some light on how to manage patients with hyperuricemia. But are there any conditions which also reduce this? Can you throw some light on that, please?
See, basically, when it comes to hypertension, hypothyroidism, hyperparathyroidism, obviously also metabolic syndrome, as I mentioned to you, and certain drugs also, like those who are on, who had a transplant and who are on immunosuppressants like cyclosporin, or those patients who are on, certain drugs like levodopa, or anti-tuberculosis drugs like pyridosonamide, ethanbutamol. Also certain diuretics also decrease the excretion of uric acid. So beware when you are on a polypharmacy to look up, that also could be the cause. And if it could be alternated with another, equally matching drug, which can take care of your, decreased excretion of uric acid. And another important thing which I want to make a note of here is those patients who are on ketogenic diet, they induce dehydration, only then you can move into ketosis and things like that. So ketosis itself, whether it is diabetic ketoacidosis or lactic acidosis associated with alcoholism, and probably add on metformin in combination with alcoholism, all these also could be a major risk factor for hyperuricemia. Obviously, it's idiopathic also, and if you have renal failure also, you're going to have under excretion.
Yes, absolutely true, Meenakshi. So that was wonderful. And now moving to another important growing problem, I think that's fatty liver, which is an important issue which we need to focus on now, especially in India. So the diet in fatty liver again is a very challenging aspect. So I would just like to know whether it is all about carbohydrate restriction or about the fat restriction. So how would you advise basically a young 20-year-old girl who has grade 1 fatty liver and of course PCOS? So how would you go about, Priyangi? Could you throw some light on that?
Yes, sure. Thank you, ma'am, for your question. First of all, I would like to thank the entire Wodcon team, especially Dr. Benny Negalur, ma'am, for making me a part of this prestigious program. Now, coming to your question, it's a really interesting one. Yes, we do see a lot of fatty liver cases rising, and as we have been discussing already, that it is insulin resistance which is at the root of everything, because someone with PCOS would have insulin resistance as one of the central features, and which is responsible for the all the metabolic abnormalities that is there, including fatty liver, which is one of the manifestations. So here, when we are talking about the diet in fatty liver, I think it would be more reasonable to say that it is, rather than looking individually at fat or individually at carbohydrate, it would be more reasonable to say it's more about total calorie restriction and the diet quality. I'm coming to the details of that. Because as we were discussing that the main goal here would be to control or improve the insulin resistance state that is there. So for that, the basic thing that is required is weight loss. So weight loss, we are not looking at a very rapid weight loss, but a gradual weight loss around 10% of the present body weight over a period of 6 months, which can be achieved through a regular physical activity, regular and consistent physical activity, and calorie restriction. Now, when we look at the diets, this is a young 20-year-old girl. So when we look at the diets of these youngsters today, especially young women, we find that it's not the total amount of food, it's not that much. So it's more of the diet quality that is poor, because they are skipping meals, they are not taking proper balanced meals. There is heavy dependence on junk food. There is heavy dependence on highly processed and refined products, which and simple sugars, of course, which contain the typical what would I say, culprits that are associated with the condition. So cutting down these foods straight away would lead to a calorie restriction. So that is number one. And coming to your question, whether it is about fat restriction or carbohydrate restriction, there are studies which have looked individually at fat restriction, fat restricted diet, and as well as there are studies which have looked at carbohydrate restriction. But we still do not know what is the exact level of restriction that would be the best therapeutic approach to correct fatty liver. So in absence of such a data, such knowledge, we should focus on the total calories and the quality of the individual carbohydrate or fat that we are looking at. Because if we are restricting the carbohydrates just like that to a very severe extent, then we are missing out on the complex carbohydrates which are associated with, which comes with fiber and the antioxidant micronutrients that are there. So, and in case of fat also, if you are severely restricting fat, then we are missing out on the monounsaturated and the polyunsaturated fatty acids, especially the PUFA. So the quality of both these macronutrients should be looked at, because excess of any of these could be bad, because one is the exogenous source, and the other gives the raw material for the endogenous triglyceride synthesized in the liver. So so we should look at the individual. The diet history is very important, so that we can arrive at a nutritional diagnosis to determine that which particular component of the diet is higher, whether it is fat or whether it is carbohydrate, and accordingly reduce whichever nutrient is higher. And already Neeti ma'am has very beautifully summarized the various the aspects of the diet. It would be similar here as well. We need to include whole grain sources of various. We need to look at whole grain unprocessed cereals. We need to include a lot of vegetables, at least 1 to 2 servings of fruits, which would ensure carbohydrate intake of the desired profile, and the correct amount. And of course, we do not know the appropriate amount of fats, but we wouldn't go too high on fats. We would concentrate on reduction of saturated fat, the sources of saturated fats, things like full cream dairy products, then processed meats, red meats. Of course, red meat consumption is not that great a problem in our country, but these days, of course, the consumptions are rising. And again, baked products, bakery products, cakes, biscuits, these are also significant sources of unhealthy saturated fats and trans fats also. So these are the things that need to be restricted in the diet. And one more thing is that when we are planning a diet for a young girl, they might not have the inclination or the time for a very elaborate sit-down meal with a lot of items. So suggesting options like sandwiches or wraps made with healthy alternatives like whole grain sources, including vegetables, and some amount of protein, as mentioned by my previous panelists as well, that the protein intake is not enough in most of the cases. So including protein in all the meals is very important, because that also improves in insulin sensitivity. So 15 to 20% of protein in the of the total calories is required. So another very practical approach that I find helpful in my patients is in teaching them the diabetic plate method. So that 1/4 of whole grains, 1/4 of proteins, and half of vegetables, that proves very helpful, where they can create their own meal options, which would be balanced, healthy, and of course the proportions would also be right. So it's to conclude the whole thing. I would say it's more about total calorie restriction, because when we are restricting the total amount of calories, we are automatically bringing down the individual the absolute carbohydrate content as well as absolute fat content of the diet. The qualities of both these nutrients should be emphasized on, and of course an adequate amount of protein should be there.
Thank you, Priyangi, for that elaborate advice for your patient. And thank you, dear panelists, for that wonderful and very important take-home messages, so many, so that we'll be able to incorporate in our daily practice and help our patients to live a healthier tomorrow. So, and thank you all so much. Thank you, Dr. Benny Neglur ma'am, and all the beautiful girls and the strong men for joining hands in unraveling the Pandora's box of Wodcon 2022. Thank you so much for the opportunity, ma'am.
Thank you so much. Firstly, I want to thank Dr. Kavita for handling the session, in spite of me not being able to connect so well since I'm traveling. Thank you, Dr. Kavita. And I hope this dessert has completed the meal that we've been having for the last 2 days. And we can't thank more to Dr. Neglur, ma'am and sir. Thank you so much for having us year after year in the Wodcon, and looking forward to see everyone in the next Wodcon 2022. Excellent session throughout the days. Thank you so much, everyone.
Thank you so much, Kavita and Ruby, and thank you all the panelists, Meenakshi, Neeti, Priyagi, Cheryl, and also Neglur sir, because he also gave in a lot of information. So thank you so much. Did I miss anybody? Nazneen, of course, Nazneen. Thank you so much, all of you, for being here. And like all good things come to an end, I think we are coming to end of a beautiful 2 days event, which all of us enjoyed working with Dr. Benny ma'am and planning it. And I hope you all enjoyed being a part of it. Over to you, Benny ma'am. Thank you so much.
Ma'am, you're on mute.
Thank you so much for all the ladies in yellow. And the dessert session was the icing on the cake. But you know, whenever I'm in the midst of nutritionists, I wonder whether, am I eating right? Am I eating enough? And today Shilpa put a plate for us in our group. And I said, oh gosh, I'm eating double that quantity. And then we heard a lecture on metabolic flexibility by Dr. Krishna. And he said that you have to eat by sunset. And it seems that all of us are doing wrong. So we need to correct. And thank you so much for all your inputs. So we are now come to the close of our conference. So I'm having mixed feelings. I want this to go on and on and on, because I must tell you the deliberations yesterday and today were of a very superior quality. We've had real stalwarts giving update and especially unraveling the Pandora's box so well that I'm sure it's going to make a change in the practice of all healthcare practitioners. And the second is that all good things must come to an end. But I'm going to miss my core team meetings, the core team talks. I'm going to miss all of you, Shilpa, Purvi, Shefali, Ami, and of course, all my other friends who have taken part in the making of this conference. And, you know, people and delegates and friends are telling me, oh God, you've got such a wonderful team. So it is really good to hear that, because my entire team, and of course, Dr. Neglur, how can I forget him? He's the backbone. So all of us, all of here and the entire core team has made this Wodcon happen. And I'm so, so grateful to all of you. But most importantly, all the delegates who attended, and I don't have an idea of how many logged in. I must thank all of you, audience and delegates, for having come for our Wodcon conference. I'm sure you have taken back a lot of carry-on messages, and we know that we cannot have a conference without an audience. Especially, I want to name some of you. Of course, Shilpa, Purvi, Shefali, Ami, Dr. Neglur, and I hope I've not missed anybody, my core team for this help. I need to thank my scientific advisors, Dr. Neeta Deshpande, Dr. Bansi Sabu, Dr. Sunil Gupta, Dr. Manoj Chawla, and Dr. Rajiv Kovil, and my special mentors, Professor Chandalia, Dr. Sarita Bajaj, Dr. Usha Sriram, Dr. Vijay Panikar, and Dr. Shashank Joshi. And I think collectively we have made a difference. I also thank the RX events. I think it was a flawless conference. Nothing, no glitches from their part. The glitch was only with the, I think, speaker 1 or 2. But RX did a wonderful job. Thank you so much, Hardik, Neelam, Kushal, and some of you whom I have missed. So we close this con, but I want to hear some comments from you. Thanks a lot. Thank you so much, everyone. I think my namaste will, and you know that WhatsApp will tell it all. So would you like to say something, Dr. Neglur?
Yeah, I think it's a big thank you for all of you and the faculty and of course the industry for supporting us wholeheartedly to make this conference a great success. And I say coming together for a conference was the start of it. Working for the conference is a part of it. And enjoying the success of the conference is the heart of it. So we have really done a great job for making this conference a great success. And I appreciate each one of you for having contributed immensely day in, day out. I remember how much you all worked hard for this to make this conference a great event. And I appreciate your hard work. And I sincerely thank, and we continue this association for years to come. You remember I began with Rigveda, and now I would like to end with Bhagavad Gita. And what Bhagavad Gita says, Nahi jnaninam sadrusham, pavitram iha vidyate, Swayameva yogasam samsiddham kalena atmen nindati. What it means nothing is more sacred than knowledge and wisdom. And every one of us tries to learn the same to attain the title of Sarvajna. Sarvajna means who knows everything about the medicine. That, of course, is impossible to get, but all of us strive for that. And all of us have achieved from this conference. And we learned a lot from each one of you. And we could carry a lot of messages home, which will last for 1 year until we meet again next year. With these words, I thank you once again and say goodbye to you all. See you again.
I also invite, I think, each one of my core team to say something, and of course, and the others as well, whoever wants to speak. So Shilpa, Ami, do you want to, Purvi, Shefali, do you want to say something? Something short and sweet.
You're on mute.
Yeah.
You're on mute.
Thank you so much, ma'am, for having us on your team. And always a team is as good as its leader. So, you know, we learned so much from your leadership and sir's leadership. So the main thing is delegating work. I think that's so important. Being cool and elegant, that's also very important. So thank you so much. And it was a really great learning experience also from Shefali, Purvi and Ami. So thank you so much for having us here. Thank you very much. And we meet again next year.
Sure, ma'am.
Surely.
I echo ma'am's words. I have absolutely learned so much of hard work which goes into making a conference this huge, this successful, and hats off to your vision and sir's vision, and right from choosing the topics to appropriately, allotting the speakers that particular topic, and it was a wonderful learning experience. And to all the speakers, to all the faculty, they've done a marvelous job. RX Events has done a marvelous job, and I cannot thank you enough for allowing me to be a part of this team. It was wonderful.
Ma'am, as you said, it's a mixed emotion because we've been together for so many days now, interacting, so much learning. First of all, thank you very much for making me a part of the core team. It was wonderful working under your leadership, so much to learn, so much to know. And with my other co-members, Shilpa ma'am, Purvi, Shefali, they have been such a wonderful team, always helping out whenever needed. That's what is required as a team. And thank you everyone as faculty, speakers, RX team for having, and a big thank you to ma'am and sir for making us a part of your family and taking us on board for this conference. Looking forward to more again with you, ma'am. Thank you so much.
So, ma'am, I'm going to take off from where Ami left. This is extended family. And over the years, I think we all have chimed really well. We've understood each other's working style and, thought process. But huge thanks and gratitude to sir and you for making me a part of this and, giving us this wonderful opportunity to closely observe, closely work with you. It's been extremely overwhelming to see the kind of, handling faculties, national and international repute, their travel plans, the last minute changes. I think it will be... It's a small thing if I say we learned a lot, because we have evolved as professionals and personally also by spending that kind of time with you. So I'm really indebted to you for that. And yes, it has been a great experience with Shilpa, with Shefali and Ami to, again, learn some more and work in unison as a team. Big thank you to RX Events and to Arindam and team also for those beautiful creative invites. I think this has seriously been a great blend of science, art, creativity, and great sense of familiarity because passion because everyone who came here, we've been glued to our chairs for 2 days, and every single faculty had the same thing to speak about yourself and sir, which is not an easy feat or easy thing to achieve, ma'am. So really salute and hats off, and I'm definitely that we are not going anywhere. I think we have to continue this. We have to do many more things together so that, you know, Wodcon and its intentions are well achieved. Thank you.
Thank you. Thank you very much.
And I would also like to just add, so thank you so much for believing in all of us, and in fact bringing all the nutritionists together on this very prestigious platform. It's a wonderful feeling, and you have always been a role model, you know, a woman of substance for all of us, and we always look at you as an inspiring woman and learning so much. Of course, with Dr. Neglur sir always at your side, and so much to learn from you, sir. I've always been wanting to be a good student of yours. Thank you so much. Thank you.
Thank you. Good you said that Dr. Neglur with you and not behind you or something. Because that's what they say for men. Behind every successful man, there is a woman. They never say the woman is with the man always. So, Kavita, I liked your statement. Thank you so much. And in the end, I want to thank the sponsors after this academic feast, because I won't name each one of them, but they will come to meet me and I will individually thank them, because without that, we cannot make a conference, however much we want to do it. It is the team effort of everyone, and I missed out on Arindam. You can also convey that, and I'll write to him as well. So all of us together, next year, Wodcon should move ahead and do better. Thank you very much.
Yes. Yeah. Thank you, and have a good night. We'll see you again. See you again.
Thank you, ma'am.
Thank you. Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
Thank you,
everybody.
Thank you. Thank you.
I'll do this to my grandchild.
Yes. Shefali, that flying kisses for whom? For Benny madam or for me?
No, for you only, sir. For you, only for you.
Thank you.
Oh God.
Thank you. Thank you very much.
Thank
so long it's flying, it's okay. So long it's flying, it's okay.
Ma'am, we'll give it to you, sir, later.
Okay.
Okay.
Bye, ma'am. Bye, Shilpa, ma'am. Bye, Purusha.
Bye.
Bye.
I think the last part, I think we should ask Hardik to cut off that last part.
Yeah.
Yeah, Hardik, are you listening to me? Or,
yes,
please cut off that last part, otherwise